Is next.
Mr. Secretary, for years, communities across the country have struggled to fill major provider workforce gaps, a growing crisis exacerbated by the pandemic. Based on my legislation, Congress authorized the creation of 1,000 new Medicare-funded graduate medical education slots in the Consolidated Appropriations Act of 2021 and outlined specific criteria for distributing these slots. However, CMS has repeatedly included additional criteria not specified in the law, which unfairly disadvantages many states, including New Jersey. Since enactment, there have been 2 rounds of distribution for these slots, meaning we are 40% of the way through the program, and New Jersey continues to be completely shut out. It's been years, and we still don't have an answer as to how we get positions to teaching hospitals in my state. The law clearly specifies that the Secretary shall, not may, shall distribute residency positions to each of 4 specified categories of providers. So what can you commit to doing to help ensure that states are no longer unfairly shut out of the program in contravention to the way the law is written?
Senator, appreciate the question because I know that this has been one you've worked on for quite some time, and our team has been trying to be responsive to your staff as well. As you know, New Jersey, like California, the circumstances sometimes make it difficult for some regions to be able to qualify for some of the resources, and in this case, GME slots. We're more than willing to work with your team, but the resolution is not so simple because as you try to resolve the issues that affect states like New Jersey or California, you create other issues for other states.
Well, let me interrupt you because it's not so difficult. The law is clear. It is CMS, the kingdom of CMS, that has decided to add additional criteria that Congress did not stipulate. I'm sure when you were a member of the House and the Ways and Means Committee, you really appreciated when federal agencies changed the law that you helped pass and enacted it in a way that was not your intention. That's exactly what's happening here. Exactly what's happening here. And I think you have the power to fulfill the law as it says the Secretary shall distribute residency provisions in accordance with the law. This is not happening in accordance with the law. And so this suggestion that the department is trying to be cooperative and helpful, it falls far short on me. I hope we can find a better way forward. Last month, your agency's Inspector General issued a concerning report finding that over a few-month period, 16% of unaccompanied migrant children files lacked any kind of sponsor background checks. It also found that in nearly 20% of cases where unaccompanied minors were released to sponsors pending a background check, there was no documentation confirming those checks were ever completed. Given the alarming pipeline of unaccompanied migrant children being released into situations where they are ruthlessly exploited for their labor, this is a glaring blind spot that needs to be addressed. Extrapolating from the report, we're talking about potentially thousands of migrant children who are sent to unvetted sponsors. As the report concludes, the failure to complete background checks increased children's risk of being released to unsafe sponsors. What specific actions have your agency taken in response to the finding of the Inspector General's report? And how is your agency working to ensure that expeditiously finding sponsors for unaccompanied migrant children does not come at the cost of their safety and well-being?
Senator, I can assure you that most of the recommendations that were made by the Inspector General for incidents, you're referring to incidents that occurred back in spring of 2021, a 2 or 3 month period. I can assure you that what was being observed by the Inspector General back then is not the case today. If you recall, at that point, we had an infrastructure that had been virtually dismantled. We had to stand it up. And at that point, we were dealing with an influx of children.
So today we would find none of this, is what you're telling me.
You would find that we are now doing all the background checks. We're doing thorough assessment of anyone who's seeking to become a vetted sponsor.
I look forward to seeing that as a reality. Finally, a recent Supreme Court decision has upended vital protections of ESRD patients, protections that Congress passed 40 years ago through the Medicare Secondary Payer Act. I'm proud to partner with Senator Cassidy on a bill to amend that act and protect patients living with ESRD from discrimination by private health insurance plans. But unfortunately, we're not able to get your agency to work with us to fix this problem. Will you commit to CMS working with my staff and Senator Cassidy's staff to have the appropriate information we need to address this problem?
I absolutely commit to make sure that our staff is working with your and Senator Cassidy's staff, and I know that we've been engaged with some of the folks on this particular issue.
Thank you, Mr. Chairman.
Senator Cornyn. My colleague next is Senator Casey.
Mr. Chairman, thanks. Mr. Secretary, good to have you back here, and thanks for your service to the country at a difficult time. And I want to start with the issue of prescription drugs, and grateful for your work and the work of the administration on efforts to lower the cost of prescription drugs. We all know that prescription drug costs in our country are significantly higher than so many of our competitor nations. I voted for the Inflation Reduction Act, which had a provision to allow Medicare for the first time to negotiate for lower prices. It also had that $35 a month cap on insulin for Medicare Part D beneficiaries. I'm just holding up here just an enlarged version of a piece of paper I put out a couple months ago now to summarize the benefits of the Inflation Reduction Act prescription drug provisions just in Pennsylvania. Just to give you an example, there's a lot you can't see from where you're sitting, but just the capping of insulin at $35 a month, 80,200 Pennsylvanians will benefit from that. And then another one just for highlight, we know that less than a year from now, the $2,000 out-of-pocket cost cap will go into effect. That will impact nearly 829,000 Pennsylvanians. So big numbers just in one state. I wanted to ask you to give us a state of play. What's already in effect and how it's working, and then what has the administration proposed in the budget to further expand policies and measures that will continue to ratchet down the cost of prescription drugs?
And Senator, we may well ask you for a copy of that document that you just put up, because we can always use anything that helps convey information to consumers. $35 a month, insulin, life-saving in many cases for many people, but for folks on fixed income, you know how important that is for seniors who have to depend on their Social Security check to pay for things. The fact that today a pharmaceutical company that tries to raise the price of its drugs beyond the rate of inflation, we now get to yank back the extra that they're charging beyond the rate of inflation. That's a big one. Today, we're in the midst of negotiating for the 10 costliest drugs in the Medicare program, which in 2022 cost Americans, just in Medicare, 65 million people on Medicare, $46 billion. We're going to finish the negotiation by August. We'll be announcing what the price will be come September. That's already in effect. Those prices would then come into play beginning of 2026. Next year, we'll get to negotiate another 15 drugs. And as you heard, President Biden would like us to negotiate not just another 15, but another 50, because we're going to be saving a ton of money. The Congressional Budget Office has said we're probably going to save at least $100 billion in just negotiating for better prices in those first 10 drugs. On top of that, you're aware, and this is very important for a lot of seniors in Pennsylvania throughout the country, the cap on how much they'll have to spend out of their own pocket. It's already begun this year, cap of about $3,500 for catastrophic costs. But by next year, when people are paying for these drugs, if they're on cancer or have kidney failure, tens of thousands of dollars today they pay out of pocket because their cap is really high. Next year, the cap will be $2,000 overall. Game changer for so many Americans.
And that $2,000 cap goes into effect January 1, correct?
Yes, next year.
And then can you just briefly walk through proposals for some of them you mentioned, but this budget? You said the president proposed 50 more prescription drugs to be negotiated.
We know what works.
Yeah.
If CBO, the Congressional Budget Office, is telling us for just these 10 drugs, we'll save $100 billion to taxpayers, why do we limit it to 10?
Yep.
You all were good enough to help make sure that next year it's 15 we negotiate. But the president's saying, why stop a good thing? Let's negotiate more of these, because we know in America we're paying 2 or 3 times the cost for these drugs than other people around the world.
Well, I appreciate that. And the second issue that I wanted to note is how grateful I was that the president's budget includes a provision to allow states to provide continuous Medicaid eligibility for children under the age of 6. This continuous eligibility will reduce gaps in coverage that interrupt access to essential care services for kids, such as preventive care. Ensuring kids have access to high-quality, affordable health care is, of course, one of our #1 priorities. And I introduced legislation, the Medicaid for Every Child Act, which would automatically enroll all children through the age of 18 in Medicaid, I should say. How is HHS working to expand access to health care for children? Just, I know I don't have much time, but just a brief summary.
Well, you've mentioned a very important aspect to it that the President has in his budget. We are also trying to make sure that we provide care from the very moment of birth, in fact, beyond, because we're focusing on maternal health, because too many women in America, believe it or not, in the richest country in the world, are dying or their babies are dying within the time of birth or within the first year. And so today we offer a woman who's on Medicaid not just 60 days of postpartum care, but 365 days. And fortunately, so far, 45 of the 50 states have adopted that. And so that's going to help kids moving forward to start off on the right track. There are any number of things we could mention, Senator, but I know your time is short.
Thanks so much. Appreciate it.
Thank you.
In August, your department recommended the reclassification of marijuana from to a Schedule III for the Drug Enforcement Administration. Previous administrations had used a 5-factor test to determine what the scheduling of a drug should be, but this administration, your office, has created a new 2-factor test to determine currently accepted medical use. What's the reason for the change?
Senator, thank you for the question. And as you'll see from the report that has now been made public, there has been a lot of science that's been collected over the years on cannabis. We have far more information now. As you know, throughout the country, many states have moved much farther than the federal government has, even in places like Texas, you see where action has been taken on cannabis. What we're doing is simply reflecting what the science is showing.
You compared it to heroin in terms of its potential for abuse. Why didn't you compare other types of drugs that are scheduled by your office?
I'm going to try not to speak directly for the FDA because the FDA did this assessment analysis independently from HHS. They are the agency that has been tasked with that job with their scientists, and I won't try to speak for them, but what I will tell you is that the rigorous work that was done to come to these conclusions was based on the science and the evidence they had before them.
Did they do additional research into adolescent brain development or mental health consequences or impact on pregnant women?
I'm sure they took into consideration all the information out there on both the effects and the evidence that there is on cannabis use.
You're saying that for a fact?
Senator, as I'm saying, I don't want to try to speak for the FDA and its scientists because I didn't do the actual assessment, but I can almost say—
you announced a recommendation. I assume you would take into account impact on adolescent brain development, on mental health consequences, or pregnant women.
As I said, I'm sure that FDA would have taken into account all of the different circumstances involved. I didn't make the recommendation. It was made by FDA.
I want to follow up on some of the questions that Senator Menendez and Senator Grassley asked. Your department is responsible for the administration of the Office of Refugee Resettlement, correct?
That's correct.
And that means that any unaccompanied children who come to our border are basically transferred to your care by the Border Patrol, correct?
That's correct.
And you identify a sponsor for them in the interior of the United States, correct?
That's our obligation, yes.
Yes. And there have been about 400,000 of these unaccompanied children that have come to the United States during President Biden's term of office. Can you tell us where they are now?
We can give you information on the vetting process and
No, I ask you, do you know where they are now?
As I said to you, we can tell you who the vetted sponsors were that received these kids.
That's not what I asked you. I know that you've interviewed sponsors to some extent, although not adequately. I agree with Senator Menendez. But do you have any responsibility for their welfare as you sit here today?
While they are in our custody, we have jurisdiction to provide them with the care that they need.
I'm talking about now that they're in custody of your vetted sponsors.
Senator, you and your colleagues did not give us jurisdiction to provide the oversight of these children once they left our care.
So that's not your responsibility, is what you're saying?
We don't have jurisdiction. We can't spend money on things we don't have jurisdiction.
So you don't know whether they're being trafficked for sex, whether they're being forced into dangerous jobs of child labor. You don't know whether they're going to school. You don't know whether they're getting the health care they need. You simply don't know, correct?
Well, while they are in our care, we know all those things, and they don't have
Well,
it.
they are no longer in your care once you transfer them to the sponsors, right?
As I said, Senator, the statutes that you all passed don't give us the authority to monitor these kids once they are out of our custody.
So whose responsibility is it to look after the welfare of these children?
My understanding is the statutes that you all passed left that open for the communities where they enter.
Say that again?
My understanding is the statutes that you all enacted that said that our jurisdiction over these kids ends once we have delivered them to a vetted sponsor, is that the communities where they reside will now be in charge of providing for their services.
So as a result of the broken border policies of the Biden administration, these kids have been placed with sponsors. You don't know where they are. You don't know what's happening to them. You don't think that's your responsibility, and you frankly don't care.
No, that's not accurate. And these laws preceded President Biden taking office. This system has been broken, as you know and I know, for more than 40 years, or close to 40 years. You and I have been in Congress for quite some time. I started in Congress back in '93.
Well, you have a job to do right now. You have about a $1.8 trillion budget, and you have the responsibility for taking care of these children, and you simply hand them off to sponsors, to homes that you don't know the conditions they're living in. You don't know that they're going to school, whether they're being sold for sex or trafficked or forced into labor. You don't know, and you don't think it's your responsibility, correct?
No, I would dispute pretty much what you just said, Senator.
The time of the gentleman's expired. Senator Barrasso.
Thanks, Mr. Chairman. Mr. Secretary, thanks for being here. Good to see you again. I want to turn to the crisis at the southern border and how it's overwhelming our healthcare system here in the United States. What we've seen on the news, reported and written and on video and television, hospitals in sanctuary cities right now, New York City, Denver, San Diego, Chicago, Boston, tell us that they're at risk of collapsing financially due to the overwhelming number of illegal migrants flooding their emergency rooms and the clinics who are essentially getting free care, having the American people pay for their care. Clinic in Chicago reported seeing nearly 16,000 migrants last year, illegal immigrants. The cost of their care totals over $30 million. This is what the hospital is reporting, paid for by American taxpayers. Denver Health was in the headlines in 2023, reported over 20,000 hospital visits from migrants. The hospital is now, not surprisingly, in financial distress. These hospitals are now asking the federal government to bail them out. And it's completely Democrat-caused failure to enforce the law at the southern border. Can you please explain why it is the responsibility of hardworking American taxpayers to foot the bill for all of this care for people, 9 million now, from all across the world who have flooded their way into the United States?
Senator, I appreciate the question. What I can tell you is that we have extended the resources and authorities that we have at HHS to try to be there to help any healthcare facility when there is a way that we can go in to be supportive. I don't know of a particular case that you might want to mention, but I know that we are prepared to be supportive of any facility where the authorities that you have given us allow us to go in and support.
Well, in terms of it's not hard to find stories about hospitals in one sanctuary city after another saying we are overwhelmed with the number of people that we're treating and have no way to recover the costs other than to turn to the American taxpayers. The federal government doesn't pay for the health care of every legal U.S. citizen. It seems like it's in the position now of having to do it for all these illegal immigrants. Why should the American citizens be forced to pay for illegal migrants to receive this same care for free? Because that's what's happening.
Senator, as I said, I don't know how particular states operate their healthcare systems with regard to the folks that are coming in, but what I can tell you is that when we are approached, whether it's through the Medicare program, the Medicaid program, or simply those who are seeking out other types of authorities and funds that could help them, we're ready to try to be responsive.
You are aware that when a hospital is inundated with people who are not paying, they have to shift the cost to the people that are paying, and that's what's happening right now all across the country, and specifically at so many of the sanctuary cities. I want to talk to you a little bit about something that Senator Langford and Crapo asked about as well, and that's the nursing home staffing ratio requirements. Specifically, your department is proposing a rule on nursing home staffing ratios requiring a registered nurse to be present 24 hours a day. Currently, it's required 8 hours. CNA hours per patient per day increasing, and the hardship exemption for rural communities who can't find people to hire, even though they try very hard. It's requiring much more paperwork. Most of the Wyoming nursing homes that I talk to, they would have to actually hire additional staff, not in addition to taking care of the patients, but to just fill out the paperwork that your department is requiring. Look, we had concerns. We expressed them to the Director of Medicare and Medicaid, Brooks LaSure. She shared that the Centers for Medicare and Medicaid have committed $75 million to support nursing staff in nursing homes. How do you plan for these funds to reach these rural communities that are really getting hammered by these additional rules? And only about four out of 5 nursing homes say, we can't comply with what the administration is now forcing upon them all across the country.
Senator, you packed a lot into that question. Let me respond first to the issue of the funding, how we can make sure it gets into rural communities. One of the things that we have done is make sure that we try to get those dollars into the communities that need it most to be able to staff up. But I must tell you, if you're going to call yourself a nursing home, you should have a nurse that's present to provide care to the families that are leaving their loved ones there. It is embarrassing that while not 1 of every 5 Americans lives in a nursing home, nowhere near 60 million people live in a nursing home, 1 of 5 people who died from COVID died in a nursing home. We need to make sure that the standards that these homes have for the people that we love and leave in their custody will be the right care, and it will be with professional standards. And all we're seeking is to make sure that all nursing homes, many of them already do this, but all nursing homes meet the standards that you or I would expect if we're going to leave our loved one there.
Well then, Mr. Chairman, let me just say, and my time has expired, so I won't go to an additional. Only 1 in 5 nursing homes can meet the proposed requirements. Even those trying to hire people can't find people to fulfill it. So 4 out of 5 nursing homes are going to be out of compliance with administration rules. And apparently what you're saying is that all of the nursing homes, these other nursing homes, are right now incompetent to provide care, and I think they're still providing pretty good care today. Thank you, Mr. Chairman.
Time of the gentleman expired. I thank my colleague. Next is Senator Grassley.
I'm going to bring up a problem with your department, very same problem I'm recently having with the environmental EPA. So it isn't just your department that this might be a problem. But last month, I wrote oversight letters to 15 HHS contractors and grantees. Those 15 organizations received some of the largest contract awards for the care and placement of unaccompanied children. My oversight work is based on new information that shows many children may have been placed in a very dangerous situation. I want to know what these contractors are doing to ensure children's safety. In response to my 15 letters, your department sent an email to contractors and grantees on February 28th that I want to quote. Kindly direct Senator Grassley's office to HHS's Office of Assistant Secretary for Legislation for this request, end of quote. My staff have been told by contractors that they're ready to respond to me, but HHS instruction has so far caused them not to. Do you accept the premise that recipients of congressionally appropriated taxpayers' money must respond directly to congressional oversight requests? And I hope you can answer that positively, that they should. If not, when will, if you would agree with me, when would you direct your staff to clarify to recipients on my letter that they must respond to Congress? Now, we had EPA saying these letters I sent to other groups spending taxpayers' money that they could respond directly to me. So can you say that for your department?
And Senator, as a former member, I too wanted to be able to conduct oversight when I was in the House of Representatives. And so absolutely, these contractors, the various entities, Americans have every opportunity and right to respond directly to you. We offer to provide them with some guidance if they wish to have it. They were under no obligation to get it, but you are absolutely within your rights, and they are as well, to be in communication.
Okay. So as a follow-up, just let me be very clear. These folks that I wrote to have received together billions of dollars of taxpayers' money. When I and my colleagues send them requests for information, they have an obligation to respond, and this administration's interference, which evidently we're not going to have anymore, at least for a while, has been obstructive. Then another question, if HHS receives a law enforcement request for information relevant to a child's trafficking investigation, does the HHS provide that information to law enforcement without requiring a subpoena?
Mr. Chairman, we work on an ongoing basis with law enforcement throughout the country because, again, we have custody, temporary custody for minors. And so we continue to work with law enforcement throughout the country. Yeah. We follow the rules. In some cases, we're dealing with very private, sensitive, confidential information. And so we make sure we follow the rules so we don't violate any individual's privacy at the same time that we're fulfilling our obligations to respond to law enforcement.
Are you saying in some cases you can direct directly to law enforcement without a subpoena, and then are you saying in other cases you might need a subpoena?
We try to make sure that we're complying with the law when it comes to providing information. Some information is more confidential than other pieces of information, so we make sure that we're not violating any privacy rights, any protections in providing information, whether it's to law enforcement or any other entity.
This will have to be my last question, and then I'll submit for writing answers. At last year's budget hearing, you and I discussed supporting rural health care, including the need for CMS to fully utilize the Rural Community Hospital Demonstration Program. Right now, CMS is only using 25 of its statutory 30 hospital spots for this program. You told me last year that HHS would, quote unquote, do more to support rural hospitals in need. Following our discussion, I wrote CMS administrator. Then at my request, the CMMI director met with 2 rural hospitals interested in joining the program, but that's where the progress stalled. CMS explained that in order to fill the open spot, it would require 12 months of work and too many hospitals would be interested. If CMS has the tools to help one rural hospital and isn't, you should be doing something about it. I realize you might not know about every program at HHS, but why doesn't your department want to help 5 rural hospitals through this program? It's budget neutral, and Congress has reauthorized it 3 times since 2003.
I know time has expired, Senator. Mr. Chairman, may I respond?
Just briefly.
Briefly, Senator, let's follow up on this, but what I will tell you is if you take a look at the President's budget, and we can get back to you with a number of the projects that we've undertaken in rural America, we are doing a great deal, especially with many facilities that are on the verge of closing, and that would be even worse for many parts of rural America. But let me follow through with you on your particular concerns, because we have quite a bit to talk about when it comes to our work in healthcare for rural America. And this budget, as you will see, makes major investments in rural America.
We're going to have to move on. Senator Menendez, at this point, it's Senator Hassan next, and Senator Cantwell will be chairing, and we'll get everybody in. Okay.
Well, thank you very much, Chair Wyden. I want to thank you and the ranking member for this hearing, and thank you, Mr. Secretary, for being here today. You and I spoke last week about the cyber attack on Change Healthcare, the payment processor for hospitals and doctors all across the country, and the impact that this hack is having in New Hampshire. And I raised the issue with the President on Monday. As you and I discussed, this hack is having a really outsized impact on small and rural hospitals, including 4 critical care access hospitals, critical access hospitals in New Hampshire, which have not received what amounts to 98% of their expected payments for the last 3 weeks. After you and I spoke, at least one of our hospitals received approval for aid from the Medicare program, so thank you very much for your quick attention. While this has been some progress, our providers are facing a really long road ahead. So this morning I met with Andrew Whitty, the CEO of United Health Group, which owns Change Healthcare, and this meeting followed my push this week to urge United to step up and provide more urgent aid to providers. So Mr. Whitty and I had what I would call a constructive conversation this morning. United Health Group has made new commitments to provide cash aid today to the providers in my state who need it without any unfair or risky terms. What will HHS's role be in the coming days to ensure that United Health Group is following up on these commitments?
Senator, first, thank you for the work that you're doing to make sure that not just in New Hampshire, but generally that United Health and other payers step up.
Right.
We, as you probably know, we had a meeting earlier this week with the payers, with United Health Group and providers. And we're now having a follow-up meeting specifically with the payers on Friday. And what we're doing is essentially saying to the payers, many of whom actually have already received their payments from Medicare and Medicaid, they're holding money and providers aren't getting paid. We're saying to them, you need to start making payments. While you may not receive the actual bill, you have a general sense on a monthly basis what these providers bill you. So there's no reason to not work out an advance payment to these hospitals and other doctors and other providers.
Okay, well, I look forward to continuing to work with you and your team in making sure United Healthcare payers generally are doing what they need to do, especially with our critical access hospitals. Really,
look forward to working
important.
with you.
Yep. I want to turn to a different topic now. I was really pleased that the department's proposed budget included $1.6 billion for state opioid response grants. These grants have helped New Hampshire improve its response to the fentanyl crisis. In the past, you and I have discussed the program's impact and the importance of continuity of funding here, so our providers can really plan and really work towards an overall comprehensive prevention, treatment, and recovery strategy. The most recent appropriations language requires HHS to, and this is a quote, avoid a significant cliff, close quote, for any state when allocating funds from year to year. States have to have clarity from the administration regarding how the new funding amounts will be calculated over the next 2 years. Will you commit to having your staff work with mine to ensure that this information is clearly communicated to states as soon as possible?
You absolutely have that commitment.
Thank you. And finally, last week's set of government funding bills contained multiple provisions to support addiction treatment for those on Medicaid. One of these bipartisan measures, which I worked on with Senator Blackburn, permanently requires Medicaid programs to cover all medications used to treat opioid use disorder, a requirement that was set to expire next year. The funding bill also included bipartisan legislation, which I worked on with Senators Thune and Blackburn, to expand access to short-term residential addiction treatment under Medicaid. Mr. Secretary, can you discuss how these provisions, now signed into law, will be supported and expanded upon by the program in the President's budget?
Senator, and first, thank you very much for your commitment to this issue and for being so dogged in pursuing real results for folks. We're going to try to make sure we're partnering with states and local communities to make sure that they're aware that Medicaid can actually now be more helpful. We have to wait to see how they structure their programs because they're the ones that operate them, but we want them to know that Medicaid wants to be in the game.
Okay, thank you very much, and I yield my time, Madam Chair.
Thank you. Senator Young.
Thank you, Chairman. Mr. Becerra, welcome. It's good to see you again. Mr. Secretary, HHS can and must play a critical role in advancing access to innovative medical technologies. I know you agree. But the reality today is that many medical technologies authorized by the FDA face significant barriers in securing Medicare coverage. This prevents patient access to key medical innovations. I'm encouraged by CMS's work last year on releasing the long-awaited proposal, Transitional Coverage for Emerging Technologies, or TSET. This would establish criteria for an expedited coverage pathway to provide Medicare beneficiaries with faster access to innovative and beneficial technologies. We're now waiting on a final TSET notice, which we thought would be finalized by end of last year. I, along with a number of my Senate colleagues, sent a letter to CMS asking for TSET to be finalized as soon as possible so that patients don't have to continue experiencing delays and barriers in accessing innovative and often life-saving medical technologies. Secretary Becerra, given that roughly 7 months has passed since the TSET comment period ended, can you assure us that CMS will issue the final TSET policy yet this spring or early summer?
Senator, thank you for the question and for the work you've done on this particular issue. And by the way, I hope that we continue to work this because we're talking about the new frontier when it comes to medicine. And so we're trying to make sure we do it the right way. Obviously, there are many eyes that are placed on these new proposals. What I can commit to you is to make sure that we get this out as quickly as we can. We got to get it right because we want to make sure people have access to the medicines.
When do you estimate, surely you have an estimate of the time period, right? Would spring be realistic or early summer?
I wish, Senator, honestly, I wish I could say yes, but I want to be honest with you that the process doesn't move always as quickly as one would expect. Again, this is not dealing with something a movie, this is not a movie we've seen over and over again. This is new stuff. We got to get it right.
What is, for those who are watching, care a lot about this issue, which is many of my constituents, what is the holdup, so to speak? Why is this taking longer than maybe they had expected? Because business people and innovators require certainty. And what are you doing to try and manage some of those dynamics?
First, we have to make sure that whatever we propose fits within the statutory prescriptions you gave us. So we can't go outside of it, and we don't want to be so narrow that it doesn't do everything you're asking us to do. And that takes a lot because sometimes you all give us specificity in the legislation. Sometimes it leaves it somewhat open, and we have to interpret. Secondly, we have to make sure that everything we do at the end of the day will be done in the interest of the patients who will be receiving the medications and therapies. And finally, we have to make sure that whatever we do, we have to be able to look around the corner to make sure that what we're doing isn't impacting something else where we might end up in court and everything gets delayed because we're in court.
Thank you. So stepping back, how does HHS plan to address a broader, at least perceived disconnect between the pace of innovation and outdated pathways? I think that's always a dynamic that we're going to be dealing to some extent, but closing that window will save lives and improve lives immeasurably. So what are your thoughts on that?
Yeah, and remember, as you know, we're working with two different standards that really are at play here. FDA has a standard before a drug can hit the market.
Right.
FDA has to say it's safe and it's effective. Then you have a different standard with Medicare, and CMS has to make a determination, not a safe and effective, but a reasonable and necessary. Two different standards. And so drug gets out because FDA says it's safe and effective. It doesn't automatically mean Medicare covers it.
So you've struck on sort of the inherent challenge that we're going to be dealing with probably on a going forward basis unless we change the standards statutorily. But from a management perspective, how are you trying to minimize that delay?
And that's where we get into the rules and why haven't they come out as quickly as you like? Because we have to make sure we're not overstepping our bounds.
Okay.
And we could use your help because the more you all direct us, the better we can move faster.
If you have thoughts on how we can do that, because you have an army of internal experts, surely they have some ideas about how we might consider optimizing the process. I would welcome those.
I will take up the invitation.
Okay. Oh, fantastic. Well, I look forward to working with you on that. And as I come to the end of my time, I'll just ask you, there's a patient listening sessions. I could itemize some of the challenges. This is associated with the Inflation Reduction Act. CMS held a number of patient listening sessions. Wouldn't surprise me if you anticipated a question about this in your hearing, but suffice it to say that they were not perceived by participants to have been particularly helpful. In fact, they created the impression, because of their design, that they would that they weren't intended to really gather a lot of information. So what are your plans to improve the process so that patient concerns with the IRA changes are fully heard and addressed?
Senator, here I'll again offer to take your guidance. If you know of any particular concerns that are being raised, we'd love to hear them.
I'll submit them. I'll submit them to
Please.
you. There's an itemization. Time doesn't permit the ability to unpack about 10 concerns.
Yeah, and we try to reach out, but our funds are limited on doing that type of outreach. Most of our money has to be spent on actually doing something, but we are always looking for ways to try to get feedback from patients.
Thank you, Mr. Secretary.
Thank you, Chairman.
Thank you so much, Mr. Chairman and Ranking Member and Secretary Becerra. Welcome. It's always good to see you. Appreciate all the work you're doing, you and your department, and I really appreciate the critical investments to expand healthcare access and affordability for communities, for families across the nation that's proposed in the President's budget. And this really does build on the investments and the work that we have done as Democrats with the President in the last 3 years. I do want to say, Mr. Chairman, I want to correct one thing. You were talking
Please.
about, yes, that former President Trump didn't do anything on prescription drugs. What I would say, he didn't do anything for people on prescription drugs. But President Trump and Republican colleagues did give a 40% tax cut to Big Pharma.
You got it.
In their 40% tax cut did not translate to a 40% reduction in prices for the seniors in Michigan, or for anybody on medication in Michigan. So we have been focused, working with the President and with you, on cutting prescription drug costs for Americans who have been paying the highest prices in the world, even though we have major investments we do as taxpayers to support the development of these new drugs. So the bills that we have been working on together have delivered lower costs, as we know, improved access, and transformed the way we provide behavioral health care in this country, which is so important and, as you know, is something I care deeply about. We have over 21 million people now receiving health care through the Affordable Care Act. That's a record, right? Over 21 million people signed up for insurance, very, very affordable insurance, and that's including 418,000 Michiganders, many getting a good policy for $10 a month, $20 a month. I mean, it's transformed families' lives to be able to have that health care. The health care premiums have gone down hundreds of dollars for the 271,000 Michigan residents who are using the Affordable Care Act, and of course, the $35 cap on insulin is lowering out-of-pocket costs for seniors in Michigan and across the country, not counting the inflation caps on cancer drugs that are used in doctors' offices or hospitals, not counting the cap this year on out-of-pocket costs, or next year when it goes to a permanent $2,000. And so there's a lot of, it's a big deal. It's a big deal, what we have been doing. So I want to just ask you a question and speak to what I like to call healthcare above the neck, because we need to make sure healthcare above the neck is the same as healthcare below the neck for people. And we've made historic investments in mental health, behavioral health, in a bipartisan basis. It's been really terrific to see that happen. I appreciate partnering with you and with the President to lower costs and create more access, as you have talked about. But particularly in this budget, the President including significant investments in the future of community care, which is certified community behavioral health clinics, where we are funding through the healthcare system, not through grants that stop and start. And as you know, this is something that keeps people out of the hospital, out of the jail unnecessarily, people off the streets that have been homeless, and gets them the care that they need. So we expanded CCBHCs nationwide through the Bipartisan Safer Communities Act. States are stepping up to participate. We have more states this spring that will be coming into the full program. I know that the budget not only supports CCBHC's expansion, but making it permanent. And I also want to give a shout out to Senator Cornyn. Thank you, being my partner in moving forward the definitions on CCBHCs to make sure they're permanently a part of Medicare and Medicaid. So this program is permanent, and so thank you for partnering on that. Can you elaborate on your plans to make this a permanent foundation for how we provide behavioral health care in communities across our country?
Senator, first to you and Senator Cornyn, thank you for putting in place something that has proven to be a great success and that now everyone wants to do, because mental health conditions don't surface between 9 to 5. They occur at any hour, any part of the day, and you have to be ready. And what you all did in making certified community behavioral health centers available, critical care centers available 24/7, was a God-saving measure for so many people. And so we're going to try to encourage other states to buy in, because the more we have these centers, the quicker we cut the cost of care for taxpayers, because at the end of the day, many of these folks end up using the emergency room to get the care that they need. And so what you have done is, by establishing these centers that are specific for them, for mental health conditions, it gives them a chance to see professionals that could treat them right away. And so we're going to build on that. The president's budget commits to that. And thank God you all came together on a bipartisan basis to address what 9 in 10 Americans say is a growing mental health crisis in this country.
Thank you. Thank you, Mr. Chairman.
Senator Tillis.
Senator, Mr. Becerra, thank you for being here. I want to get some housekeeping out of the way. I'm going to resubmit some questions for the record in this hearing that I submitted back in November to Director Marcos, and I really would like to get a prompt response to these. I'm not going to go through them now. It has to do largely with the facility down in Greensboro that I don't think I'll have time to talk about today, but I am a bit concerned with the timeliness of it. But I've been in and out because I've tried to get it in the order here, but you can see how people come in and out. But this is beautiful. Nobody's behind me, so I may even be able to ask
I remember those
extra
days.
questions. But yeah, and actually that's one thing I was going to mention. I've spoken with a number of people who serve with you, and they have great things to say about you. And I know some of the bipartisan work that you've worked on. But I do feel like there have been some partisan decisions that you're more or less responsible for implementing that I have a concern with. And I'm gonna point to drug pricing or price controls in the IRA as one of them. No question that we can look at that and say that we saved, I think that you mentioned $100 billion. Is that what you mentioned in response? That's true. But what have we lost? I know that shortly after the IRA was implemented, that there was at least one shareholder call or one call that was shared with us that has a double-digit drop in small molecule research because it's got to come from somewhere. And so I'd be interested if you could maybe submit for the record, unless you have detailed information now, data that would refute the fact that if you take down, I worked in research and development, not in pharmaceuticals and high tech, margins got to come from somewhere, or the money's got to come from somewhere. And if you reduce the potential to get compensated for your product, then you just do, but you have less money to spend in R&D. It looks like there's a direct correlation to IRA's price controls and a big dip in small molecule research. If you have any information to refute that, I'd like to see it. We got to get smarter with how we try and drive down drug pricing, because you mentioned in response to someone else that we want to bring manufacturing back home. Well, if you squeeze the margins for a pharmaceutical manufacturer, and we have a lot in North Carolina, then you produce fewer resources to make the case to bring manufacturing home when we know we're in a more expensive jurisdiction. So all of these things are interrelated. You can't, on the one hand, whack this industry and say reduce lower prices and then try to get this industry, who has a fiduciary responsibility to their shareholders, to say, but you got to come manufacture home. Now, maybe we can get them out of China, but we are not creating a hospitable environment in the United States for them to make these business decisions if we continue to whack them, not to mention that the president, through TRIPS waivers, is even making it more chilling on the pharmaceutical industry in terms of absolutely having a intellectual property, being able to defend their intellectual property rights over a period of time to recover the cost of an investment they made in a drug. If we don't figure out a bipartisan way to deal with this, I will guarantee you we can have people thrilled about winning the battle, but we are going to lose the war. And when we talk about drug pricing, the last time I checked, a therapy or a drug that was never brought to market cost zero, but so do the human consequences. So I'm just going to give that a soapbox speech because, as you said to Senator Barrasso, there's a lot packed in there. We got to get the right way to do it. And this is a very dangerous game that we're playing of just making purely partisan progress on this issue, like arguably the IRA was. It wasn't a single Republican vote. I also wanted to cover one of the advantages of being this far down on the dais. You get to hear a lot of other people talk. It's another thing that I think we'll probably maybe meet with you separately. Number one, we have got to get telehealth permanently authorized, period. Anybody who's just asking for another extension doesn't know how the free market works. The free market works this way. I know that this is the new operating standard from the perspective of the federal government, and I also know that there are state impediments that we need to work on. I'm doing my part in North Carolina. But you're not going to stimulate investment and innovation in telehealth unless they know it's permanent. Businesses don't operate on 2-year horizons. And it has been stress tested. All of the naysayers about telehealth before COVID have been proven wrong. It works at scale. Its efficacy is indisputable. So we need to collectively work on the federal layer and then put pressure on the state layer. And I've told my colleagues, do not come to me in this state and tell me telehealth is good, except for a couple of professions or except across certain territories. It is irrational, and I reject it before you even walk in my door. But we need some leadership from the administration, I think, for you to get it done right. And I'll submit other questions for the record.
Time of my colleague has expired. We're going to go right to Senator Cantwell here in a minute. But just coming back, I heard my friend, and we've done a lot of work together, talking about manufacturing and bringing it back from overseas if we have bipartisan approaches in terms of issues like R&D. I will tell you later, if I can catch you, I know of such an example. It got 357 votes in the House of Representatives. And kidding aside, I want to work with my colleague.
I'm sorry. You called me? Okay. Sorry. Okay. Sorry. Thanks, Chairman. Secretary, nice to see you again. Thank you. Thanks for so much in the IRA mattered in people's lives. Just did something in Toledo on a whole nother subject that mattered to people there. I want to thank you particularly for your work in prescription drugs. One of the most important things we did, $35 insulin, 72,000 Ohio seniors will benefit, 219,000 Ohioans who rely on ACA will benefit. We want to expand, as I know you do, and Senator Whitehouse and I have worked on this to expand the insulin cap to everyone, not just Medicare beneficiaries. Federal government negotiating better prices for patients. Many years ago, when you and I served in the House together, I used to take buses to Canada, about 3 hours away. People would be able to fill their prescriptions with negotiated price the way our own VA does, saving 50, 60, 70%. We can do that now, and thanks for your work on that. So walk through briefly, because I have another topic I want to talk about, how this will all work, how HHS can work to implement the law to ensure lower prescription drug costs.
So, Senator, it's already in effect, as you mentioned, with insulin. We see how it's working. I've had any number of conversations with a lot of seniors who rely on their Social Security check, essentially, for their day-to-day living. When they hear that $35 is all they'll pay now for their insulin, where before they were paying $100, $150, $250, it's a godsend for them. The fact that today we can yank back the extra profits that a pharmaceutical company is making if they try to raise the price of that drug by more than the rate of inflation, that's a great thing for Americans on Medicare as well. The fact that today the out-of-pocket costs for a senior are now being limited so that even if you have to use that expensive cancer drug, you won't pay more than about $3,500 out of pocket. That's still a lot of money.
And that number comes down.
And it's next year it comes down to $2,000 total. And for folks who are paying tens of thousands right now, that's real money.
And you think about what this Congress, the last two, have done in terms of restoring, in my state, 100,000 union workers' pensions restored, what the child tax credit did temporarily. We keep moving on it, dropping poverty rates by 40%, and what we're doing in drug prices. I mean, it affects huge, huge numbers of people that need a little bit of help in their lives. Thank you for that. I want to shift to East Palestine. You and I have talked on the phone about it. The site of the train derailment in eastern Ohio, just slightly into western Pennsylvania. Senator Casey belongs to this committee. I made my 9th trip there this week. The administration's announced a few NIH grants to get some work underway on health monitoring. That's a really good first step. I've asked HHS to set up a voluntary disease registry for the residents of that community. And I just wanted you to commit to working with my office and the residents of East Palestine and its surrounding communities, including Senator Casey's impacted constituents, on a voluntary disease registry and additional resources for long-term health monitoring.
Senator, look, I thank you for your leadership on this, on East Palestine. You know, I feel like you're always nipping at my behind on this one and making sure we're doing something. I'm glad we were able to get $250,000 to that local community health center right after the incident occurred to help them out. We're glad we sent CDC out there to do the in-person surveys to help find out what the health status was of people. NIH now this year announced 6 grants that are going out to help understand what's going on there for the folks in East Palestine. And we are absolutely prepared to work with you and state and local partners on this issue on a registry and these other matters.
Thank you. 2 other quick things. I appreciate the commitment you made when we talked during last year's budget hearing to use a project labor agreement during the construction of the new CDC NIOSH facility. NIOSH is an institution, the National Institute of Occupational Safety and Health, unlike any in the world. Cincinnati, Ohio, make a huge difference in workers, studying and understanding workers' illnesses and diseases and injuries, and that matters for, I mean, it really is about the dignity of work. Thank you for that, and look forward to working with you to make sure we have the resources to see this project through to completion and get that PLA in as quickly as possible. The other thing is we spoke recently about the financial issues. Salem Regional Medical Center, it happens to be in the same county where East Palestine is. The train going through Salem was actually on fire before it derailed 8 miles later in East Palestine. So that regional medical center faces problems because of an error made by one of Medicare's regional contractors. I need your commitment to continue working with me to ensure that we deliver timely solutions to ensure that we can keep providing care through the Salem Regional Center, if you would.
We're prepared to continue to work with you, Senator.
Good. Thank you, Mr. Secretary.
To Senator Blackburn.
Thank you, Mr. Chairman and Secretary. Thank you for being with us today. I know we've talked some about the unaccompanied minors that have traversed that southern border. A big part of the solution is to secure that southern border. Now, these children have found themselves in the custody of HHS in the Office of Refugee Resettlement. And what we have seen during this surge is the administration's inadequate ability to actually handle the capacity of unaccompanied alien children that are coming into this country. And instead of fixing the border, which is what we would have liked for the president to do, you pressured your staff to expedite the release of these children, prioritizing speed over due diligence. In fact, in a video and a Zoom call with your staff that I viewed, you actually said this, and I'm going to quote you. If Henry Ford had seen this in his plants, he would have never become famous and rich, end quote. Now, you made that comment talking about how to assembly line process children that were coming into the country. And over due diligence, over safety, you prioritized speed and moving them on out. Now, the OIG, your HHS OIG, recently reported that your staff didn't make timely safety and well-being calls, if they made them at all. 22% were late, months past the time they were due, and 18% never went out at all. At all. And it also found that the staff skipped essential safety steps, such as ensuring that the sponsors did not have a criminal record or that they were not sex offenders. So it should be no surprise that we're continuing to hear reports suggesting the existence of trafficking schemes that are preying on these vulnerable individuals, allegations that we're hearing of coercion, of forced labor, and despite my persistent inquiries on this issue, your staff has stonewalled getting answers back to me. Now, I've written you twice. I got responses that were non-answers from your assistant secretaries, one of them being over 6 months late, and I got it just last week before this hearing. Mr. Secretary, this leads me to believe that you don't give a rip and flip about what is happening to these vulnerable children. Now, you answered Senator Cornyn about knowing where the children are and knowing who the sponsors are, but I've talked to caseworkers in some places, and they say they can't ask if somebody is in the country legally or not. And OIG said they had concerns. They had 35% of the case files had legibility concerns over images, scans of photo IDs, birth certificates, legal documents. So let me ask you this. Can you sit here today in front of us and say with full certainty that your department knows the identity of these children's sponsors?
Senator, let me make sure I respond to the question in terms of the identity of sponsors. No child in our custody is released to a sponsor without having gone through a full vetting. So
a
certainly
full
we
vetting
know
that you said, let's speed it up because Henry Ford could never have been rich and famous if he worked at the slow process you are. Children are not widgets on an assembly line. They are human beings.
and that's exactly what I said.
Well, sir, I would say OIG disagrees with you. He says that you do not know. Do you think you have a responsibility to follow up with these children when they're placed?
Senator, we not only believe it's our responsibility to take care of these children while they're in our custody, but we make efforts, even though you and your colleagues did not give us the authority to try to follow them after they leave our care.
No, sir, you have the authority, 6 U.S.C. 279B.
To do what?
ORR shall be responsible for coordinating and implementing the care and placement of unaccompanied alien children. That is a shall.
That's correct.
It means you got to go do this.
That is the sponsorship
and then
vetting
section
process.
2.8.4. Care providers must conduct a safety and well-being follow-up call with an unaccompanied child and his or her sponsor 30 days after the release of the date. Mr. Secretary, Director Marcos is failing in this. There are 85,000 children that we know of that you all cannot find. And you are hesitant to move forward with giving us the information. My time has expired. Thank you, Mr. Chairman.
Thank you, my
Chairman,
colleague.
Mr. Chairman,
Senator Whitehouse.
Mr. Chairman, if I could
just very briefly.
Very briefly. First, I take umbrage to the mischaracterization and in some cases misrepresentation of the facts by Senator Blackburn. And I also want to make it clear that we have people at ORR who are working as hard as they can with the resources that we have. Your misrepresentations on the authorities we have at ORR are appalling. It is unfortunate that you wish to mischaracterize the work that we're doing, and we do everything we can with the authorities you give us to provide the care that these kids need.
Ms. Secretary,
Mr. Chairman, I would ask to submit the letters and the statute for the record.
Without objection, so ordered. Senator Cortez Masto.
Thank you, Mr. Chairman. Secretary, thank you for being here. I appreciate it. First of all, thank you. The incredible work that you and your team are doing around prescription drug negotiation as authorized by the Inflation Reduction Act is so important for seniors and so many across the country to lower drug prices. So thank you. I also recognize that Big Pharma is in court right now trying to challenge your authority under that legislation, which unfortunately is happening. In addition to the Inflation Reduction Act negotiation, we also imposed caps on out-of-pocket spending for seniors for the first time. And so how is the initial out-of-pocket cap, which was put in place just January of this year, it's just the initial, but benefiting seniors right now, and how might that change when the $2,000 cap is in full effect next year?
Senator, thank you for the question, and thank you for your work. I know Nevadans are able to keep a little extra money in their pocket because of the work that you and your colleagues have done to lower the cost of prescription drugs. Many Americans, especially those who are in Medicare and who are getting older, have very high costs for medication. They are perhaps suffering from cancer, maybe they are having kidney failure, but oftentimes their costs are extremely high. And while Medicare provides a lot of support and pays for a lot, out-of-pocket costs can be very high for some individuals. It can be in the tens of thousands of dollars. Today, this year, the catastrophic cost limit kicked in as a result of the president's lower cost prescription drug law, which means that no senior today for those catastrophic costs pays more than about $3,500 out of pocket. And next year, starting 2025, the most for those medications that any senior will pay out of pocket will be $2,000. That is a life-saving measure for many people.
And that's true, and I've heard from so many of my seniors. How do they become aware of it, though? Is your agency pushing information out so seniors are aware?
We're trying to get that information out, but a real quick story. I had a senior come up to me and say, I went back to my pharmacist because when I saw what they had charged me for my insulin, I felt guilty that they had undercharged me, so I went back to the pharmacist and said, you undercharged me. And the pharmacist said, no, that's the new price, $35. She was just up in the clouds because this is a senior on fixed income, had been paying, I think, $117 a month, $35, that's real money in her pocket.
Yeah, it makes a difference. It makes a difference to so many of my seniors as well. Let me jump to mental health. Every single one of Nevada's 17 counties is designated a health professional shortage area. Also known as HPSA, as you well know. All 17 counties are primary care shortage area, and 16 out of 17 Nevada counties are designated as mental health shortage areas. The president's budget proposes to extend the 10% incentive payment for physician services provided in shortage areas to include a broader range of clinicians and behavioral health practitioners. This committee has also passed a bipartisan package allowing more mental health providers to receive an increased bonus for practicing in shortage areas. Should this increase in shortage area bonus become law, providers across Nevada would see an increase in their Medicare reimbursement. My question to you is, many shortage areas lack a physician, but Nevadans may have access to a nurse practitioner or a clinical social worker. So has HHS evaluated how extending the range of clinicians eligible for the HPSA bonuses might impact our workforce challenges, particularly in our rural communities?
Great question, Senator, because you're right. We learned, especially as a result of COVID, that there are health professionals that may not be physicians who can do some of the work that right now they're prohibited from doing. So we're working with states because the licensing issue is at the state level. So for certain practitioners, nurse practitioner, for example, to do things beyond what is currently provided by state law, we have to have the states make amendments. And so we're working with them because COVID taught us that a lot of health professionals are ready to go. They just have to be freed from those constraints.
Well, I appreciate that, and it's one thing I know working in my state, and you as a former Attorney General recognize that at a federal level, there's only so much jurisdiction you have, and it does require either state or local community government partnership here when it comes to looking out for the best interest of our kids, or whether it comes to opening the door for access to more physicians or doctors or mental health clinicians coming into the state. There is a role for the states to play as well, and I appreciate that work that you and your staff are doing, that partnership. Thank you.
Thank you.
Thank my colleague. Senator Cassidy is next.
Hey,
Mr. Smith.
Thank you, Mr. Chairman. Thank you, Secretary, for sharing your time here today. I'd like to start off with an issue that I've worked on for quite a while now, and that's TANF reform. I think there is ample opportunity to get some things done here. I, a while back, introduced Jobs for Success Act in the previous Congress, and to really focus on helping folks who need the most help, who are very needy, that in fact the neediest among us. One of the most important provisions of that bill, I will say, is that it would prohibit the use of TANF funds for families with income greater than twice the poverty line, so 200% of federal poverty. I'm pleased to see the priority was reflected as a key proposal in the Administration for Children and Families' recent proposed rulemaking on strengthening TANF as a safety net and work program. In fact, the very first proposal included in that proposed rule is to establish a ceiling on the term of needy so that it may not exceed a family income of 200% of the federal poverty guidelines. So I certainly appreciate that the ACF recognizes this issue. So setting aside other issues of TANF, I'm wondering where we I think there could be some other things that we would disagree on, but I'm just wondering if when it comes to establishing this ceiling of 200% of federal poverty, could you support the legislation? I've introduced the legislation already. Could you support that as a standalone measure?
Congressman, first, thanks for the work you're doing on this, because it is not easy. It will take congressional action to get reforms to TANF that will get it to work better, to do, as you said, to concentrate the money on the most needy families. We, as you mentioned in our proposed rule, look to try to do that as well, but we are absolutely prepared to work with you to see how we can do it, because if it's in a statute versus a regulation, far more powerful.
Okay, so I'll take that as a yes.
We'll work with you, because our own proposed rule is right now undergoing a lot of comment as well. So we're trying to take in comment to figure out where best to go. But without a doubt, you all will be indispensable making sure we can get TANF moving in a better direction.
Okay, thank you. Earlier this week, I'm glad our committee held a hearing in Texas to discuss problems that our constituents encounter in accessing emergency care. I'm glad to say that a critical access hospital, formerly critical access hospital in my district, Friend, Nebraska, previously having been in critical access, shifted into the rural emergency health facility, and that was rocky. That transition was rocky. There's concerns that it didn't need to be that way, obviously, but wanting more information at the local level, they tried to get that information. It was not available. I think it took some 4 months for this institution, that was facing budgetary problems, to shift gears into this new category so that they could help their own patients. And so I'm just wondering, fortunately they had local government to help back them up, but not every facility would have that. So I know that this rural emergency healthcare designation is very new, but I'm wondering what HHS can do to make the process faster and even more transparent. And could there be a dashboard to allow the local level to pursue the status of where they stand at a given point in time so that they can get this done more quickly?
Yeah, and Congressman, you bring up a very important point in that this new classification will be very important for a number of these facilities. We want to make sure we do it right, because, as you know, there's always an effort when there's money involved to game the system, and we have to make sure it's done right, so we reserve the category for those who truly qualify. I think with time, we're going to start to really get a better sense of how to move this faster for those who wish to qualify, but You know, the best thing I can tell you is that we're going to do everything we can to sustain some of these hospitals and facilities in rural America, because if they go, there's nothing to replace them.
Okay, thank you. And just briefly here, I'm concerned that despite ongoing attention to the Office of Refugee Resettlements losing track of thousands of unaccompanied minors, I'm just wondering, do you truly believe that ORR is doing everything possible, especially when it appears that we've lost contact with nearly 20% of children released through the Unaccompanied Children Program?
Congressman, thank you for posing the question. And respectfully, I'm going to correct what you said. We haven't lost any child. Please remember that our jurisdiction that you all gave us, that Congress gave us, is for custody of children. Once we find a vetted sponsor, which we're obligated by law to do for these migrant kids, we lose all jurisdiction over them. We don't have the ability to follow up with them or require them to follow up with us. So it's hard to lose anybody you don't have jurisdiction over. Okay. What we do try to do is voluntarily keep tabs of them as we transfer them out to a sponsor. So but while they're in our care, they do not get lost.
Everything is working fine. Is that your suggestion?
In our jurisdiction, the custody that we have of kids, I welcome you to come and take a look. We are taking care of these kids. Now, what happens to a child once they're into the community and they get attracted to get a job at some meat packing plant? I wish I could tell you I could speak to that. Until you all give us jurisdiction to oversee some of that, I can't go there.
Well, last March, a year ago, I wrote a letter, got a response in July. I had to follow up in October and still haven't heard. So I'm concerned that there's problems. So I hope we can work together to establish a better system. Thank you. I yield back.
Thank you.
Thank you.
Thank you. We'll now proceed to the question and answer session. On February 29th, every Republican member of this committee sent you a letter asking what your department is doing to address the impact of the illegal immigrant crisis on our healthcare system. This influx of illegal immigrants has forced safety net hospitals like Denver Health in Colorado to turn away patients and reduce the number of beds reserved for Denver residents seeking substance use disorder and mental health treatments. What is your department doing to address this growing crisis, given the real fear that other hospitals in sanctuary cities across the country may similarly be impacted, harming the nation's healthcare system, safety net, and threatening healthcare access for vulnerable patients?
Mr. Chairman, thank you for the question. As you know, we have some of the most advanced and capable hospitals in the world. We count on them to be able to keep Americans healthy and safe. We continue to work with them day in, day out. When Change Healthcare had this cyber attack, we were there to support them as well. We will do everything we can to make sure they continue to provide the services that Americans count on, whether it was during COVID or whether it is now. We're prepared to work with every one of our hospital facilities to make sure that they continue to operate and provide the services that Americans count on.
Has your department been working with Denver Health in Colorado with the issues that I just raised?
We've certainly been working with the state of Colorado. And if we were to get a particular request from a particular facility, we would certainly then try to work with them to resolve any issues they might have.
Earlier this month, the committee passed legislation introduced by Representative Fischbach to block the implementation of the unworkable one-size-fits-all nursing home staffing mandate. Estimates show this rule will impose a $40.6 billion cost on nursing homes, 94% of which currently wouldn't be in compliance, jeopardizing access to care for 1.2 million Americans. Can you commit to the Medicare beneficiaries watching this hearing that no nursing home will close and patients won't lose access to care as a result of this rule?
Mr. Chairman, I can commit to you, and I commit to each and every one of the Medicare beneficiaries that is out there, that if they need a nursing home, they will find one that offers them quality care. We want to make sure that no nursing home becomes a death sentence for any American who has to use the facility. And we want to work with every nursing home to make sure that they are offering quality services. And if you think about it, of the 1,200,000 or so Americans, 1,500,000 Americans who reside in nursing homes, that is a fraction, a little bit more than 1% of, not even 1% of the population. But when you take a look at the death numbers that occurred during COVID and you realize that 1 of every 5 Americans who died from COVID died in a nursing home, something's going on. And we can't just close our eyes to it. We have to make sure that if we're going to leave our loved one in a nursing home, there is a nurse that's available to provide care. And these standards simply say that. Make sure that if you're going to claim that you're a nursing home, you have the professionals who can provide the services to our loved ones before we leave them there in your care.
So San Francisco recently enacted a law requiring residents who are suspected of using illegal drugs to undergo treatment as a condition to receive welfare benefits. Since 2011, my home state of Missouri has required certain TANF recipients to be screened for illegal drug use, a law that I helped advance at the time as a member of the State General Assembly. And as it relates to the rise in opioid abuse, you yourself have said all options should be on the table when it comes to how communities across the country address the drug crisis. Given that TANF has an outright ban on providing assistance to those with drug-related felony convictions, I appreciate your position, which many of us have believed for a long time, that states should be looking at how to utilize drug testing in their welfare programs. If San Francisco's actions are suitable, then surely other cities, counties, and states should be encouraged to make similar decisions. And so to that end, and consistent with your recent comments, is it fair to say you're open to Congress and states putting stronger protections in place to make sure recipients of welfare benefits are being screened or tested for drug use?
Chairman, thank you for the question. I want to make sure, please do not misinterpret what I said when I referenced the drug crisis, the overdose crisis that we face in this country. Certainly, we want to make sure we are exploring every opportunity to save a life when it comes to the overdose crisis that we face. What decisions a local community decides to make for itself and how it will handle TANF dollars, which is different from specifically dealing with the overdose crisis. I won't pass judgment there. I don't represent that area. I don't have jurisdiction on those issues. But what I will tell you is that any community, whether it is San Francisco or whether it is your district, Mr. Chairman, we are ready at HHS to try to help address the overdose crisis, because no American should die simply because of fentanyl and these other drugs that are now infecting our communities.
Thank you, Secretary.
Thank you, Ms. Moore. I always love hearing your testimony. Thank you for the great questions, for really putting the Secretary on the hook. I appreciate that. You always do a great job. Thank you, Mr. Secretary, for being here. Obviously, it's very important to have you here. And I know many of us are, at least on our side of the aisle, are concerned about the Department of Health and Human Services FY25 budget request and some of the political priorities that seem to be permeating this budget over the needs of the American people. And I want to just kind of jump into some of the questions. My first one is the co-chair of the Election Integrity Caucus says, in response to President Biden's executive order, it's 14019, I'm not sure if you're familiar with it, your department has announced that it plans to turn more than 1,400 community health centers into voter registration hubs. Implementing this policy will require these essential safety net providers to take their focus off rural disadvantaged communities they serve on and to get involved in political activity. And you just cited to Dr. Murphy that we really have to be focused on our core mission, which is the mission of providing health care and good health care to our communities. Do you think it's appropriate for the federal government under this executive order to be engaging in electioneering or these vote harvesting types of drop boxes and political activity while they're doing their official jobs as members of the Health and Human Services?
Congresswoman,
government payroll.
Thank you for the question. Those community health centers cannot engage in electioneering. That would be a violation of federal law. And simply by providing people with access to information so they could register to vote is not a violation of federal law.
How about providing, having staff have to monitor drop boxes and other political entities that are there? Is that something that the people from Health and Human Services would be doing at this election coming up?
What you've just described does not sound anywhere near what the job would be.
But the executive order specifically asks federal agencies to engage in this type of political activity. Is that something you're going to prohibit as the secretary?
I think you've inaccurately described it, but if you have the executive order and read me that, I could tell you what it means, but
It's
I know
14019. We've talked about, I mean, it's on my, you can go to my website, tenny.house.gov. I explained my votes there too, but let me move on because I think it's really dangerous for our federal employees who are on our government payroll to be engaging in electioneering
they can't
to the
do that.
extent.
It would be a violation of law.
But somebody's got to monitor and make sure we have election integrity there. So I assume that, who's going to be monitoring this other than maybe some of our, I just want to be sure that you as secretary are making sure there's a wall between the people who are serving the public for healthcare reasons and those who are engaging in political activities.
We make it clear to all of our employees.
Will you be doing that to make sure that happens?
We always make it clear to them that they cannot engage in activities that cross the line.
Including what would be under Executive Order 14019.
That's where I disagree with you. I don't believe there's any electioneering that would be done by federal government
Do
personnel.
you think a Dropbox is something that, who monitors a Dropbox at a federal agency?
As I said, if you show me what you're referring to in the
We'd be happy to provide that. I want to get to the next question. So I know that the administration's, I want to just ask you quickly a question. It could be your personal view or it could be the view of the administration that you serve. Do you consider yourself, when it comes to the issue of abortion, as pro-choice?
I'm here testifying as the Secretary of Health and Human Services. I have a pretty long record about where I am personally, but I'm here today as the Secretary of Health and Human Services. So I would answer the question, if you'd like, as the Secretary of Health and Human Services.
That'd be great, yes.
And so I would answer you by saying that we provide every type of health care service available to the American public. We'll protect every American's right to access the health care that they're entitled to under the law.
So if a woman wants
to
choose to have a baby, that service is protected as well?
Every service that a person is entitled to under the law, if we have a role in providing that service, we'll make sure that that right is protected.
Thank you. I greatly appreciate it, because under your leadership, HHS is expected to finalize a rule that will block crisis pregnancy centers from receiving temporary assistance for needy families, otherwise known as TANF funding. These pregnancy centers are dotted throughout the country that do provide pregnancy testing for sexually transmitted diseases, prenatal, pregnancy education, ultrasounds, adoption referrals, and a number of items for needy families. And TANF is about keeping families together, I assume. So I want to make sure that you are going to make sure that, why isn't this rule covering crisis pregnancy centers if indeed you are looking for access for all families and all choices they make, whether they choose to have the child or choose the abortion route?
Congresswoman, I think you've mischaracterized what the rule would do. So long as entities qualify to receive the money and will be providing the services that are required by the statute and regulations, they will receive their monies.
So, but it specifically prohibits crisis pregnancy centers from receiving that money?
No, it doesn't. It prohibits anyone that is not providing the services that they're obligated to provide if they want to receive the money.
Thank you. I appreciate it.
Mr. Fitzpatrick.
Secretary Becerra, it's so wonderful to see you since your first elected office was representing me in the California legislature nearly 40 years ago. So to see you in this position is just wonderful.
Thank you.
I wanted to talk about the administration's commitment to reproductive health, including the Title IX Family Planning Program. And I'd like to bring up the issue of contraceptive access, which is more urgent than ever considering the ongoing attacks on reproductive rights around this country. As you just said, the ACA requires health insurance plans to cover preventative services, including birth control, at no cost to the patient. But for years, there have been extensive reports of plans failing to comply by illegally denying coverage, delaying claims, requiring cost sharing, forcing step therapy, or failing to maintain a transparent exceptions process. Now, I appreciate that HHS recently released new guidance for insurers recommending they cover all forms of contraception, including a therapeutic equivalent, otherwise known as generics. But many of us members are very concerned about compliance with this, and that's why 143 House members and 13 senators signed a letter to the health insurance plans asking whether they're going to comply with this therapeutic equivalent standard. So my question is, how will the department enforce this new guidance to ensure that everyone has access to the birth control that works best for them?
Congresswoman, thank you for the question and actually for your just intense dedication to trying to address this. We have met with the plans and the plans' representatives. We have met with pharmacies and the pharmacy representatives to make it clear that under the law, they must make contraception medications and services available at no out-of-pocket cost. We've also told them that we have enforcement authority under Section 1557 of the Affordable Care Act, and we are prepared to use that. We also we've explained to some of these entities that because they rely on services and reimbursement for services based on Medicare and Medicaid, that they must abide by federal laws in order to continue to receive those dollars. So we're going to use every lever we can to make it clear that there are laws in place that protect patients' access to care, and we will do everything we can to enforce those requirements and protections.
Thank you. That is so reassuring to hear. And then on a different topic, I'd like to bring up the role of artificial intelligence in Medicare Advantage coverage determinations. I'm concerned that the increasing use of AI in coverage decisions has resulted in wrongful denials of medical care for an alarming number of seniors enrolled in Medicare Advantage plans. In fact, there's a class action lawsuit going on right now against one major insurer's use of AI to deny medical claims where AI systems allegedly played a role in the denial of over 300,000 payment requests within a 2-month period. The average time spent supposedly reviewing each of these claims was a mere 1.2 seconds. So in response to these care denials, I sent a letter to CMS last November with 30 other House Democrats expressing the need to increase oversight of the use of AI in Medicare Advantage payment denials. I appreciate that the administration recently issued guidance that aims to increase oversight of AI tools. Can you talk about how the department plans to enforce the requirements that MA plans comply with Medicare rules and do not inappropriately create barriers to care?
Congressman, thank you for the question. And as you know, we are moving to try to remove some of the layers of obscurity that have made it very difficult for us to have clear sight on how the MA plans are operating and to have the data that shows how they're administering some of their programs. And so we're trying to make sure that we monitor the way the MA organizations use their utilization of utilization management tools that will ensure us that they are complying with the new requirements that we put in place in regulations. We're going to continue to make sure that if prior authorization is used for making decisions on payment of bills, that we have better sight and we understand what data they're relied on. And certainly because of the preoccupation with AI, we want to make sure that algorithms aren't being used that discriminate against communities and populations because they don't take into account the full breadth and scope of circumstances and the data that's necessary to make sure that decisions are being made based on coverage.
And that is exactly what our worry is. Thank you, and I yield back.
Thank you.
For a while. This is not any new information to any of us, so we need to tackle that issue immediately. If that would be my suggestion.
We'll reach out to you.
Thank you, sir.
Thank you.
I yield back. Thank you.
Mr. Letourneau. Thank you, Mr. Chair. Mr. Secretary, welcome today.
Thank you.
We have seen a surge in recent years of youth mental health issues. And we are seeing in particular that children's use of social media is impacting their mental health. Many companies are more interested in making money off kids than protecting them, sadly. The data is alarming. For example, the rate of eating disorders has doubled amongst adolescent girls, and children's hospitals are seeing a surge of children showing up with serious mental health issues, including a 67% increase in referrals at Children's Mercy in my own state. The NIH has begun working on a study to better understand the impacts of social media on mental health. Are there any current findings that you can share with us today?
I'd like to tell you that we've had some definitive research done and we can give you findings, but I'm not aware of it. I can make sure we check with NIH, and if you'd like us to follow up with it, we can. But we are I think there's not just NIH, but a number of agencies, a number of private sector and academic research institutions are trying to look into this as well.
Well, that's what I want to talk about. What is HHS doing to prevent, research, and intervene early when a child is struggling with their mental health, especially in the case of serious mental illness like eating disorders?
I can try to make sure we respond back with the different projects that are underway, research projects underway at NIH, and we can certainly make sure that our agency, our SAMHSA agency, the Substance Use and Mental Health Services Administration, also follows up with you because they're the ones that are doing the more direct services to communities today. And so, for example, when you all passed a bipartisan bill on gun violence and provided monies for mental health services, SAMHSA was the agency that was charged with trying to dispense those dollars best.
I would love some of those
follow up
answers. That would be helpful. The crisis of antimicrobial resistance,
yes,
or AMR, threatens modern medicine and is currently a leading cause of death worldwide. I'm encouraged that the administration recognizes AMR is a serious and urgent threat to patients and public health by including a proposal that aligns with the bipartisan, bicameral Pasteur Act, which I'm proud to co-lead in the House, to encourage the development of innovative antimicrobial drugs and ensure we are armed with an adequate supply of properly stewarded antimicrobial products against highly dangerous drug-resistant microbes. Can you describe your budget proposal on antimicrobial subscriptions in more detail, including an expected timeline for implementation?
Yeah. First, Congressman, we don't know each other well, but I'd love to give you a hug because there just aren't enough members of Congress who want to touch this issue of antimicrobial resistance. And in so many ways, as you know, people are dying at rates that sometimes surpass COVID. And we have an obligation to make sure people are safe and we don't lose quality medicines because they're not used properly or they're overused, and we don't prepare for the next bacteria that may come at us really hard. And so what we're trying to do is very, very similar to what you're proposing in the Pasteur Act, is figure out a way to make it worthwhile for manufacturers of these medicines to stay in the game, because many of these medicines, as you know, don't have a lot of profit behind them. And so it's tough for a business to stay afloat trying to sell drugs that you can't sell for very much money and often aren't needed until there's a crisis. And so the subscription model, which says everyone will buy in and start to try to do the manufacturing, give us an industry that can be available. They can do that because we'll have a subscription model where everyone pays in early, so there's money to be had, so you don't have to wait till there's a crisis to know that you get paid for your good work in manufacturing a particular medicine.
I appreciate that. Of the over 100 million Medicaid enrollees, approximately 40 million are able-bodied adults. Over the past several years, your administration has revoked multiple waivers, allowing states to test work requirements for these able-bodied adults on Medicaid. At the same time, we've seen data from state Medicaid agencies indicating that many of these same able-bodied adults are not working at all. We've had work requirements as a core principle for participants in the TANF program for decades now. What is your opposition to allowing states to experiment with policies to move these adults from welfare to work?
And so, Congressman, let me make sure I'm clear, because you mentioned both TANF, the welfare program, and Medicaid, which is a healthcare program. So tell me where you want me to focus.
Well, focus specifically on on your revoking multiple waivers, allowing the states to test work requirements.
So this is in regards to Medicaid, which offers waivers to states.
The 1115 waivers.
1115 waivers are part of the Medicaid program within the CMS agency. The waivers are provided to states, and just to make sure it's clear, Medicaid has certain laws that Congress has passed on how we implement Medicaid and how we get resources to states to implement the program that's principally for lower income Americans to have access to doctors and hospitals. Medicaid, it's a matching program where—
I'm running out of time.
I'm sorry.
Get to the core of my question,
Okay.
which is my observation that there seems to be an opposition to allowing states to test things like work requirements.
Sure. The Medicaid program's focus is on healthcare, making sure healthcare is improved. If you look throughout the Medicaid statutes, you won't find a single word that says work requirements. And what we do is we make sure that any proposal by a state, whether it's direct Medicaid servicing or through a waiver of those servicing requirements, that the health of that individual who will be impacted by the waiver improves. And so that's what we look at. We don't look at any other thing. A state may want to try to do other things, which is fine, but our purpose is to make sure if you're going to ask for a Medicaid dollar, that when it is applied to that individual in your state, it improves the health of that individual. And so that's what we look at. And if certain waivers are retracted, it's because we're not seeing results, and taxpayers have a right to demand results when states spend taxpayer dollars.
I'll tell you what's good for people's health also is understanding the dignity and pride that comes with work. and not allowing states to pursue this, and to have the opportunity to observe what works in one state and what may not work so that we can have best practices is not a good thing. And so I hope that you will rethink your position on this.
I just want to make sure we're clear. We don't stop any state from.
My question was very clear. Your
Well,
answer wasn't so
Gentleman's
much.
time's expired.
Thank you, Mr. Chairman.
All right, Mr. Edwards.
Thank you, Mr. Chair. Thank you, Mr. Secretary. I appreciate you being with us this afternoon.
Congratulations on your.
Thank you, Mr. Chairman, and welcome, Secretary Becerra. I think before I start asking you some questions, I want to clear the air on a couple of topics that have come up from Mr. Smith and Mr. Buchanan regarding no TANF for people above 200% of the poverty level. You said you were taking comment on that, so I'm going to give you comment. I do think that the framework for TANF was to respect flexibility, and although the quarterback, Brett Favre, and folks misused it in Mississippi, I do think that retaliating against the fund and people who need it is the wrong move. So that, taking $5 million a year from the contingency fund, I think is wrong-headed. I think it's wrong-headed to say that you won't serve anybody above 200% of the poverty level. When you start thinking about the kinds of things that you say you want to do under TANF, some TANF monies is used to supplement the EITC, the state child tax credit. And so before you fall into the trap of my colleagues on the other side, by nodding your head to that, I would want you to think that through. I was really pleased to see that the budget was addressing mental health and substance abuse problems. Once again, I have a bill that would provide perinatal mental health and substance abuse problems for pregnant women from the earliest stages of pregnancy until 1 year afterwards. And I think that you don't want to upend that with some sort of agreement about 200% of the poverty level. So that's my comment on that. And with regard to drug testing, TANF recipients, I say that, I'm not a lawyer, so I don't know much about the 14th and 15th Amendment and due process and equal protection and stuff. But I know that if you're going to just pick out people who receive TANF, there are a lot of people who receive entitlements in our country, and you're not drug testing them. So maybe we should expand the list of people who receive monies up to and including some very wealthy people who receive tax credits and tax benefits. That being said, let me ask you some questions I intended to ask you before their testimony. I was really interested in understanding how HRSA, the HRSA opt-in modernization program, whether or not that can fill the gap in access for people of color to be able to access deceased and be included on the deceased donor transplant list. Will this help to decrease the disparity?
Congressman, I apologize. You're going to have to repeat the question.
All right, I'll ask another question. How about the Medicaid unwinding? There are 12 million people out there who do not receive Medicaid because of procedural reasons. And so is there anything that your department is doing help with the states to do outreach to these 12 million people that lost Medicaid?
Congresswoman, since before last year, we started working with governors and states about the Medicaid unwinding process and making sure that as they go through the redetermination process, that they're making sure that for bureaucratic reasons, people aren't kicked off of indispensable.
Well, they are being kicked off. So is there any effort to make sure we contact and reach those people to get them back on?
Yeah, we've engaged in a number of the one where we were able to get 500,000 to 600,000 kids back onto rolls because we found that the states were not applying the procedures properly.
Okay,
one of the methods.
Thank you. I don't have much time. I have legislation to reduce the tax disparity affecting the health professionals who receive the Indian Health Services scholarships. So does your budget, which does a lot for Native Americans, address the tax gap between Indian Health Service scholarship recipients and others?
Gosh, I'll have to get back to you on that one.
Okay, thank you. Let me ask the question that you didn't hear before. There's a big disparity in organ transplantation for people of color and other people. The HRSA opt-in modernization, is that going to help people of color access the donor list?
The whole purpose behind the reform and the legislation that recently passed is to change the dynamics so a monopoly doesn't run the system, and it's done on a more competitive basis, and the system that's in place to make sure who gets transplants is done fairly throughout the country is now going to be done without profit or other motive involved.
Okay, just one final question. The principal illness navigation, the PIN, for cancer and stuff, do you think that the kidney transplantation would benefit from this PIN navigation system?
Congressman,
is that a possibility?
You're going to win the prize for giving me the hardest questions to answer that I wasn't prepared to give you a direct answer to. So let me get back to you on that one as well.
Thank you so much, and thank you, Mr. Secretary, and thank you, Mr. Chairman.
Thank you, Ms. Tenney.
Thank you, Mr. Chairman. Thank you.
Far more than someone who says they're a friend.
Thank you, and I yield back.
Mr. Siscomani.
Thank you, thank you, Mr. Chairman, and thank you, Secretary Becerra, for being with us today, for coming to testify. As you know, the U.S. has large disparities in health outcomes among U.S. women. We talked a bit about that right now, and minority populations as well when compared to men. And as a father of three girls, I've never wanted to see my daughters face undue challenges because of their gender or their race. And that goes for healthcare research to job opportunities as well. So my question is, despite making up more than half of the population, women have been historically understudied and underrepresented in health research, as well as being chronically underfunded. And I'm concerned. I'm concerned many of the diseases we are focused on today, such as Alzheimer's and cardiovascular disease, impact women to a far greater extent. In light of this, how does HHS plan to advance women's health research across the agency to prevent, diagnose, and also treat health conditions in women?
Congressman Siscomani, as a father of three daughters as well, I feel for you because you have to sometimes go without the kisses and hugs that you get from those three daughters probably every day you're around.
True, all the way.
Yes, and you're gonna love. I don't know how old yours are, but mine are now in their 20s, and they're gems. In fact, one of them was in this room for a while. You're a lucky man. And what I will tell you is that this president has given us an opportunity to really focus in on women's health and women's health research. This week, the president announced through an executive order that we're going to double down on doing health research. Quick thing I learned, women athletes, for the most part, the athletic apparel they wear, whether it's their shoes or their jerseys, are simply downsized versions of the men's shoes and jerseys. Women's feet are very different from men. Their arches are different, but yet they have to wear for professional athletic activity shoes that were designed for men. Jerseys, I found out that the Spirit, I think is the name of the team, the soccer team here, women's soccer team here in Washington, D.C., their jerseys are just smaller men's jerseys. It goes to that extent that not only have we not done the research on heart disease, which attacks women more than men, but we don't even make sure that our athletes, our greatest athletes, are getting the kind of equipment they need. We have to do more. If you're interested in that, we'd love to chat with your team about what we're doing and how we could use your support.
Yeah, that was the full nature of the question. And to begin to tackle this health disparity, we need to begin with how agencies collect data, I think, as well. I don't know if you were aware that only about 5% of clinical trials even report the number of participants by sex. So how much of your budget is going to focus on women's health research specifically?
Well, the president's budget actually increases by several hundred million, the focus on women's research. And we have a particular project, and I hope you're familiar with ARPA-H, the new program that's similar to DARPA at the Department of Defense. They have what they call a sprint on women's health And what we're doing is we're going to reach out to private sector companies, usually small businesses that are having difficulty finding capital to move their project forward. And we're going to see which one of them, it's sort of like a Shark Tank. And we're going to invest in some of these private sector innovators to see what we can move forward. And it's going to be on women's health research.
Well, I do want to take you up on the specific briefing on that. One more question. While on the topic of women's health here, I specifically want to ask about the department's focus on maternal health.
Yes.
A critical component is having safe medications and therapeutics that can be used during pregnancy. But despite 90% of the pregnant women taking medications, less than 5% of medications have any data on how it impacts women during pregnancy or her baby. Like I mentioned, and you and I talked about, I'm a dad of 3 girls. I'm also a dad of 3 boys. So I've been with my wife through 6 different pregnancies. And then to think that mothers are likely taking medications that have never been studied on pregnant women, that's concerning. So what is the agency doing to begin studying common medications and therapeutics taken by pregnant women?
We are, and the focus of the Women's Health Research Initiative is to absolutely make sure that not only are women included in general research projects, but that there are those that are specifically geared towards their health and their conditions, so we understand them better. Why is it that women seem to get Alzheimer's at a greater rate than men? Those are the kind of questions that these initiatives will actually help us answer, and we'd love to have you on board, and congratulations on the 3 boys as well.
Well, I definitely am on board. I want to make sure that we are, the disparities here between the percentage of the research that we're actually conducting and the percentage of women getting these diseases is quite astounding. So the numbers have been there for a while. This is not any new information to any of us, so we need to tackle that issue immediately. If that would be my suggestion.
We'll reach out to you.
Thank you, sir.
Thank you.
I yield back. Thank you.
Mr. Letourneau.
Thank you, Mr. Chair. Mr. Secretary, welcome today. Thank you. We have seen a surge in recent years of youth mental health issues. And we are seeing in
Mr. Byer.
Mr. Chairman, thank you very much. And Mr. Secretary, good to have you here. I want to just add my voice to the concern about the new TANF rule, specifically about high school dropout prevention programs. Some of the most important ones around the country, Jobs for America's Graduates and others, rely on TANF funds to pay for it. And the argument, of course, is better to people that don't need to go on TANF in the first place. And I hope that you and your folks will pay attention to that. What we'd like to do is ultimately reduce the overall TANF burden. And it's the old pay me now or pay me later piece. I also want to thank you and applaud your dedication to suicide prevention and mental health. You know, it's really important that we adequately fund the 988 number, the CDC suicide prevention effort. I believe there were 507,000 calls alone in the month of January. It's making an enormous difference. And I also want to applaud you for your work on long COVID. You know, it's still we've done a lot. Last week we had Long COVID Awareness Day, but we still don't really understand post-illness acquired conditions. And now is the time to ramp up for the lessons learned. You know, President Biden is leading on the AI revolution, and I know you've testified its consideration in your budget. You've been using artificial intelligence in healthcare, the FDA specifically, for years. But can you talk about what gaps you see in your existing regulatory authorities and funding when it comes to supporting AI innovation in healthcare?
Congressman, great question, and thank you for the work that you've done on this subject. We don't have enough authority to really go in and see behind the curtain of what's going on with a lot of these entities that are using AI. We'd like to make sure, for example, that the algorithms that they're using won't end up discriminating against people because the data they're using to input into these algorithms don't take into account the needs of particular communities. We'd also like to make sure we have a better sense of how they're going to deploy some of this AI technology, because it could be done in a way that, once again, it leaves out certain communities if they don't happen to fit the criteria or the perspective of that particular algorithm. AI can be a tremendous asset. It can help produce efficiencies, accelerate access. At the same time, if we're not careful, it will do it only for some but not all Americans. And so our interest is being able to look behind the curtain to make sure that the platforms that are being used have equity in them from the very beginning.
Yeah, very good. Thank you very much. There's a lot we can also learn from the electronic health records conversation with respect to AI. And one of the ideas has been an assurance lab, which I know the FDA Device Center Chief's been considering. Can you talk about this is something HHS is seriously pursuing, the whole notion of assurance labs?
I'm going to tell you, I'm not as deep on that as I should be, and what I could do is get back to you and make sure the team responds well from HHS.
I also want to say, on the negative side, we're still disappointed at the continued underfunding of AHRQ ARC. It's a really important part of your HHS piece to get the quality right to begin with.
I got to give you a hug, Congressman, for saying that, because you're absolutely right. They do some tremendous work.
Thank you. And finally, on CMS data concerns, the research community has talked to us about CMS has announced changes to its research identifiable file data and the discontinued delivery of physical data extracts. We're hearing that they could be incredibly damaging to public health system research and health research at large. The Virtual Research Data Center, all caps, has significant coding limitations, it's slow, has regular system errors, interoperability limitations, among other things. And apparently there's significant new fees to access that can run tens of thousands of dollars per researcher, per year, per project, with no option even for having screen sharing among researchers in the same project. Can you talk about how HHS and you can address the access and affordability? What makes VRDC usable in the first place?
Congressman, you've touched on something that I think will become a very important subject to resolve, and that is that data is so valuable, and for researchers, it's gold, and we want to make sure that researchers have that information that they need so they can continue to come up with innovations and therapies that will keep people alive. At the same time that we know, as we saw with Change Healthcare, that there are bad actors who are constantly trying to get access to that same data and use it for the wrong reasons. We have to make sure that everyone who accesses data, and we provide a lot of data, that it's not misused. And so we're just doing what everyone is now having to do, is moving toward platforms that provide more security, because you don't want your personal data, I don't want my personal data to get to go into the wrong hands. If it's a researcher doing the right thing with it, great, but we don't know, and we have to live in this new world. That's why we're migrating to something that provides more protection, but we'll continue to take comment because we've heard these concerns, and we want to make sure at no point do we stifle research.
Thank you very much, Mr. Secretary. I yield back.
Are in rural communities.
Thank you. I yield back.
Mr. Edwards.
Thank you, Mr. Chair. Mr. Hoyer, I appreciate your comment, and I mean that respectfully. I would, and I don't want to get into the debate about marijuana and cigarettes right now, although I believe we need to be having some more conversation up here on this Hill about the harmful effects of marijuana and the state's rights to circumvent federal law. But this is probably not the time for that. And so since I saw the word appropriations over the door out here, I'm going to try to turn back, Mr. Secretary, the conversation to appropriations. As this committee puts together a funding bill for the upcoming fiscal year, we're going to have to set priorities about how to spend the taxpayers' dollars. And importantly, we have to stick to the limit set for our subcommittee. With that in mind, I want to ask you about some of the ways HHS's budget proposes paying for its priorities, because some of those appear to exceed the principles agreed to in the Fiscal Responsibility Act. The HHS budget also has mandatory funding proposals for things traditionally paid for with discretionary appropriations. A few examples include $1.4 billion for cancer moonshot activities at the National Institute of Health, $150 million for a community violence intervention initiative at the Center for Disease Control and Prevention, and another CDC proposal for $1 billion for vaccines for adults. Why, Mr. Secretary, did the administration propose these expansions to the mandatory side of the budget, especially given the warnings that we hear from the CBO about the projected growth in mandatory spending and what it means to our growing debt?
Congressman, thank you for the question, and clearly you've hit the ground running in your new committee assignment, so congratulations to you. Let me just use one of the examples, vaccines for adults. We have a program for children, Vaccines for Children program, which is very successful, and the reason so many children have been vaccinated and kept safe from things like measles and other types of very contagious diseases. That program, Vaccine for Children, is on the mandatory side, and it's because it is widespread, The utility and value is well known, and rather than have to go through the constant discretionary budgeting process of allocating money for something we know is indispensable, we considered a mandatory program. Vaccines for adults are no different. We know from COVID that if you didn't get vaccinated, chances are you were the one in the hospital or perhaps dying. We want to move that to the mandatory side because, again, it's indispensable, it's universal, and it's something that will not only benefit the individual, but American society. And so the purpose of moving some of these programs into on the mandatory side is because there's a clear value in not having to go through the yearly exercise of saying you'll allocate dollars for a very worthwhile purpose.
And so to follow up, exactly what would that value be? Do you not think that the taxpayers deserve to have this dialogue and to have the expenditures questioned year after year? Why should we just take for granted that carte blanche for perpetuity that we'll spend these mandatory dollars?
Yeah, Congressman, having served where you are for 24 years, you have that opportunity to have that discussion. In fact, you have the right, not just the opportunity, to actually change that so that it won't be a mandatory program, or it will become a mandatory program. That's the purpose of these hearings and your debates. You all decide if it's a mandatory or discretionary program. We live by your direction, and we'll try to make sure that we provide the type of services that you expect. But honestly, you all the reason the adult vaccination program is not mandatory is because Congress has not yet decided to do so. President Biden has said, we believe it is now time to make it a mandatory program. It is worthwhile to do.
All right. Thank you. I'd just like to make a comment to the chair and to the rest of the committee that I would resist adding any more mandatory spending to our budget. I think every dollar should be challenged with every budget. So, thank you. With that, I yield back.
With a final statement, I want to recognize the ranking member, DeLauro.
Thank you so much, Mr. Chairman. I really appreciate the opportunity. Just one or two observations. I think we've got a task cut out for us on this
Ending advance premium tax credits and continued support for rural health providers. I am proud of the Biden-Harris administration for taking the necessary steps to close the coverage gap in this country. As a representative of Alabama's 7th Congressional District, a district with high rates of chronic diseases, yet in a state that has not expanded Medicaid, closing the coverage gap remains a top priority for me. The advance premium tax credits were established by the Affordable Care Act, and thanks to the American Rescue Plan, more Alabamians can benefit from this tax credit. Prior to APRA, the consumers with household incomes above $400,000, 400% of the federal poverty line were excluded from qualifying for these tax credits. But in 2023, almost 240,000 Alabamians enrolled in the marketplace health plans received the tax credit. This means that more citizens in my home state, which did not expand Medicaid, can afford health care. This is really unprecedented and necessary in states that did not expand Medicaid. So my question to you, Mr. Secretary, is with the advanced premium tax credits being vital to reducing the coverage gap, is your agency committed to working with Congress to expand and extend this subsidy expansion beyond the 2025 timeframe?
Congressman, that's a priority of the president's, yes.
Absolutely. I also remain committed to supporting the hospitals in my district. I applaud the Biden-Harris administration for the new option available to support rural hospitals through rural emergency hospital conversions. Just Monday, I spoke about the challenges of access to emergency medical care in my district. Issues from hospital closures to low ground ambulance reimbursement rates have really caused a problem all across this nation, and it was just exacerbated during the COVID-19 crisis. So, Dr. Becerra, can you share how the new rural emergency hospital designation has been helping rural hospitals provide emergency care? And beyond the $5 million in technical assistance, how is your agency helping to expand this designation in communities across this country?
Congresswoman, the new designation, it becomes very important for rural emergency hospitals because it gives them enhanced support. We know that if some of these facilities are going to survive, we're going to have to do something differently because they provide that critical care, and it's oftentimes very expensive care, and it's not something that a facility can rely upon having at all times. So it's a very difficult financial proposition for a lot of these facilities. We're hoping that this new designation, rural emergency hospital, will help them survive in a place where if they were to go, then families would really be in a hurt.
Not just families, whole communities really depend upon these hospitals. So I wanted to say hats off on this designation and do everything you can to try to expand that. Thank you. I yield back the balance of my time.
For that.
Thank you, Chairman Smith, and thank you, Mr. Secretary, for being here today. West Virginia has the highest mortality rate in the country for patients with kidney disease. I have focused much of my energy on the healthcare space on advocating with patients who have chronic kidney disease, ESRD, and I'm glad to be able to discuss these issues with you in the past. Last year, I led a letter with Congressman Blumenauer about the need for a pediatric ESRD modifier within the ESRD payment bundle, and I was very pleased when your agency took our advice and created one. I'm excited to see how this improves child care or children's care with ESRD. I also led a letter with Congresswoman Del Bene about the need for Medicare coverage of home dialysis for patients with acute kidney injury. Many patients with AKI are at the beginning of their kidney disease journey, and studies show that almost 50% of the patients with AKI never regain kidney function. Ensuring that these patients have access to home dialysis from the start is critical to helping them remain on home dialysis down the road if they do develop ESRD. Just last week, this committee heard a powerful testimony from a home dialysis patient about the absolute life-changing potential of home dialysis. For these reasons, I'm concerned by CMS's decision not to allow home dialysis for patients with AKI, which does not seem aligned with HHS's overall goal of increasing home dialysis uptake. All patients, including those with AKI, deserve the opportunity to decide, along with their clinical team, what dialysis modality is right for them. How are you working to ensure that CMS policies around AKI patients are aligned with HHS's overall goal of increasing home dialysis?
Congresswoman, thank you for the question. And by the way, thank you for your deep work on this issue because for many folks, and it's not a large community, this is life and death. And so thank you for the work that you're doing. We're talking about, we have to make sure that when we're extending access to some of these services through the Medicare or Medicaid programs, that we do it right because taxpayer dollars are involved. We have to make sure that we're focusing correctly. On this particular issue, we've been taking comment from the AKI community, and we will continue to do so. I will take back your comments today to our folks at CMS so we can follow up with your team if you'd like. We're not done, and this is an issue I know you're not going to stop working on, and we'll try to get there because what I think we all understand is that at the end of the day, the quicker and better we get services to these families, the less it's going to cost taxpayers.
And I do appreciate your commitment to kidney disease patients, and I thank you for working with me. In West Virginia, about half of Medicare beneficiaries receive coverage through Medicare Advantage. Your department recently cleared a CMS rule that is waiting for White House approval that would overhaul the Medicare Advantage enrollment process. This committee's been engaged on this issue. 14 members, including myself, sent you a letter on January 12th on the proposed rule. Like you, we are concerned about bad actors and aggressive marketing practices that cause headaches for seniors. We also believe seniors need resources to decide which plan to enroll in, but your proposal would limit resources in the enrollment market for everyone, not just bad actors. Would you commit to me that CMS will not reduce enrollment resources nor limit the ability of agents and brokers to help beneficiaries find Medicare Advantage plans that do fit their needs the best?
Congresswoman, let me commit to you to work with you on that issue. Now, one of the concerns we have is that we want to make sure that people are steered to the plans and services they need, and we want to make sure that at the end, it is in the benefit of a patient that they end up in a particular type of plan or service. So more than willing to work with you to address that, because I think you and I both have the patient's interest most in mind.
Thank you. Mr. Chairman, I yield back my time.
Thank you.
Mr. Leader, Madam Chair, Mr. Vice Chair, or Mr. Co-Chair, and to the members, it is first great to see you here. Thank you for doing this hearing. Thank you for giving witnesses an opportunity to speak the truth to what is occurring in America. And most especially, thank you to the witnesses for being willing to speak truth to what's going on in America. Much is happening in the world of healthcare. While President Biden has worked to expand access to healthcare, take, for example, the record number of Americans who have insurance today, more than 300 million, never before seen in this country, who now have access to a doctor or can take their child to a doctor and to a hospital and no longer worry if they'll go bankrupt as a result of doing so. While he is doing that, some places are restricting care, taking away rights and freedoms to the care Americans need. Right now, 23 million women of childbearing age live in states with abortion bans, including 4 million Floridians who are here today trying to make sense of yesterday's Supreme Court decision. It is important to hold this field hearing here in Broward County because the people of Florida know firsthand what it's like to have their rights limited. People like Deborah Dorbert and Sandra Elidor, who courageously shared their powerful, painful stories. It is important to be here today because we know that women and doctors are facing risks and threats to their life and well-being. That a 10-year-old rape victim must leave her home and her state of Ohio to receive the abortion care she needs. That a 13-year-old rape victim in Mississippi starts the 7th grade as a mom because she didn't get care when she needed it. That doctors, like my wife, Carolina, an OBGYN who specializes in high-risk pregnancies, are being forced to weigh legal opinions before rendering their medical opinions. That the 10 states with the highest maternal mortality rate have enacted abortion restrictions, leaving more women in deserts of care as providers are making the difficult decision to uproot their families and move to other states. That the medical students who are choosing not to establish their practice in states, sometimes their home states, that attack reproductive rights in healthcare, are perhaps now witnessing women who are going to have access to even less care in those states. And that our daughters, my 3 daughters, have fewer rights today than their mothers had. Today we're seeing extremists push the boundaries of how far they can go to regulate reproductive rights. In Alabama, they went after in vitro fertilization. Is contraception care next? Poet Robert Frost once said, "How many things have to happen to you before something occurs to you?" How many things have to happen to Miss Dorbert, Miss Elidor, before something occurs to us? President Biden, Vice President Harris, each and every one of you, we've all been working across government to expand rights and push back against these deeply unpopular and dangerous restrictions. We're protecting an American's right to privacy as a patient, but also as a provider. We've increased access to contraception through the marketplace under the Affordable Care Act and under Medicaid. Women now have access to the first over-the-counter birth control pill. And we are right now in the Supreme Court defending a woman's access to medication abortion. It has never been more important than today to take action to protect our rights and freedoms as Americans, especially our rights and freedoms to care for our own bodies. Just last week, I was at an event with Governor Gretchen Whitmer in Michigan, a state that passed laws to protect IVF and to decriminalize surrogacy, and where contraception and abortion access are enshrined in the state's constitution. Even where these rights are protected, people are scared, and I know, Congressman Kildee, you can attest to that back in your home state. I am grateful for Leaders Jeffries and all of your congressional leadership to restore women's rights and freedoms to the health care they need. but I am most grateful and proud for the courageous actions of our witnesses today. Their stories, their willingness to share their personal, private, painful experiences will lead the fight to restore our rights and freedoms to the care we each need. Madam Chair, women in America should not be living in medical apartheid in this country. We all have important work to do. Thank you for letting me be part of that.
Thank you, Mr. Secretary, for being here. Mr. Secretary, if the mother is healthy and the baby is healthy, do you really support abortion of the baby up to the moment of birth?
Senator, let me make sure, to the moment of birth, you're saying after gestation, the 40 weeks?
You know what I'm saying, Mr. Secretary.
Well,
let's suppose it's the day before the due date, and the baby is fully formed, and the baby's healthy, and the mother is healthy. Do you support aborting the right to abort the baby then?
I've heard no one say that. I think everyone has said, those who support reproductive rights have said, support Roe versus Wade.
You said it in 2020 in a press release. This is what you said. You said, quote, "No government, state or federal, has the right to make decisions for a woman about her body or her health care," end quote. Your words, not mine.
Good words.
So let me ask you again. Up to the moment of birth, if the mother's healthy and the baby's healthy, do you believe that there should be the right to abort that baby up to the moment of birth?
Again, I'll give you the answer. I have always supported Roe v. Wade, which does not do what you've just said, and I know of no one who is proposing or advocating what you've just announced. And I would hope that what you would recognize is that that should not stop a woman from having the right to decide for herself, with the consultation of her physician, what she should do.
Would you support making it illegal to abort a baby if the mother's healthy and the baby is healthy on the day before that baby is scheduled to be born?
I certainly would support the reestablishment of Roe versus Wade.
Okay. So you think that there are restrictions that the state, federal or state, as the case may be, can place on abortion?
Senator, if you talk to any woman, she'll tell you that she uses common sense in making her decisions.
Do you think that the state or the federal government in the third trimester of a pregnancy has the right to impose limitations, moral and legal right to impose limitations on an abortion? I think that's a yes or no.
I would certainly say that Roe v. Wade answered those questions. We defend and support Roe versus Wade.
Roe v. Wade has been overturned. I want your answer. Do you support restrictions by the federal or the state government on the right to an abortion in the third trimester?
And my answer is clear, that if we establish Roe versus Wade, we get back to a system that gives women protection.
Do you support restrictions to the right to an abortion in the third trimester? Why are you dodging the question?
I'm not. I'm just saying. I'm telling you where I am. I am.
Tell me. Do you support restrictions in the third trimester?
I have
if
personally.
If the mother's healthy and the baby's healthy.
Yeah. And Senator, let me try to make sure I answer this. Personally, as you mentioned, I've been quoted on a number of occasions before I became secretary. I support a woman's right to make a decision about her body.
But do you support restrictions in the third trimester? I just asked, why are you embarrassed to answer?
Because I believe in Roe versus Wade, and I think everyone recognizes that
that
law.
Roe v. Wade?
I do.
Roe v. Wade allowed for restrictions in the third trimester.
Then you have your answer.
Do you support restrictions in the third trimester?
If Roe versus Wade is as you described, then
why are you scared to answer the question?
I'm not afraid to answer. I'm
asking. Are you worried you're going to get in trouble with people, with your colleagues?
No,
who
not at all.
Abortion up to the moment of birth?
Not at all.
Then why won't you answer the question?
Because, Senator, I think I've given you the answer that makes the most sense. Roe versus Wade worked for some 50 years.
Do you support restrictions in the third trimester on the right to abortion? It's real simple. You're the secretary of a department of the United States of America. Yeah. Do you support them or do you oppose them?
My answer is pretty simple. We will defend
Roe versus Wade.
You
don't want to answer it, do you?
I've answered.
You know why you don't want to answer? because you and your colleagues believe that a child has no rights, even a fully developed child. You know that?
You can say that.
And I know.
I know where I am. I will continue
Okay,
to
let me
defend a
ask you
woman's
for a
right.
final time. I think this is number 5.
It's not gonna make any difference, but go ahead.
Yeah, well, if you want to choose to not answer it, that's up to you.
I'm not denying anything.
Let me phrase it another way. What restrictions do you support in the 3rd trimester to the right to an abortion? Tell me what restrictions.
If you read the Roe versus Wade decision, it'll answer your question.
Why don't you just answer it for me?
I did. Roe versus Wade
What
established the
restrictions
protection.
do you support on the right to an abortion in the 3rd trimester? You
Roe versus
personally.
Wade. Roe versus Wade.
Okay. Roe versus Wade doesn't say what restrictions. Roe versus Wade just says the state and the federal government have the right to impose restrictions. I'm asking you, what restrictions you support? For example, if the mother and the baby are healthy, and we're a week before birth, and the parents change their mind and say, we don't want a boy, we want a girl, abort the baby who happens to be a girl, would you support that right?
I know no one who would go as far as what you're indicating,
Well, then why wouldn't you say you would oppose it?
because I'm telling you where I stand.
No,
And I
you're
have
not.
been very
You're
clear on that
dodging
for a
and
long
bobbing
time.
and weaving and flip-flopping like a
Let me
bank
stand as still
catfish.
as you'd like. Senator, I won't move, and
Let me
I'll just
ask
move
you
my
again.
lips.
If a week before birth, baby healthy, mother healthy, would you support the right to an abortion because the parents dislike the gender of the baby? Yes or no?
Yeah, as I said, a woman should have the right
But you
to make the
haven't said,
decisions
Mr.
about her body.
Secretary, you won't answer my question. Would you support that?
As I said, I'm going to do everything I can to support a woman's right to make the
Would you
decisions about
support
her
what I
body.
just described? You're not going to answer me, are you? I don't understand why you're scared to answer me.
I'm not afraid to answer your question. I've answered it over and
You're
over.
scared to
Thank you,
death
Senator
to
Kennedy.
answer me. I just find that appalling. You're the secretary of the department.
Thank you, Senator Kennedy.
Can we have a second round, Madam Chair?
I am just going to start a second round right now. You just hang in here. We're going to start a second round of questioning. We will certainly accommodate any senators who have not yet had their first round who appear. As we know, we have several competing subcommittee hearings at this juncture. Capito.
Thank you. Yes, Secretary Becerra, I want to talk about rural health because I mentioned in my opening statement a $12 million. It appears as though it's $12 million lower. I understand that our bill funded it at $364.6 million, which is rural outreach, rural hospital flexibility, and other things. The request is for $352, which is lower, 12.2 lower than what we actually funded this for. I understand also that the budget release and then the timing of the actual passing of the budget were almost at the exact same time. Might not have been ideal for you. What would you say about that? Healthcare delivery systems in rural America are still very difficult and underfunded. We have the lowest life expectancies in rural America. What's your response to that?
Senator, you actually touched on probably the most important aspect of my answer, and that is that our budget was being framed at a time when we had no idea what the 2024 budget would look like, and because of the constraints on where we could go, we had to make sure we tried to be consistent with what might come out. So we are more than willing to work with you on the kinds of investments we would make in healthcare generally, but more specifically with regard to rural health. You will find that there are specific investments in rural health, especially in the area of substance use disorders, in trying to keep hospitals afloat that we can work on to build on, because I think you're right. There's no doubt that it's tougher if you're in a rural community to find a healthcare facility near you. And so we'll do everything we can to try to keep not just them sustained, but also to have them thrive.
Well, we'll work on that and understanding the circumstances of when your budget came out.
Yeah.
I did have a lot of questions on drug abuse and SAMHSA, prevention and harm reduction. Here's the discouraging thing. These statistics are not coming down. I mean, the overdose statistics, I heard on the radio the other day that the statistics in DC alone were up, I don't know, 20, 30% deaths resulting from overdose. We don't have, I don't think we have the statistics quite yet for this past year. We've got a flow of fentanyl coming up through the southern border. We got to do better here. I mean, we are losing a generation. And I understand in your last answer some of the areas, you know, fentanyl strips and naloxone, but that's still just treating somebody who's already in heavy addiction. I mean, I think the prevention aspects of it have not gotten to the younger children as much as they should. We got to start kindergarten. What's your response to that?
With you, completely with you on that. Here's the difficulty. As you know, at the federal level, the Department of Health and Human Services, we don't administer these programs. We work with the states. The states are the ones that have control over healthcare and this aspect of healthcare. What we do is essentially provide them with more resources, or we give them some support and flexibility in doing what they can with the dollars that we give them. We are more than willing to work with the states to increase their capacities. They need more capacity.
What states are doing it? I mean, I'm sure you're looking at what the innovative programs of a state that might be able to be shared nationally. I'm sure that's best practices that you're pursuing here on the prevention side.
Oregon, as you know, had an issue with increasing drug use. And what they have done, when I've been to visit, I've seen how they are incorporating young people into their programs to try to get them to become essentially peer support, so that peer-to-peer kids are hearing from someone who can help them out. Obviously getting the adult and professional help as well, but we need to try to reach young people, to your point, before they become users. And so there's where we got to figure out a way to capture them quickly. And I think Oregon is doing a pretty good job of trying to use young folks to help them approach that cohort.
Well, coming from a state that doesn't have legalization of recreational marijuana, I think that's an example of where some of the issues may be. I know there's a lot of people that believe that's a good thing to do. I personally am not one of them. Quickly, on the suicide prevention line, you've asked for a lot more money here. We've provided a fourfold increase in fiscal year 2023. You're requesting $100 million more for 2025. I'm wondering, can you give me a breakdown? You might not have that right now, but how is this breaking out to, is it going out the door to state and local crisis centers versus a contractor that's administering the system? I'd just like some more details on this request, given the sensitive nature of the program and the critical work they do.
Certainly, and we can follow up with your staff to give you more of the details, because those are out there. Most of the money helps sustain the state operations, the call centers that already existed. We essentially have buoyed them because we established backup call centers, because a lot of the states didn't have the capacity to deal with all the calls that might come in. We didn't want people waiting on the phone with a busy signal. Yeah. So we stood up all the backup call centers. We also made specialty lines. So, for example, if you're a veteran, there's a line that's specific for you. Those are the things that the federal dollars have really helped boost. We also helped create the text and chat feature, so that if you didn't want a phone call.
Is that online now, the text and chat feature?
Yeah, absolutely it is. Okay. Absolutely. It's available now for hearing impaired. Mm-hmm. It's available in some places, Spanish language. We're trying to make sure no one feels like they should not call. And now you hear that we're going to finally get to the point where we can make the 988 call work, so that wherever you are, whatever your area code is, you're going to get a professional where you happen to be, not based on your area code. It's working. The $600 million that is in the president's budget for 988 is absolutely going to save lives. We know that in the first 18 months of launching National 988, 1.5 million people reached out to us and said, help. We were able to answer.
Thank you.
Thank you, Mr. Secretary. We're now going to begin our questions, and I'll start by recognizing myself. Secretary Becerra, our communities continue to struggle with the opioid crisis. I cited the statistics in my opening statement, but as a reminder, in 2022, 108,000 Americans died from a drug overdose, a record high. We've seen the opioid epidemic transform over the years. When I first was elected to the Senate, it was primarily an epidemic of prescribed opioids. Then we saw some shift to use of heroin. But now with the emergence of synthetic opioids like fentanyl, we are seeing an increase in deaths among individuals, particularly youth, who don't even know that they're taking fentanyl. With fentanyl, one pill can kill. How does the HHS budget address the devastation that we're seeing from opioid-related deaths in our communities?
Madam Chair, perhaps the most important thing is that we recognize, as you just mentioned, that it's a shifting landscape. And so some $9 billion that the President's budget has to address drug overdose and the opioid addiction are really targeted on things like fentanyl, on trying to make sure that we give states the capacity to help their young populations avoid overdose. And it makes sure that we're providing the harm reduction to make sure that people don't accidentally kill themselves when they think they're doing something that is recreational. And so of the $9 billion, it should not surprise you that more than $1.5 billion is going to state opioid resource grants that will help states decide how they can best tackle the opioid crisis, especially among children. SAMHSA, our agency that administers most of our substance use and mental health programs, is going to receive about $4.5 billion of the $9 billion because they're the ones that work closely with state mental health programs throughout the country. And so it is letting the states have the flexibility and the resources to tackle this crisis.
I want to dig a little bit deeper here because, as I mentioned, many times teens will take a pill that they got from a friend or got online, unaware that it's laced with fentanyl. I've heard from so many parents in the state of Wisconsin who have lost a child to fentanyl poisoning. The budget proposes substantial funding for treatment programs, which is certainly incredibly important for tackling this crisis. But how is HHS working to prevent young adults from using, and children, from using drugs and making these deadly mistakes in the first place?
Madam Chair, we did something at the federal level that had not been done before. We stopped relying on stigma to drive our federal policy. So today, we actually support programs that offer fentanyl strips to individuals so they can find out if the drug they might be taking is laced with fentanyl. That way, they don't kill themselves. We also made naloxone far more available. So today, you can have access to naloxone in public places so that if you see someone who's overdosed, there's a great chance that you might save their life by administering naloxone for them. And so we're also trying to make sure that local communities understand what they can do to make that naloxone more available. So whether it is naloxone, fentanyl strips, clean syringes, we're now using the evidence-based programs that have shown success to drive our policies.
Thank you. I want to shift in 2018, I worked to pass legislation requiring HRSA to identify areas with critical shortages of maternity health care professionals so that we would have evidence to support increased investments in areas where women and families need providers the most. Unfortunately, the number of maternity care deserts nationwide continues to increase, and over 2 million women live in a county without a hospital, birth center, or obstetrics provider. The decision overturning Roe has made this problem worse, as states with abortion bans have seen a drop in applicants for obstetrics and gynecology residencies. Given our nation's unacceptably high rates of maternal mortality, we must do everything we can to target investment to increase access to care and support the maternal health care workforce. Secretary Becerra, what is HHS doing to build the workforce pipeline and better support our maternal care professionals?
Madam Chair, there are about $8 billion that are dedicated in this budget to trying to address maternal health. Much of it is focused specifically about $400 million is focused specifically on trying to tackle the maternal mortality and morbidity rates that we see in some of our communities, especially the Black and Native American communities. We're trying to make sure that we get to women before there's any chance that they would have complications in their pregnancy. And as you know, as a result of our efforts on Medicaid and your support, we now are able to offer a woman and her baby not just 60 days of maternal health and child care after delivery, not just 60 days, but 365 days of care for mom and baby, so they can make sure they're going to start with a fruitful life.
Thank you. Senator, thank you. Senator Britt.
Thank you, Madam Chair. I appreciate it. Mr. Secretary, thank you for being here today. Obviously, we are here to talk about budgets. I've heard a lot of talk about abortion today. And in particular, when I'm looking at your budget, obviously, there was no mention of the Hyde Amendment to be in there. So I want to confirm that you believe taxpayer dollars should go to be able to fund abortions.
Senator, thanks for the question. The president has made it clear he wants to remove the Hyde Amendment from the budget proposals, and that's what he's done.
Okay, so when we're talking about that, Senator Kennedy asked you a question, and you all were talking about, your answer kept being Roe v. Wade, and I want that to be the law of the land. So let's just stipulate that your hypothetical is the truth. And so if Roe v. Wade were the law of the land, and a woman wanted to take the life of her child the day before her child was due, or the day after her child was due, then you support her ability to choose to do that. Is that correct?
Senator, I will say what I said to
Yeah, no. I've stipulated Roe v. Wade is law of the land. So there's 7 states in this country and the District of Columbia that allow you to take the life of a child the moment before a child is born. So clearly you support a woman's right to choose to do that.
Senator, the example you gave is fiction, as far as I know. Can you give me a particular example?
If it actually is fiction, then why not say no? That's out of the realm of possibility. That no woman would think to be able to do that. Because the truth is if you say that taxpayer dollars should go to fund abortions, then you're saying that my taxpayer dollars should go to fund something like that. And if that's unthinkable, then why don't you just say it's unthinkable? And in fact, then we can just take it off the table and not allow that to be legal. Because the truth is, when you do that, I'm going to read this to you. In particular, when these abortions occur, the gruesome surgical techniques involve crushing, dismembering, and removal of the fetal body. So they actually deliver the baby breech and then have to put scissors up the baby's neck, open it up, and then suck out the brain so that they're able to get the head through the birth canal. And so then there's also the opportunity to go in and actually put a needle in that child's heart and kill that child. If that child is then delivered alive, do you believe that that child on that table, that we should be able to save that child? Or do you believe that our taxpayer dollars give this woman the right to say, don't save my child? I just think when we're talking about this and you're saying so boldly, no taxpayer dollars go, and you actually won't answer the question when it comes to Roe v. Wade. And I'm saying I'll stipulate that your hypothetical is the case. There are still 7 states in this country and the District of Columbia that allow us to do that. We're one of like 7 nations that allow that to take place on our soil. 2 of the other nations are North Korea and China. And I just believe when we're talking about budgets, I want you to know where I'm coming from and why I believe wholeheartedly with every ounce of me that we have to preserve the Hyde Amendment. And on that note, moving to maternal health. When we look at this, Alabama knows this issue all too well when it comes to maternal mortality and the crisis we have in this country. Nationally, the number of reported pregnancies related to deaths in the United States increased from 7.2 deaths per 100 live births in 1987 to 17.6 deaths per 100,000 live births in 2019. We are moving in the wrong direction. Obviously, with more resources and technology and availability, we should be able to turn this in the opposite direction. The resources made available by HRSA's Title V Maternal and Child Health Services Block Grant are essential to reducing maternal mortality rates and providing better access to quality health care and services. Most of this vital funding goes to states to help them address the priority health needs in their state. Mr. Secretary, with this happening, why does your budget request actually deduce and take funding away from the Title V Maternal and Child Health Services grants that actually go to the states?
Senator, we actually increase funding for maternal health. We have some $2 billion in our budget for maternal health.
But the actual grants, though, went down. The number for the grants went down.
We'd have to take a look at that because we have actually continued to provide support. And for maternal mortality and morbidity programs, we are doing more. We have some $360+ million in this budget to address the maternal mortality and morbidity rate.
Well, I'd like to actually work with you on that because obviously Alabama, this is a significant challenge. We have the highest maternal mortality rate in the nation. My reading of your budget is that number actually goes down even though your overall budget goes up. So let's have a conversation about that because we need that money in the states. It looks like you have a project-driven basis where a lot of that money is going. These grants help us, particularly in our rural communities, make sure that we can get the care to these women that they need. And so I'd like to, if you will commit to working with me on taking a look at that and making sure that states have the money they need to make an impact.
I commit to follow up with you on that.
Thank you.
Thank you.
Secretary, how many employees does the Department of Health and Human Services have?
Roughly 90,000, Senator.
And your testimony is that half are back in the office full-time and half aren't?
That the OMB guidance essentially calls for a process where we can have physically.
I understand the OMB guidance.
Yeah.
Is it your testimony that half are back of those 90,000 are back in the office full-time and half aren't?
My testimony is that we are in compliance with the OMB guidance on how we handle the workforce.
Is it your testimony that half of the 90,000 are back in the office full-time and half aren't?
Again, my testimony is that we are complying with the OMB guidance. We can make sure you know what the guidance is so you know what we're complying with.
Is. I'm just trying to understand how you've implemented it. What percentage of your employees are back in the office full-time?
I could try to get that information back to you because we have a mix. I came to talk about the budget, but I can try to get back to you.
You don't have any idea how many of your 90,000 people are back in the office full-time?
I can tell you the types of mix of employment that we have.
Yeah, but that's what I'm asking. You got 90,000 employees.
That's right.
How many are back in the office full-time? What percentage?
And as I said, this is a budget hearing. I came to talk about the budget.
Yeah, but you don't know. You don't know how many of your people are back in the office full-time.
I can get back to you, Senator. I could get you as best I can a response to that particular question, but I came here to talk about the president's budget.
Why is Medicare Advantage so popular?
I'm sorry?
Why is Medicare Advantage so popular?
Why is Medicare Advantage so popular? You'll have to help me with what do you mean by that?
You don't know what Medicare Advantage is?
I absolutely know what Medicare Advantage is.
Yeah,
when
why
you
is
say
it
popular,
so popular?
Is there some survey that you're talking about, or what?
Yeah, about I deal in numbers.
Okay.
About half of our seniors who qualify for Medicare choose Medicare Advantage, don't they?
That's actually more than half.
Okay. And why is that? That makes it popular, right?
Medicare Advantage today, this is the first year that we've seen more individuals select plans in the Medicare Advantage.
Why is it so popular?
Again, when you say popular, I've heard many Medicare beneficiaries who are complaining about being stuck in a Medicare Advantage plan.
Is it because the average person, average senior on Medicare Advantage pays $2,400 less in premiums on Medicare Advantage as opposed to traditional Medicare, plus gets more services like dental and vision in many respects? Could that have something to do with it, you think?
I'm assuming that you've seen some polling or surveys that give you some of those answers. I've heard many, many things, both good and bad, about Medicare
I've seen the
Advantage.
facts. Are you telling me that people on Medicare Advantage don't save money in premiums and copays over traditional Medicare?
I have no doubt that some do. But I wouldn't have no doubt that some pay more.
I'm talking about the average.
Again, I don't know what numbers you're referring to, but I'm
looking
more than willing to
at the
discuss
numbers
those with
that your
you.
department puts out.
Okay, then what are those numbers, Senator?
The numbers say that the average person on
I'm asking you if
Medicare
you could show me the
Advantage
numbers.
pays $2,400 less in premiums and copays and gets extra benefits. Is that right?
My understanding is they're also restricted in the doctors they have access to, the hospitals they have access to.
You're trying to destroy Medicare Advantage, aren't you?
We've actually provided an increase in funding for Medicare Advantage.
No, you haven't.
Sure we have.
You cut funding in 2023 by 1.1%.
That's absolutely incorrect.
And you next year you're proposing a 0.16% cut. And in fact, the Medicare.
That's absolutely incorrect.
That's not incorrect.
That's absolutely incorrect.
And in fact, the Medicare trustees.
Senator, saying it doesn't make it true.
The Medicare trustees said that you've lost your mind. My words, not theirs.
Senator, saying something doesn't make it true. The dollar amount that we're giving to health insurance companies under Medicare Advantage
Are you telling
has
me today
increased.
that you have not cut payments to insurers in Medicare Advantage last year by 1.1%?
We are giving Medicare Advantage. Health insurance companies under Medicare Advantage are receiving more money this year than they got last year for Medicare.
You cut them by 1.1%.
That's not a cut, Senator.
And you're proposing another 0.1% cut. In fact, I mean, you and President Biden say you will not touch a hair on the head of Medicare, but you're trying to destroy Medicare Advantage.
Actually, the president's budget extends the life of Medicare beyond your and my lifetime.
Look at the numbers. In 2023, under your watch, Medicare Advantage patients saw on average a 12% increase in deductible and a 5%
The insurance companies did that, not us, Senator.
And Florida and Utah and Wyoming saw their premiums go up 50%.
Okay, Senator, blame the insurance companies, not us.
Because you cut the payments
Senator,
to the
we did
insurance
not cut.
companies to drive them to traditional Medicare where you can control them better. Isn't that the case?
The fiction you're propounding doesn't resolve the issue that we have every year so far under this administration increased the funding for health insurance companies who offer these managed care Medicare Advantage plans.
Thank you, Senator Kennedy. Now I'll recognize Senator Hyde-Smith.
Thank you, Madam Chair, for your indulgence.
Senator Manchin.
Thank you, Madam Chairman. Secretary, I was pleased to see the department's finalized the rule implementing the Jessica Grubbs Legacy Act we worked on for so long. The law reduces barriers for treating persons with substance abuse disorder by aligning the privacy laws governing their records with HIPAA, the law which governs all other health privacy records. This has allowed for medical professionals to access vital information they need to properly coordinate the care. In 2018, Congress passed a separate law in honor of Jessie Grubbs' life, just called Jessie's Law. This requires HHS to develop best practices standards for hospitals and doctors to display a patient's history of opioid disorder when the patient provides that information. With the implementation of the Legacy Act, it's now time to fully implement Jessie's Law. So the department has finalized a rule on confidentiality of substance use disorder patient records. When will it be releasing best practices for displaying opiate use disorder in patient records?
Senator, first, thank you for the work you've done, because I don't think people recognize that in many cases, because of this, I don't want to call it an excuse, because of the difficulties with privacy laws, HIPAA privacy laws, a lot of essential information about a patient wasn't getting to the providers, and they were making the wrong decisions, especially when it related to drug addiction. And so the work that you and your colleagues have done has really helped.
Well, Senator Capito and I worked on, but we know the family very well. It was so horrifying. This young lady had problems, and something stemmed from when she was in college, but then she was trying to get herself clean. She started running and being competitive.
Yep.
And she and her parents, who an attorney and her mother's a educator, both went with her to the hospital and says, please identify and mark my record showing it, and they forgot to do it.
Yep. And so what we're doing is we're trying to tackle that HIPAA privacy hurdle so that it doesn't become the reason the information isn't fully there. But you can understand how important it is to maintain privacy.
Oh, no, we know that. But now that we've done everything, we've gone through every hoop possible.
Yep.
When will you all be doing, when can we expect it to finally?
We are now working with providers. We've developed a training module so that they understand how this can work, how they can be consistent with privacy laws, yet still include the information. So a lot of it's going to be, and we can use your help, because we need providers to start understanding what the new rules are. They're going to say to you, oh, no, we can't do that because of HIPAA privacy. We want them to understand, oh, no.
Well, I think
Jesse's
the
law
law is
makes it
very
different.
clear. Basically, it says that the patient himself and the guardians have to have permission and give you permission to do it.
Yeah.
So we thought we crossed every hurdle, crossed every T and dotted every I. It's just time to implement it. So I would implore you to
we're doing it.
Get your staff moving on this one here. We waited a long time for it.
And Senator, I'm just pointing out, we need the help of the providers to make sure that they're getting their personnel to understand the new rules.
Okay.
Yeah.
Well, I think the quicker you put them out, the quicker they'll understand them.
Absolutely.
The Health Resources and Service Administration administers grants and programs that are critical to rural health centers and clinics and hospitals. Your budget requests a $2 billion increase to this agency to carry out these programs. However, many areas of West Virginia remain unable to access these resources. West Virginia is the only state that lies completely within the Appalachian Mountain region. The United States Department of Agricultural, Economic Research Services recognize the unique topography. We're the most rugged mountainous state, east of the Mississippi. And a recent report on what we call rugged terrain. That's all been identified and how we've been classified. The report found that almost 81% of West Virginians live in a rugged area. That's compared to just 11.7% of the entire United States population. The fiscal year 2024 bill included language for HRSA to review this report to update their rural definition to better capture the uniqueness of Appalachia. Can you provide an update on this review and a timeline for when we're going to see some results so they can qualify for the needed funds they need for rural health care?
So we're not waiting. As you know, Senator, we are moving forward with a new classification, this new classification for hospitals that don't meet the critical access care definition, so that a lot of those facilities that are teetering don't go under, so they can get some additional funding. I was mentioning to Senator Capito some of the work we're doing to make further investments in behavioral health, especially in substance use. But we are absolutely prepared to work with you as you all give us some guidance about how to get into these communities that are very rural to make sure we're being as constructive as possible. We will work with the states as much as we can because they understand better what their state needs in terms of the rural health facilities. But we're trying to make sure that these new changes that you helped us put forward will help some of the states that have large rural communities address the concerns of individuals a lot faster.
Well, sir, I thank you for your service. I just want to say again on Jesse's law, that has been a long time in coming, okay? And the families have they're hanging on needles and pins, just waiting for it to be completed. They want to save lives, and they don't want anyone to go through what they've gone through. And on the rural classification, if you want to know why the divide's becoming bigger and bigger, rural areas have been left behind. The money has not gone appropriately for the challenges they have, and that's so important.
Yeah.
Thank you, sir.
Thank you.
Next for a second round, we have Senator Capito.
Thank you. Thank you again, Mr. Secretary. We authorized ARPA-H it was funded at $1.5 billion, and you're requesting flat funding for ARPA-H. For those who don't know what that is, it is intended to fund high-risk, high-reward research to find biomedical and health breakthroughs. It's fashioned after DARPA, which is done in the defense arena. And biomedical research has long enjoyed bipartisan support, of which mine is obviously part of that support. I have heard some concerns about either repetitive or deflecting or competitive, maybe, research that could be that is conducted at NIH as opposed to ARPA-H. So ARPA-H reports to you, and NIH is a separate entity. And I would like to know, can you tell me how you plan to make sure that the research activities of ARPA-H and NIH remain distinct? And I mean, I don't think they should be siloed because one can feed to the other, but to avoid that duplication.
Senator, so just to be sure we're clear, both both NIH and ARPA-H
Right.
report to me. But ARPA-H, which is very similar in its research mission, some said should have been housed within NIH. What we did was we kept it separate because it's supposed to be a much more nimble operation. The difference, basic research is done at NIH. It may take 10 to 15 years before we see some novel discovery come out of the NIH research. ARPA-H says in 2 years, no more than perhaps 3 years, you're on the ground with this novel approach. And so ARPA-H was, as you mentioned with DARPA, with the Department of Defense, to help us get those innovators who are having difficulty finding enough money because it's a small idea, actually get them off the ground. And so this is where that cutting-edge research will quickly get moving. And so ARPA-H has actually had some great successes. And as I mentioned to you in our conversation, I'd love to make sure that if you'd like, we let you know some of the projects that are underway at ARPA-H.
Yeah, so I understand your longest project so far is 9 months old. I mean, that's because this is a new program.
Correct.
You have the ability to withdraw funding at any, but I don't know how many projects you have going, 9 to 10 maybe going right now. You have the ability to withdraw funding if it looks like these things are, that's some of the hardest things to do, as we know.
Yes.
We serve together. Have you withdrawn any funding from any of your projects that are moving so far? Is it too early to tell?
We're only 9 months in, and so usually 2 to 3 years, but you're right. These program managers are hired with the understanding 2 or 3 years, and that's it.
And so do you have a firm and affirmative oversight plan to make sure that you're redirecting funds if somebody's got an idea that's not going to work, let's move on, and you have that oversight plan already in place?
Yeah, Dr. Wegerson, who, by the way, came from DARPA, Dr. Wegerson understands that completely. It's in the design of the proposals. Everyone understands this is not going to be something that's living for a decade. It's either you hit it, you have success, or we're moving on.
Okay. I want to ask you about your return to work process. COVID's over. It's been over for over a year now. The White House Chief of Staff, Jeff Zients, and I excuse him if I pronounce his name incorrectly, encouraged agencies through an order in May 11, 2023, to bring back in-person work policies. What is your in-person work requirement?
We are complying with the OMB guidance that was put out there.
Well, what is that? I don't know what that is.
It essentially says make sure that your work plans with all of your employees have a mix. So some are full-time, some are have some telework ability. And so it's having the mix, and what you're traditionally trying to do is have at least half of your workforce in at all times.
Okay, so approximately what percentage would you say is back in the office 5 days a week?
As I said, we're complying with the OMB guidance.
Well, I know.
So that means we're essentially there, but we're 90,000. We have people throughout the country. We have a mix. Unlike other agencies, we have folks who are medical
Have you
providers.
negotiated any contracts or with the federal unions that say you have to be in 2 days every 2 weeks and a day is 6 hours?
Yeah, we've negotiated contracts with the unions to make sure that we're complying with the OMB guidance.
Well, I mean, are some of those like that? Because I know we're finding that in other agencies.
Yeah, for example, telework has been around for a long time, and so we may have made adjustments to the telework plans that we have, but what we have to do is because they're under an employee collective bargaining agreement, we have to discuss that with you.
So can we have your collective bargaining agreements? I mean, I'm sure they're public, so we could see what you've negotiated in certain areas. Because quite honestly, 4 days a week, a 2-week period, 6 hours is a day, most of America would begin laughing at that.
Right, and that's not something that you have for the 90,000 people in the workforce. But let me see what I can do as far as providing you some of that information.
All right, and then I think my time's up, so I'll let these guys go ahead. Thank you.
Thank you.
Good to see you, Mr. Secretary. Thank you for being here. In 2003, Congress established the Rural Community Hospital Demonstration Program to test an alternative payment model for rural hospitals that were facing certain financial constraints with the Medicare's Inpatient Prospective Patient Program, the IPPS. And Congress has extended the program several times, most recently in the Consolidated Appropriations Act of 2021. But Mississippi ranks among the states with the highest rate of hospital at-risk closings. This demonstration program could serve as a means to keep their rural hospital doors open to serve their communities in need of high-quality health care. However, CMS has not solicited applications since 2017, despite, as I understand it, there being a handful of open spots in the program. Do you believe this program has been helpful to rural hospitals facing closure, and we should extend the program when the time comes?
Senator, thank you for the question. The rural emergency hospital designation extended a lifeline to some of these facilities. It is absolutely essential that we give hospitals that are willing to stay open a chance to survive if the older version definition of how they could get reimbursed isn't working for them. So we look forward to working with you because we've got to figure out a way to keep some of these facilities open and operating.
Do you know about how many spots are currently open right now in the program?
I don't have that with me, but I can make sure my team follows up with you.
No problem. And can you commit to working with me to solicit applications for the program and find ways to help us keep these hospitals open?
Absolutely.
I talked to administrators this morning that have been in my office, and we are constantly battling this in Mississippi. You know, we're just putting out one fire after the other. Mississippi has consistently seen some of the poorest maternal health outcomes in the nation, made worse by high rates of chronic disease and limited access to specialty care for many mothers. And we've also led the nation in infant mortality, something that we're not proud of at all and very concerned about, but it's driven largely by a very high preterm birth rate stemming from lack of prenatal care. Access to maternity care in rural areas is a major challenge, and we are seeing a rapid expansion of OB deserts, that we refer to them as, across Mississippi. In some areas of my state, women are having to drive more than an hour for any kind of obstetric care. How can we work with you to improve outcomes for our mothers and babies in Mississippi?
Senator, because everything you've said I agree with regard to maternal health, and especially how it's impacting our Black and Native American communities. The most important thing is early access. And as you've mentioned, sometimes, especially because a state like Mississippi has a lot of rural communities, it's tough to have access. And so that's why it is so important to not allow any existing health facility to go under in rural America, because then the access becomes even more difficult. Telemedicine, telehealth is going to be very important for communities, families in rural America, because it means they can have access without having to do the physical travel. We'll continue to support that so long as Congress gives us the flexibilities to offer telehealth flexibilities. But the most important thing is access. And I will simply say here, many of the women who are having bad outcomes could have qualified for earlier care had they been eligible for Medicaid. And I think if we expand Medicaid in some of the states that haven't yet done it, about 1.5 million more Americans, many of them women who want to deliver a baby, would have access to early care and not wait until it's a difficult circumstance in the delivery.
Yeah, well, I appreciate your concern and your willingness to help toward this, because it truly is crucial. Mississippi's a large state. We don't have many people, but we're a large state.
Yes.
And we're scattered. And it is truly a hardship on so many mothers to actually get to that care. We have a lot of babies born in cars, sad to say. My time is out. Thank you.
All right. Just to give you a quick status update, we're hearing that there are at least 2 other members who are desperately trying to get into this hearing to ask you questions. I will entertain a 3rd round.
Lucky me.
Lucky you. And if they do not appear before the end of our 3rd round, we will let you go. So I want to focus for a moment on the Centers for Medicare and Medicaid Services, or CMS. This agency provides services for millions of Americans through Medicare, Medicaid, and CHIP. Wisconsin families and seniors rely on these programs, and I believe that we need to do everything that we can to ensure that they are working effectively to provide the care that our constituents deserve. Funding for program management at CMS was flat for almost a decade. Can you describe the negative impact that not investing in program management activities has on Wisconsin families and seniors and American families and seniors?
Senator, thank you for the question. I know everyone always focuses on what we do on the ground to help families, and that is absolutely what our governments, local, state, federal, have to do is be there for folks when they need us. The folks who are there when they need us are the folks who often get neglected when it comes time to providing budgetary authority. So we provide money, Congress provide, and I was here for 24 years as a member, so I remember those days. We'd always fund the program, but we would neglect or skimp on providing funding for the personnel. CMS is essentially in that strait. For the last 13 years, its budget actually has gone down. At the same time, its population that it serves, Medicare, Medicaid, CHIP, ACA, Marketplace, has gone up by over 40%. So it's going in totally opposite directions. Every year we're doing more. CMS is negotiating the drug pricing. CMS is helping states address the Medicaid redetermination so people don't lose their coverage. CMS is having to deal with all these determinations about whether Alzheimer's treatments or cancer treatments will get covered under Medicare. CMS is a workhorse, but it's not getting fed. The people that are doing all the work, unfortunately, are stressed. So anything we can do to ensure that we can continue to have good production would help. And by the way, I haven't even mentioned cybersecurity. CMS, when Change Health suffered that cyber attack, CMS, through Medicare and Medicaid, was there to make sure doctors and hospitals still got money, even though all the systems, electronic systems, had gone down. That was CMS.
You mentioned many of the functions that CMS participates in. Can you speak also to nursing home inspections?
Well, it's, I hate to say it publicly, but I think every American who has their loved one, their mom, their grandfather, their disabled brother in a nursing home expects that there's going to be quality care. One of the ways we ensure quality care is to do inspections, to do the surveys, to make sure that these facilities are providing real care to Americans that we love. Unfortunately, the resources that we have received, especially on the administrative side of the budget, don't allow us to do the surveys 100%. We did over 2/3 of the surveys that we needed to of the nursing homes throughout the country. The funding has continued to go down. I fear that we're going to continue to drop in the number of surveys of nursing homes that we're doing, which one of these days is going to result in some nursing home being in the news because some tragedy happens and it's a nursing home that we didn't have an opportunity to inspect. That should not happen. And if we had the resources, and it's a small drop in the bucket of all the money that you all provide CMS, that would help us make sure that nursing homes are safe.
Thank you. Senator Shaheen.
Excuse me. Thank you, Madam Chair and Ranking Member Capito. Secretary Becerra, thank you for being here today and for all of your work on a daily basis. I'm sorry I missed your opening remarks, but I very much appreciate you mentioning insulin and the need to address insulin affordability. And despite the efforts in the last year's legislation, the Inflation Reduction Act, to cap out-of-pocket costs for insulin for Medicare at $35 a person, we still see challenges with affordability for insulin. Can you speak to that and what we're seeing on the private market compared to Medicare now that we've capped the cost?
And Senator, I know despite many of your efforts to include the $35 cap on insulin for everyone in America, the bill ultimately had to get pared down to only provide it to the 66 million Americans who receive Medicare benefits. The president in his budget calls for extending that to everyone in America, not just those on Medicare. And what we're finding is that in some spaces, some of the manufacturers of insulin have said that they would reduce the cost to commercial private insurance plans to $35, but not everyone in America is experiencing the savings that comes from having access to insulin at $35 a month.
Well, thank you. And in fact, then we have companies like Novo Nordisk who said that they were going to reduce the cost for Levemir, and then now they've taken Levemir totally off the market after saying they were going to reduce the cost. So there's some disingenuousness in what we're hearing from some of the providers. And on a similar note, I've heard from constituents about ongoing shortages of insulin, Humalog and Novolog. We heard from Walter Chapman, who's a 70-year-old constituent in Dover, New Hampshire. He visited 3 different pharmacies. He called several others in surrounding towns before he could finally find his insulin in stock. And he wasn't calling small independent pharmacies. He was calling CVS, Walgreens, Walmart with big footprints. So what are we going to do to address these shortages, and how can we make it more transparent so people know what they're getting?
And this is where work is ongoing. We have a proposal that we've submitted to try to have more transparency in the pharmaceutical industry, because it is so difficult to know what's going on behind the curtain. There is no reason why insulin should be in shortage anywhere, because it's so easy to produce and so inexpensive to produce. But that's the game that's played. And that's why the president continues to want to get behind the curtain. That's why it's so indispensable that you gave us the authority by law to negotiate, to drive down the prices of some of the most expensive medicines under Medicare.
And in fact, we have legislation in the Senate, Senator Collins and I do, Senators Warnock and Kennedy, that would cap the cost, out-of-pocket costs for insulin, as well as dealing with availability. I hope that we will see leadership bring it to the floor this year, because I think we have the votes to pass it. On another note, as you know, Title X funding is critical to ensuring family planning providers can keep their doors open in states, particularly states like New Hampshire, where abortion remains legal, but where we have many small providers and we have state legislatures that are preventing those small providers from getting the funding they need. I appreciate Health and Human Services working with family planning providers in New Hampshire, but can you tell us what else you're thinking about in terms of helping keep those folks in business?
So most every time I travel across the country, I will visit a family planning program, because they are indispensable to so many families. They do more. Some people think all they do is provide care to women. They provide care to families, family planning. The president's budget, as you're probably aware, tries to boost funding under Title X, another $100 million, so we get back to where we used to be in some of the funding levels for these programs, to over $350 million. That's going to be important, because families are desperate for the kind of care that helps them have good outcomes in all of their family planning.
Well, that's right, and it's unfortunate that this is an issue that's become all about abortion, because the family planning providers in New Hampshire serve thousands of women. They provide well-check visits, they provide cancer screenings, they provide STD screenings, and without them, we would have so many people who would not be able to get care at all. So you're absolutely right, and I appreciate what the department is doing. Thank you. Thank you, Madam Chair.
I really appreciate it. Mr. Secretary, you've said by helping rural hospitals stay open, we are helping residents of rural areas get the care they need close to home. Having access to care nearby is not only more convenient, but it also lends to better health outcomes and boost local economies. I want to say I couldn't agree with you more. I certainly hope that you mean that, and I assume that you would confirm that you do.
Yeah, and any ideas you have, because there are a lot of healthcare facilities in rural America that are on the verge of closing.
Yeah.
Once they close, it's tough to reopen, so we're more than willing to work with any of you who are interested in that.
That is wonderful, because that's actually the commitment I want from you today. We, as you know, there are a very small number of new rural hospitals that opened in 2020 just before the country shut down, and one of these hospitals is actually located in Alabama. So Thomasville Regional Medical Center was among the unfortunate few who were deemed ineligible for provider relief funds due to the formula's reliance on the figures from 2019. And you're well aware of this, as you know.
Yeah.
Throughout your tenure, many of my colleagues, Representative Sewell there on the other side, in the other chamber, and on the other side of the aisle, has talked to you about this and has asked for your commitment in budget hearings just like this, and received it, to working with us to find solutions for this group of needy hospitals. These members received a commitment from you and their offices to ensure that these hospitals received proper federal assistance via the Provider Relief Fund. And so my assumption is that you stand by that testimony. And my question would be, what actions did you take to ensure Thomasville Regional Medical Center received adequate provider relief funds?
Thomasville, like many of the facilities that have applied, have to meet the criteria that Congress set forth for us to be able to fund them with the provider relief dollars that were made available. Where we had some flexibilities, some discretion, we took them to try to help some of the facilities that were clearly hurting and in desperate need, especially those that were providing services to folks who are in underserved areas. But our discretion, our flexibility is limited by what Congress set forth as the guidelines for distributing the dollars. Too many facilities, and I suspect Thomasville being one of them, fell within that scope where it became difficult to reach them because of the criteria.
So what do we do? I mean, because there has to be a pathway to help, because just as you mentioned, they are on the verge of closing. And if you look at some of the things that we've seen, they have kind of, the Harvard School of Public Health put out that this congressional district has the lowest life expectancy in the country. And so if we are not going to help hospitals like this that provide people access to care within their communities, your very first statement that I wholeheartedly agree with, then what are we doing? I mean, this is what we're here for. So you're telling me why we can't. Tell me how we can. That's what I want to know.
Yeah, and we can if you all hadn't swept up close to $5 billion that we had in COVID relief dollars, we could have perhaps come to you and asked for you for more flexibility to use some of that money for some of those providers under the Provider Relief Fund. We're out of money in the Provider Relief Fund.
So there was about $7 billion left, right? Is that right?
At this stage, no.
But when that occurred?
Well, left in the sense that it had not yet been obligated, but it was already destined to go to provide different services. It was then swept up by Congress, and now it's no longer available.
So what can we do?
Well, you can always try to re-up the provider relief.
Well, no, I mean, what can you do in your role right now? What can you commit to me to help keep this hospital open? Or what resources are available? What thought process do you have? You obviously sit in the big chair, so don't tell me what you don't have. Tell me what you do have and how we can get that to a path of success.
Well, the problem is if I don't have the resources to make things happen, there's only so much I can tell them we can do, because what they want is money. They're not interested in smiles, they're interested in money. If I don't have money in my pocket, you all swept it up, it makes it tough for me to offer.
Do you have
money.
any money that could work to go towards that at all?
Senator, as you know how the way things work, you tell me where I can spend the money.
Okay, so what would I need to advocate for right here in this budget to help move that forward?
There's two things you can do. Pass legislation that gives us more flexibility in using some of the money you've already given us, which probably would gain some opposition from folks who say, wait a minute, that's already money that we're going to use and you're sending it off to somebody else, so you're going to have to deal with that. But you could do that, give us more flexibility with money we do have, which we don't have flexibility to use, for example, with a program like Thomasville. Or you can re-up a program like the Provider Relief Fund that has some resources so that when Thomasville comes to us, I can say, we now have some resources that we can provide to you.
Will you commit to continuing this conversation with me, the two of us?
Absolutely.
Thank you.
Secretary Becerra, I want to also address the 988 implementation. I was proud to be the co-sponsor of the 988 legislation along with former Senator Cory Gardner, and I believe that it has been a remarkable service. You know, we always had a suicide prevention hotline, but nobody remembered the 10-digit number, especially at a time of crisis. And when we launched the 988 number, it has literally been a lifeline for so many. I want to ask you specifically about a pilot program that has been underway regarding LGBTQ youth. You mentioned already when you call, there's a screening for service members. If you're a veteran of our military service, you can get routed to appropriate and knowledgeable services. Last year was a record-breaking year for legislative efforts around the country that target LGBTQ individuals, including the ability to receive health care, inclusion in education, even access to public restrooms. It should not, therefore, be a shock that lesbian, gay, bisexual, and transgender youth are more likely to experience anxiety, depression, and thoughts of suicide than their peers. In fact, LGBTQ young people are more than 4 times more likely to attempt suicide than their peers. We're seeing that these attacks do not live in a vacuum and that they have real-world consequences. I have been glad to work with you and the department in creating and now expanding specialized services within the larger 988 Crisis and Suicide Prevention Lifeline to provide response to LGBTQ youth in crisis. We know that there's a need there. In February alone, almost 40,000 contacts were answered by the LGBTQ sub-network of 988. Can you expand on how these specialized crisis services for LGBTQ youth and the pilot has helped support this population?
Madam Chair, absolutely, because I think you're going to the heart of what makes 988 so valuable, and that is that you have individuals who are challenged, who are at a moment of crisis, who turn to someone and actually trust, will extend confidence in someone through a phone call, through a chat, and that's a tremendous thing. And so to begin this pilot back in September of 2022, see it working, expand it to some 7 different call centers, and see more than 40,000 calls come in specifically from the LGBTQ community means that they're responding. We want to continue that because we want anyone who's facing crisis to feel like they can have the confidence to make the call, have their call be personal and private, and also get the help they need.
No, thank you. I was just singing the praises of the program, but still, there are many people who are unaware of this crisis service. And I understand HHS is planning a public awareness campaign to spread the word on 988. Will the proposed increase for 988 included in the budget request support the anticipated increase in call volume as a result of the awareness campaign that you're conducting?
We're hoping to address it. We're hoping states will further step up to the plate to help us because at the end of the day, it's their call centers that are the front line. So we need states to continue to grow their capacity because we can only depend on the generosity of Congress to help sustain that national component. What we don't want is to have gaps. We want you to be able to call from whatever part of the country you're in. So we continue to partner with states and tell them, please, make commitments in your own budget to sustain your operations. Some states have actually done that. They've got a permanent flow of dollars. Most states don't.
Thank you.
Mr. Secretary, Mississippi has one of the highest rates of cardiovascular disease and deaths from this disease, and the frequency of the disease continues to increase. It's been concerning for a very long time. It's important that Americans receive cholesterol screenings and appropriate treatments to manage this cardiovascular disease to prevent further complications that could lead to sicker outcomes or even death. The fiscal year 2023 Labor HHS report included language requesting a report which was supposed to be completed in the summer of 2023. on cardiovascular disease and the implications associated with postponing, delaying, or being provided sub-treatments. This remains a critical issue in Mississippi and a critical issue across the United States. I was very disappointed that the department is nearly a year late in providing that information to this committee as it was instructed to do. Can you tell me the status of this report, and how do you explain why the department did not comply with the deadline?
Senator, I'm going to confess to you, I don't have that information in front of me, and I apologize. So how about we do this? Let me huddle with the team, and I'll do it as quickly as you like, and we can get back to you on that particular answer. I don't want to give you misinformation, but I wish I could give you something, and I don't know if I have any of that in my notes. So rather than try to wing it, let me get back to you on that, because it's an important question.
But you have no idea why it was late or that it was even late.
And I'm sorry, I can't, I don't know. I can't tell you that I remember my team saying to me, we're going to be late. And so rather than give you, again, rather than try to dance, let me get back to you as quickly as possible. Madam Chair, if the Senator would like, we could put my response on the record.
I would like a response to that pretty quickly. And as we look at what may be the most consequential year for telehealth policy to date, we cannot overstate the urgency for Congress and CMS to act on Medicare legislative and regulatory telehealth flexibilities. Our nation's healthcare systems and providers need clarity. We need stability to implement and maintain the operational and clinical practices needed to ensure seamless quality care for millions of Medicare beneficiaries nationwide. I strongly encourage CMS to work alongside Congress by continuing to share relevant telehealth data with members of Congress and staff, as well as continuing to engage with stakeholders through public calls on pertinent healthcare issues. How actively will CMS engage with Congress this year on telehealth policies?
Senator, we'll be camped outside your door if you like, because this one is very important to us. As we discussed in our previous Q&A, telehealth is indispensable, especially in rural communities. It avoids the need for transportation. It makes it possible to have immediate access to a professional health care provider, and we don't want to lose that. And so we are at your door, ready to provide technical assistance as you all make decisions on what kind of flexibilities to continue to give us in working with the states.
And as you know, many of those flexibilities that allow Medicare providers to offer telehealth expire at the end of this year.
Yes.
And Congress plans to address these policies, but may not finalize updates until the close of the end of the year. Will CMS be able to create a regulatory pathway to allow for immediate and seamless updates to policies when the law is updated?
Senator, I don't think you're going to like the answer here, because regulatory work, as you know, takes more than just months to implement and actually put on the ground and operate. We are absolutely counting on the Congress before the end of this calendar year to come up with some telehealth solutions, because we won't have the kinds of flexibilities that you or I would want to see if we get past December 2024 without Congress acting to extend those flexibilities. We'll do whatever we can at the regulatory level, but more importantly at the executive level where we have any discretion. But as you know, the reason you all had to pass these extensions on flexibilities was because we didn't have a lot of the president's budget.
Why is Medicare Advantage so popular?
I'm sorry?
Why is Medicare Advantage so popular?
Why is Medicare Advantage so popular? You'll have to help me with, what do you mean by that?
You don't know what Medicare Advantage is?
I absolutely know what Medicare Advantage is.
Yeah,
when
why
you
is
say
it so
popular, is there some survey that you're talking about, or what?
Yeah, about I deal in numbers.
Okay.
About half of our seniors who qualify for Medicare choose Medicare Advantage, don't they?
That's actually more than half.
Okay. And why is that? That makes it popular, right?
Medicare Advantage today, this is the first year that we've seen more individuals select plans in the Medicare Advantage.
Why is it so popular?
Again, when you say popular, I've heard many Medicare beneficiaries who are complaining about being stuck in a Medicare Advantage plan.
Well, is it because the average person, average senior on Medicare Advantage pays $2,400 less in premiums on Medicare Advantage as opposed to traditional Medicare, plus gets more services like dental and vision in many respects. Could that have something to do with it, you think?
I'm assuming that you've seen some polling or surveys that give you some of those answers. I've heard many, many things,
No,
both
I've
good and
seen
bad,
the,
about
I've
Medicare
seen the
Advantage.
facts. Are you telling me that people on Medicare Advantage don't save money in premiums and copays over traditional Medicare?
I have no doubt that some do, but I wouldn't have no doubt that some pay more.
I'm talking about the average.
Again, I don't know what numbers you're referring to, but I'm
looking
more than willing to
at the
discuss
numbers
those with
that your
you.
department puts out.
Okay, then what are those numbers, Senator?
The numbers say that the average person on
I'm asking you if
Medicare
you could show me the
Advantage
numbers.
pays $2,400 less in premiums and copays and gets extra benefits. Is that right?
My understanding is they're also restricted in the doctors they have access to, the hospitals they have access to.
You're trying to destroy Medicare Advantage, aren't you?
We've actually provided an increase in funding for Medicare Advantage.
No, you haven't. You cut funding in 2023 by 1.1%.
That's absolutely incorrect.
And you next year you're proposing a 0.16% cut. And in fact, the Medicare.
That's absolutely incorrect.
That's not incorrect.
That's absolutely incorrect.
And in fact, the Medicare trustees.
Senator, saying it doesn't make it true.
The Medicare trustees said that you've lost your mind. My words, not theirs.
Senator, saying something doesn't make it true. The dollar amount that we're giving to health insurance companies and Medicare Advantage
Are you telling
has
me today
increased.
that you have not cut payments to insurers in Medicare Advantage last year by 1.1%?
We are giving Medicare Advantage. Health insurance companies under Medicare Advantage are receiving more money this year than they got last year from Medicare.
You cut them by 1.1%.
That's not a cut, Senator.
And you're proposing another 0.1% cut. In fact, I mean, you and President Biden say you will not touch a hair on the head of Medicare, but you're trying to destroy Medicare Advantage.
Actually, the president's budget extends the life of Medicare beyond your and my lifetime.
Look at the numbers. In 2023, under your watch, Medicare Advantage patients saw on average a 12% increase in deductible and a 5%
The insurance companies did that, not us, Senator.
And Florida and Utah and Wyoming saw their premiums go up 50%.
Okay, Senator, blame the insurance companies, not us.
Because you cut the payments
Senator,
to the
we did
insurance
not cut.
companies to drive them to traditional Medicare where you can control them better. Isn't that the case?
The fiction you're propounding doesn't resolve the issue that we have every year so far under this administration increased the funding for health insurance companies who offer these managed care Medicare Advantage plans.
Thank you, Senator Kennedy. Now I'll recognize Senator Heitzman.
Back, the chair recognizes Dr. Miller Meeks for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Secretary Becerra, for testifying before the Energy and Commerce Health Subcommittee. As a physician, I have unlimited endurance. I just want to follow up to Dr. Bouchon and a comment you made. So during 2012 to 2019, ED treatment cost increased from $54 billion to $88 billion, a 5.4% annual renewal growth rate. Treatment cost, ER costs, did not go down after implementation of the ACA. Just wanted to put that out there. When you testified before this subcommittee last year, I asked you if you would responsibly work with me on my legislation to implement algorithmic technologies at HHS to save taxpayer dollars by reducing improper payments, fraud, waste, and abuse. And you said we absolutely would look forward to working with you and that you are still trying to figure out how we can make the best use of AI and use it for the right purpose. We are in agreement that these technologies should not be used to deny legitimate claims and restrict access like what we see happening in some of the private plan spaces. My office submitted the legislative text for this proposal, and unfortunately, Representative Eshoo, I have to one-up you, a year ago for technical assistance, but we have not received it back from you. Yes or no, will you commit to getting this back to me within the next 30 days?
So
Yes or no? Yes or no?
I was about to say absolutely yes, but I want to make sure
thank you very much. No Surprises Act implementation has been a disaster. According to the GAO, over 61% of 490,000 claims submitted remain unresolved in June of 2023. This means that thousands of physicians nationwide are not being paid and potentially going out of business, selling their practices to hospitals, or retiring. And this is on top of what's happened with Change. What is HHS doing to improve the efficiency? More importantly, your department said that you had the ability to penalize after arbitration, but claims are still unpaid. What are you doing to penalize bad actors who are not paying after arbitration has shown that their claims should not have been denied?
And you may have, I don't know if you were here, Congresswoman, at the time, but I mentioned that the independent dispute resolution process does not involve HHS. So once a dispute is resolved, the winner in that dispute, if that winner isn't getting paid by the loser, we're not aware of that. And the only when a winner comes to us and says, wait a minute, we never got paid, do we get informed of that? So what I would do is encourage any provider that wins that you know of to please reach out to us, to our help desk, so we are informed, so that way we can take action, because we are, under law, given the authority to try to enforce those judgments.
We will do that, and if it requires legislation which was not put in the No Surprises Act in accordance with the guidance given to legislators by HHS, who said that they had the ability to, in fact, enact penalties or get this recoupment. So we'll follow up on that. Under the Biden administration, Part D drug premiums are going up, plan choices are evaporating, and formularies are getting tighter, largely due to Inflation Reduction Act reforms to Part D. Essentially, the IRA has increased Medicare costs for seniors and continued Democrats' goal of limiting health plan choices, and eventually the country evolves into a single-payer socialist healthcare system. According to National Cost Data Report on Medicare Part D premiums by HealthView Services, Medicare recipients nationwide will pay an average of 35% more in 2024 for prescription drug coverage compared to 2023. Seniors will continue to see narrow formularies, more prior authorization and utilization management, more step therapy, meaning that seniors are paying more for restricted coverage. Secretary Becerra, I'm concerned that your management of the Medicare Part D program and changes that are going into effect under the IRA will in fact drive up premiums and lead to less plan and prescription drug choice for our seniors. Part D premiums went down 11.7% under President Trump, but are up 22% from last year under President Biden. The IRA calls for increased risk plans starting next year when Part D redesign goes into full effect, and plan liability triples from 20% to 60% for expensive drugs. Have you performed any analysis on the IRA's impact on Part D plan design to see how much more restricted seniors plans will be compared to how they were pre-IRA, and how much more utilization management they'll experience?
Congresswoman, you just said a lot. I don't agree with much of it, but what I will tell you is this. Ask any senior on Medicare what they pay for insulin, and I guarantee you they're going to tell you they're paying a lot more. They ask a senior how much out of pocket they're paying right now for the prescriptions they need.
With all due respect, sir, the seniors in my district are all paying more for their drugs, but I will appreciate
that's on the drug companies, not on Medicare.
Your pre-IRA analysis.
Yeah, but that's on the drug companies. The drug companies are the ones that set the prices, not Medicare.
Last question, my time's running out. In February of this year, the committee subpoenaed the National Institutes of Health for documents related to NIH handling of sexual harassment complaints from within the agency and its grantee institutions. There are over 900 files related to sexual harassment to be reviewed. As you know, committee staff have been conducting in-camera reviews at HHS of sexual harassment cases reported to NIH. During these reviews, the documents have been heavily redacted. HHS has redacted the names of the disciplined, terminated, resigned, or transferred abusers, including individuals who were convicted of crimes. There's no basis for protecting these abusers' names from Congress. This is unacceptable. By redacting the names of all the abusers, HHS is preventing Congress from seeing whether these abusers are still receiving grant funding, or even worse, if they're transferred to a new institution and were then given new grant funding. Why are you protecting the identities of the abusers and institutions who house them from being shown to Congress?
We're going to have to take that in writing. I'm sorry. We're trying to get to everybody before vote. So Ms. Custer from the gentleman is back. Ms. Custer is recognized for 5 minutes.
Thank you, Mr. Chairman. Secretary Becerra, you must be exhausted, but we're delighted you're here. You can see the light at the end of the tunnel. Great to have you with us. The Department of Health and Human Services plays. I yield back, Mr. Chairman.
Generally yields back, and now recognize Mr. Crenshaw, 5 minutes.
Thank you, the Chairman and Ranking Member. Thank you, Mr. Secretary, for being here. HHS deals with a lot of stuff, so you've gotten a lot of different questions today, and you're going to get another one. I'm only focused on 2 pages. I'm focused on 2 pages of HHS guidance on quite a controversial subject. Well, it's controversial up here. It's actually not very controversial in the public. It involves gender-affirming care on young people, on children, on minors. It's not controversial in the public. 70% think that we should not do gender-affirming care and hormone therapy, puberty blockers on children under 18. I bet that number is much higher if you ask them about, a double mastectomy on a 12-year-old girl. And yet, HHS guidance, it's only 2 pages, is very clear in what HHS believes, which is that gender-affirming care is great. There's nothing but good things coming out of gender-affirming care. You should just believe a child immediately if they say they're a different gender and put them first on puberty blockers, a month later on hormones, and then put them in the physical body that they believe they should be in. I mean, that's very, very radical stuff and obviously very consequential. You're making permanent physiological changes to a child, and you would think that if you're going to do something like that, that we would have an unbelievable amount of evidence to show that it indeed results in positive outcomes. I mean, you'd agree with that at least, right? That you'd want the evidence.
So first, Congressman, I have to say that nowhere what you've described do we say in any document from HHS. We do not make these flat statements, as you've said.
All right,
what we do is say we follow what the medical practitioners.
I'll read it. I'll read it
science.
for you. If you don't believe me, I'll read it for you. So this is from HHS Office of Population Affairs. It says it allows children, adolescents to focus on social transition and can increase their confidence while navigating the healthcare system. Research demonstrates that gender-affirming care improves the mental health and overall well-being of gender-diverse children and adolescents. Medical and psychological gender-affirming healthcare practices have demonstrated to yield lower rates of adverse mental health outcomes, build self-esteem, improve overall health quality for transgender, gender-diverse youth. Nowhere in here does it say there's any possibility of anything bad happening. Nothing negative at all in these 2 pages. It says that puberty blockers are reversible. There's really no evidence for that. Anytime you cite something in here, it's a study that is at the most recent is from 2021, all of which have very serious problems with them. They're all surveys, first of all. They're not really studies. There's not like a double-blind, randomized control trial going on here. And in some cases, 14% actually received the hormones. And many of these studies are not even just on children, and most of the participants are over 18. So you can't really determine any kind of causation. And bottom line, none of them are systematic reviews. If nothing else, you might agree that systematic reviews are the gold standard of evidence, right? A systematic review, for anyone listening, doesn't mean a study. It means a systematic review of all of the studies. One just came out, like last week, the CAS review, which... we're just going to put up this diagram here. One of the things it pointed out was how all of these studies that have been cited by all of these radical ideological medical associations that are lying to parents and doctors showed how they cite each other in this sort of circular reasoning in order to make their point. And HHS should not fall victim to that. HHS you are relying on studies that match this much paper. These are the studies that you cite. This is the CAS review that just came out. That's a systematic review. That's the evidence that they're pushing out. That came from the British doctor, Hilary Cass. That's a huge difference in evidence. And that's a really big deal when we're talking about something as consequential as permanent physiological changes to children. I mean, right? Can I get maybe some agreement from you that you might want to take another look at this particular document from HHS, which is relying on old data, data that's from studies that have really been debunked in many ways. Can we at least look at it one more time?
Congressman, I can assure you that we look at all studies because the services that we provide are based on an understanding what the best available science and evidence are. When we talk about a standard of care, it's not something we make up. It's based on what the major medical associations, by the way, those radical associations you mentioned, many of your colleagues are members of those so-called radical medical associations.
Yeah, and they would probably agree that they become radicalized. Let me tell you something about standards of care.
You don't want me to finish the answer?
Let me talk. The CAS review also studied and they ranked 23 standards of care from all the countries. You know which ranked second to last? All of the ones you're citing here. The ones that you guys use. They ranked last as far as standard of care practice, as far as how good they are compared to other countries. That's a really damning statement from a systematic review from a very, very well-respected group of doctors. You are not relying on the best data. You're just not. And that is terrifying for our children. I'm out of time and I yield back.
Gentleman yields back. Countries around the world are banning this stuff. The United States is behind. I recognize Mr. Balderson, 5 minutes.
Thank you.
$1 trillion in new ACA spending. My question, do those go to people or insurance companies?
Do those investments go to, well, it translates into a record number of Americans getting insurance.
Does the money, does the $250 billion go to insurance companies?
The investments make sure that Americans can afford to purchase the insurance they need to get health care coverage.
How high of a deductible would you consider affordable for someone making the median income in this country, which is around $70,000? So how high of a deductible is affordable?
Rather than give you a speculative answer, what I can tell you is that 4 out of 5 people who are looking on the website for healthcare.gov are finding a health insurance coverage plan that gives them a real quality coverage for $10 or less a month in premium price.
Do you know the average deductible of a silver plan?
There are many different deductible levels based on the plan, and
it's over $5,000. Okay, in your statement, you talk a lot about lowering the drug prices in this country. Your budget includes the expansion of the price controls, but fails to include any detail on whatsoever those expansions would if they're actually going to work. We've also been waiting for years for this administration to enforce price transparency requirements for pharmacy benefit managers and insurance that the former administration finalized to unwind the black box created by these middlemen. So Ranking Member Pallone and I applauded CMS when they announced enforcement was coming last September. When can patients expect HHS to enforce, but it still hasn't happened. So when can we expect HHS to enforce the drug price transparency rule?
Congressman, we are currently enforcing that law. We're doing it as best we can. As you know, it has gone through a number of iterations in the courts. We continue to try to implement the letter and spirit of the law.
Okay, so we're still waiting. Okay, we're still waiting.
Well, we have to make sure we follow any court rules.
It's only been 3 years. Okay, moving on. Secretary Becerra, rulemaking can also have an impact on the budget and federal spending on mandatory programs such as ACA tax credits, Medicaid, Medicare. CMS has been finalizing a number of regulations just in recent weeks. For the 2025 Obamacare rule, will policies finalized in that rule increase federal payments to insurance companies or decrease?
Will the 2025 rule?
Obamacare rule, so the federal payments to insurance companies, the premium tax credits, is that going to increase or decrease federal payments to insurance companies?
Well, the subsidies that Americans now can qualify for to help keep their insurance costs down will help make sure those plans are more affordable for Americans.
So I'm asking about the money that's going to the insurance companies. Is this going to be millions, tens of millions, billions, tens of billions?
The plans are operated and offered by private insurance companies within the Affordable Care Act marketplaces.
How much federal? Okay, sorry, go ahead.
And so when we provide the subsidies will flow through the insurance companies so that they reduce the price for those Americans who get the coverage.
Going to the insurance companies, and I guess we don't know how much. For the rule titled Streamlining the Medicaid CHIP and Basic Health Program Application Eligibility Determination Enrollment and Renewal Process, so that's the rule. Does that rule increase or decrease spending by the federal government on Medicaid over the next 5 years?
On Medicare or Medicaid?
Medicaid, yeah, Medicaid.
It makes sure that Medicaid recipients can afford to get the coverage they need and expand.
Does it increase spending?
An investment to make sure that more Americans qualify for Medicaid is going to be good for those Americans.
The question is how much? Do you know how much more this rule is going to require in spending by the federal government? Or are the state governments just expected to spend because of this rule?
Well, remember, Medicaid is a state and federal matching program, so much will depend on what the states do, but the federal
I'm
government.
going to run out of time here soon, and I'm still not hearing an answer. I know $45 billion more on spending by the federal government on Medicaid in the next 5 years alone, perhaps more. So I find it shocking in preparing for a budget hearing, making repeated statements about commitment to longevity and success of these programs. You can't even answer if we're going to have to raise taxes or not to pay for these or program reductions. Do you have any process in place where rules that increase spending by the federal government actually get any kind of accountability or responsibility? Because Congress has to pay these bills.
Congresswoman, as you know, and as I know from having served where you are, that we cannot spend money we don't have.
Well, you're passing a lot of rules that are committing a lot of money.
And those rules cannot commit us to spending money we don't have.
More to come. I'm out of time. Yield back.
The chair yields back, and the chair recognizes the ranking member for 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Secretary, I'm going to try to get through two issues, hospital price transparency and Medicaid unwinding. So if I make it, ask you to shorten your answers, it's only because I want to get through both. A major bipartisan.
Mr. Chairman, Mr. Secretary, thank you for being here. I think I don't doubt your intentions. I think you and I agree on the same thing. We want to lower drug costs. You didn't have the same experience that I had, serving as a pharmacist for over 40 years, having to go to the counter to explain to the patient how much their medicine was and watch them make a decision between buying groceries and buying food and buying their drugs. I had that experience, and I know you didn't have that experience, but I have to tell you that I feel like that your promises fall flat. You and I, the last time we had the opportunity to speak, and I believe it may have been in the Budget Committee, I'm not sure, but nevertheless, we talked about the government price controls of the IRA, which I think is the very worst legislation that I have ever seen in my 10 years in Congress, my 10 years in the state legislature. It is nothing more than it is not negotiations, it's extortion. And I hope that the court cases are going to prove it to be just that. Already it's resulted, and I don't mean to get back into it again. We had this discussion last time because you say you think it's going to result in more cures, whereas the University of Chicago says it's going to result in 329 fewer cures in the next decade. Even CBO says it's going to result in fewer cures, yet you say it's going to result in more cures. I don't know how you justify that, but nevertheless, I'll move on for that because I want to talk about something else. And what I want to talk about is copay assistance and the fact that the copay accumulators are being used by the PBMs and that they are pocketing this money. Yet the courts made a decision and made a ruling that they struck down the rule that allows insurers to implement these harmful programs, but your department is defying that decision. And it's gone on record as saying you will not enforce the court decision. Now, earlier, the chair of this committee asked you about the PBM Transparency rule, and you said, well, we're going to respect the court's decisions. How do you respect the court's decisions there, but you don't respect them here? How do you pick and choose which ones you're going to respect?
Congressman, first, thank you very much for the question, and you're right. Every once in a while, we may disagree, but I appreciate the questions that you ask. We will comply with the law. That's our obligation.
Why aren't you complying with this one then? Why are you allowing the PBMs to pocket this money instead of it going to the patients as it should go to the patients? Because you know what's happening with these copay accumulators. And you know what's happening with when they have these copay assistance cards. They're not honoring them. And they're pocketing that money, and then the patients are having to either pay their copay when they run out, or when they get up to their stopgap, then they're having to pay more.
And we are, as I said, first and foremost, I can assure you that we will comply with the law. What we want to make sure at the same time is we don't allow the Medicare program and Medicare beneficiaries to get gamed in the process and ultimately end up having to pay more out of pocket at the end of the day.
How are they getting gamed here if they are not able to use these copay assistance cards that the PBMs are pocketing instead of passing it on to the patients? And the courts ruled that, but you're ignoring the courts, and you've even said we're not going to enforce it.
Well, I recognize what the courts ruled here. I recognize what they looked at.
and they were looking at the facts that were before them. We have to make sure that we run the Medicare system so it works for all the 66 million beneficiaries that receive Medicare services. So what we want to make sure is that in the process of coming up with a system to not only dispense and allocate drugs, but to pay for them, that the folks who don't end up paying the higher prices are the Medicare beneficiaries themselves. And so that's what we have to make.
I'm not sure I follow that. Again, this appears to be a case.
I think you do.
No, I don't. And I don't think you do. With all due respect, Mr. Secretary, I don't think you do, because these copay accumulators are not being honored by the PBMs. They're pocketing them. How is that impacting someone else? I don't understand that when it's not impacting the patient, when they're not getting the credit for it. But let me move on. Earlier you said, again, in this minute, I've sat here the whole time, and in this hearing you said, I promise you that I'm not going to do anything that impacts patient access to care. This impacts patient access to care.
It does not.
It does. How does it not?
Patients will still have access to the drugs that they need.
If they can't pay for it, that's why they're getting the copay assistance.
Under the Medicare program, they will have help with accessing the drugs that they need. That's unfair for you to say that any patient will be denied a drug.
It's unfair to you to say that we're going to follow the law when you pick and choose which laws you're going to follow.
Give me a case where a patient has been denied their drugs. Give me a case.
Give me a case where the patient's not been given credit for the copay assistance. All kind of cases, and you say, even though the courts have ruled that that's not right, you're not going to enforce it.
All right, I'm just asking you to prove what you just said. You just said that patients are going to be denied their drugs. Show me the case.
Patients are denied their drugs when they get the copay assistance, and they cannot afford it because it's not honored by the PBM.
Show me.
I will get those cases to you, and you get me a situation and show me where you make the decision on what court cases you're going to follow and what court cases you're not going to follow.
You will abide by the law.
You will abide by the law. You just said you're not going to enforce this one.
Carson, I just told you we will abide by the law, and we'll make sure that no patient under Medicare is paying more than they need to for their drugs.
But when it comes to the copay accumulators, you're not going to honor that.
We're going to follow the court rulings wherever we can.
But you've said that you're not.
However we can. I didn't say that. I just told you we're going to abide by the law.
You know, I don't understand how everybody else is wrong and you're the only one who's right. I just don't get that.
I'm just asking you to show me the cases where people are being denied their drugs. Please show me the cases.
You know, Mr. Secretary, I'm sorry, but this is a total failure, and I yield back.
Gentleman yields back. Chair recognizes Dr. Joyce for 5 minutes for questions.
Good afternoon, and thank you for appearing, Secretary Becerra. Let's go back to an earlier discussion.
Well, thank you, Mr. Chair, and thanks for holding today's hearing. And Mr. Secretary, thanks for being with us today. This administration's forced one-size-fits-all approach allowing Medicare to negotiate drug prices in the Inflation Reduction Act is wrong for patients, wrong for science, and wrong for our most vulnerable. The Orphan Drug Act has been in effect since 1983, and even the IRA included a very limited orphan drug exclusion from negotiations. Unfortunately, CMS has refused to correctly apply the timing provision of the exclusion, leaving uncertainty for companies working to bring rare disease treatments to the market. You know, yes or no, will you instruct CMS to reconsider its decision relating to timing for negotiations and instead apply the law as intended, preserving the orphan exemption and postponing eligibility for negotiation until the date the first non-orphan indication is granted?
Congressman, it's hard to answer yes or no to a question which you phrase in a way I don't agree. The CMS continues, and all of us at HHS continue to believe in the importance of treatments for rare diseases. And of course, the impact that absence of access to those treatments would cause to a lot of patients and families. We're committed to implement the law on drug negotiations as we must under the law, which means we have to comply with all the laws, including laws that relate to the Orphan Drug Act. So we're going to make sure that we respect the Orphan Drug Act because it's a very important law as we continue to implement under the law the new drug negotiation.
It's absolutely important that that there's no uncertainty out there for these companies because again, on these orphan drugs, we've got to make sure that they're out there, especially for those most vulnerable who need them. Let me follow up. According to reports, in the last decade, 85% of new medicines entered the American market. What this means is that American patients had access to medicines first. Germany had only 61% introduced locally. Meanwhile, countries like Canada, Spain, Austria, and South Korea fell further behind with less than half of the new medicines available. Briefly, given those data points, are you willing to risk the U.S. patients' access to innovative and cutting-edge medicines if the current price control scheme is implemented and expanded?
Congressman, as I believe you know, that the current drug price negotiation law does not include drugs that just barely came on the market. A drug, for it to be negotiated by Medicare, must have been on the market for many, many years. And so those new innovations that you're speaking to would not be subject to negotiation.
Let me just go on, because again, when we're stifling healthcare innovations, often reduce access to new medicines and longer treatment wait times exceeding sometimes in over 500 days. Foreign governments who impose similar price controls cause patients with severe conditions to wait over 16 months for treatment. Has HHS considered how the Biden administration's price controls will impact the wait times for new medicines, treatments, and cures? And let me give you an example. During the work period, the last couple of weeks, I was at 4 hospitals in my district on that period. And I was bringing this up, and one of the nurses, this is in a cancer where they were giving for infusions at this facility, at this hospital. And she said, I'm very concerned about making sure that the patients get these new innovations out there, because she said that she was a Canadian, that's an American citizen now, but one of her very good friends is Canadian, who had to come to the United States to get that life-saving drug that wasn't being offered in Canada. And, it's with these new medications, and, again, as I mentioned, has HHS considered how these price controls will impact the wait times for new medicines, especially when these medicines are so, again, I think about everything in Ohio. I think about all the great hospitals we have, all the people come from around the world to come to the United States, and all of a sudden, if they say they can't get these medications, what's going to happen out there to these people?
Congressman, I know my friend, the health minister in Canada, would probably want to challenge what you just said.
Yeah, they can challenge me on it, because again, I know that when we were talking about and had hearings, having the information out here, the health minister would want to challenge you in the way you represented what Canada does. They had to open up in the United States, different states, to make sure that their patients could be treated, because they couldn't get the treatment in Canada. And so they were coming to the United States, to our northern states.
All right, so we can compare notes, but I guarantee you there are a lot more Americans that are going to Canada
I'd be happy to debate that all day, because I know
Canadians coming to the U.S.
Because then the Canadians had to shut it off because their citizens were coming here. And Mr. Chairman, my time has expired.
The gentleman yields back. The chair recognizes Mr. Cardenas for 5 minutes for questions.
Thank you very much, Mr. Chairman, and also Ranking Member Eshoo for holding this important hearing, and appreciate the Secretary.
The lady yields back, and that concludes all members of the subcommittee, and we have 2 wave-ons, and remember there's a vote on the floor, so we'll go quick. Chair now recognizes Mr. Pfluger of Texas for 5 minutes for questions.
Yeah, thank you, Mr. Chairman. Mr. Secretary, are you the principal advisor to the President of the United States on unaccompanied alien children?
Congressman, the Office of Refugee Resettlement is the agency charged with them. We work with the White House in making sure that we...
Are you the principal, as the Secretary, Cabinet member, are you the principal advisor?
I am the Secretary of the Department of Health and Human Services, and ORR is...
So you advise President Biden normally on unaccompanied alien children?
We work with the White House.
Yeah, but you advise?
We work with the White House, we offer advice, we take their direction, and we work together.
Are you a Cabinet member?
I am a Cabinet member,
yes. How many children are unaccounted for right now?
I'm sorry, how many children what?
How many children are unaccounted for?
In our care?
There's been reports that through open press and media that unaccompanied alien children who leave the care of ORR are unaccounted for. Their whereabouts are unaccounted for. Can you answer that question as to the number?
Sure. There are no kids who are unaccounted for who are in our custody, in our care.
Understand. Do they all have a place where they have gone that is a safe place, that they are not being either abused, or that you feel good about where they are?
The children who are in our custody, I feel very good about the care that they're receiving under our custody.
When they leave your custody?
When they leave our custody, they don't leave our custody until they have gone through a process where those who are willing to become the sponsors of the children go through a thorough vetting process.
So the recent OIG report on ORR's handling of...
Which recent report are you speaking to? The one that's from 2021 or something recent, meaning this year?
Yeah, more recent than 2021, refers to the handling of these UACs and deficiencies in safety checks, deficiencies in the overall handling, the monitoring procedures. Can you kind of talk to me about what that looks like and what your office has done to address that? And are you following the OIG's guidance on that, and what steps have you taken?
First, we always work closely with the Inspector General's office, and we try to follow through with them on all of their recommendations. The report I believe you're referring to is a report that's based on information that they got from early 2021. What I can tell you is that some of the circumstances, if you recall, that's when ORR, because the previous administration had dismantled the operations of ORR to take care of kids, it was becoming difficult to find places to house them. And so we went through a process, and today...
I think that's really what I'm getting at is, you know, there are multiple reports that children have been lost, quote unquote, in the system. So
we've not lost any children.
Zero.
We've not lost any children.
Okay.
Those who are in our care, we have not lost.
Okay, so everyone is accounted for.
All the children that we have jurisdiction and custody over are not, we know where, we have them. We don't lose them.
Okay. I want to refer back to my colleague, Ms. Miller-Meeks, the question she asked that you weren't able to answer because of the time. And I'll just ask the question, but she outlined it. Why are you protecting the identities of the abusers and the institutions who house them from being shown to Congress, even though that was subpoenaed by Congress this year?
So I think it's first important to say that if there is an abuser that is receiving taxpayer dollars from the Department of Health and Human Services, or in this particular case, to the Congresswoman's questions, from the National Institutes of Health, we will take action immediately.
Why are you not releasing the names to Congress?
Again, when we act, we have to act according to the law. And there are still laws that protect privacy interests, so we can only provide certain information.
Did you receive the subpoena?
I know the department received a subpoena.
Did you actually physically read the subpoena?
I saw the subpoena.
So you read it. And did it ask for the names?
Because the subpoena asked for something doesn't mean that...
Doesn't mean you're going to comply with it.
We're going to comply as best we can to a subpoena, but we have to follow the law in complying with any subpoena.
Can you tell me on what legal basis you are referring to that you would not release those names according to the subpoena and the request?
As I said, we have to make sure we follow the process, whether the process is in protecting privacy.
You've read it. We've established that. What part of the law is preventing you from releasing those back to Congress?
Well, as I said to you, there is a process for adjudicating any particular case where there are accusations of sexual assault, sexual harassment, and we have to follow that process pursuant to the law.
Do you plan to release the names to Congress?
We'll release whatever the law allows us to release in due course.
Do you think that is going to allow you to release the names back?
It's hard for me to prejudge what's going on in adjudication.
Okay. I think in the interest of a subpoena, it would be good to get back to Congress on that subpoena with the reasons stated why you would or would not release those names.
Congressman, you're speaking to a former Attorney General. I understand the value and importance of a subpoena.
I think that's the frustration
that we
why
abide
my
by the law.
colleague asked that question, because that has not happened yet.
I think we got to get one more questioner in. So thank you. And the gentlelady from Florida.
Let me start off by saying that when we had one of these broad budget hearings previously, the issue of the Office of Refugee Resettlement came up. I asked you if you would come and talk to the Oversight Subcommittee about it. I want to commend you and thank you for keeping your word, and we had a hearing on it. I do share a lot of the frustrations that you heard from Ranking Member Eshoo earlier in regard to what we're doing, because I do think that, and as I've said many times, we may not agree how they got here, but when we have an unaccompanied minor come into this country, it is our responsibility to take care of them. And I agree with Ms. Eshoo that the failure to do so, doesn't matter why or how, is a stain on us as the committee that has jurisdiction over it, and a stain on the United States.
May I comment on that?
Yes, you may.
Thank you very much. First, I agree with everything you've just said. But remember, my jurisdiction, my authorities end the moment I release that child into the hands of a sponsor. So trying to figure out what some employer or company is doing to them, I don't have sight on that, and you don't give me money to have sight over that.
Well, and I do have a solution. I look forward to working with Ms. Eshoo on her trying to solve this problem. I have a simple little bill, 7854, that just says that when you place them, can be before they get there, if that's when your jurisdiction ends, with a sponsor that you all have to notify the local school division and the child welfare agency in the region, which in Virginia would be the Department of Social Services. Now, I think it's a simple little bill. I look forward to working with you. If there's something we can tweak to make y'all happier with it, I just want to see these kids taken care of. Not directly related, but somewhat related. I happen to be speaking to my favorite juvenile and domestic relations district judge. That would be my wife. And I said, are there some questions? Because they have jurisdiction over a lot of these issues at HHS. And she brought up something, and I actually had a case similar to this many years ago that was not an unaccompanied minor, but a minor. And I don't expect you to be able to give me an answer, but I'm looking for guidance. So ask your agencies to help give me guidance on this. And that would be, and the judges are having a hard time with it. If a 15-year-old comes in front of a juvenile judge with a minor charge, or it could be more significant, but it could be as simple as a traffic violation. If they do not have a legal guardian, and the sponsor without a court order doesn't count, at least not in Virginia. It's the only place I'm licensed to practice or was licensed. I'm currently in mothballs, so to speak. But the judge doesn't have jurisdiction to try the case. The only thing they can do is put the minor, whether they're from another country or from the United States, into the care of the Department of Social Services. Now, as you know, finding foster parents, particularly for a teenager, is very difficult. So the Department of Social Services, in many cases, only has the option of placing them into detention, which, they've gotten a traffic violation in some cases. Some are more serious. Detention is not likely to be the first response of the juvenile court system, except we don't have any place to house them. We don't have any place to put them, and we don't have a process in which to deal with the underlying criminal charge. So I'm looking for some guidance. And if the judge, and so that you understand, my wife indicates to me that in her courtroom, there are 5 judges in her area, Roanoke Valley of Virginia. It happens about twice a month. That's a lot of kids. So I'm just looking for guidance. I don't need a specific answer today, nor would I expect you to have one today. But can you work with me to see if we can't get some guidance to our judges and our local departments of social services? Because whether they're, as I said, whether previously an unaccompanied minor or whether they're just somebody whose parents have flaked out on them, we need to do something for them. Would you agree?
I'm with you, and we'll follow up with you.
All right. During an oversight subcommittee that I chaired yesterday, and some ideas were coming up about how we combat improper payments to Medicaid and Medicare. One of the concepts that came up was having the state auditors do more, and of course, revenues would be necessary to do that. One of the concepts that came up as a part of the hearing, because we were trying to solve problems, not beat each other up, was perhaps on the money that the state auditors find that was going to be wasted, abused, or even direct fraud, that we give a percentage of that money to the state auditor to defray their costs in doing the audits. It's a thought. I pass it on to you. It came up yesterday. Sometimes Congress and the administration, no matter what party is going on, may be able to find solutions. I'd like to work with you on that as well. Would you agree to do that?
Congressman, I think if any state attorney generals are listening to this, they are going to give you a kiss, because when I was an attorney general, one of the things that we wanted is to have the resources to work with the federal inspector generals to do more of this fraud detection and work. And so I think anything we could do to get those inspector generals, the attorney generals to get out there, it's going to bring us money. It's proven. You do fraud control, every dollar you spend on that with those inspectors brings you back about $4 or $5.
And we can spend it on other things. My time's up. I yield back. Thank you, Mr.
Gentleman
Chairman.
yields
Thank you,
back.
Mr.
Chair
Secretary.
recognizes Dr. Reese for 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Secretary Becerra, for being with us here today. In January, I joined many of my colleagues in sending...
To move forward, so I'll gavel myself down, and I will recognize the ranking member for 5 minutes to ask questions.
Thank you, Mr. Chairman. Mr. Secretary, I think that you know very well that's an issue that I've spoken to, asking you questions about it for almost a year now. And it's the issue of, the Office of Refugee Resettlement and the children that were referenced in the New York Times articles. In fact, you last testified before this committee in July of 2023 after the New York Times reported on the, I think well, I'm not the only one that thinks so, horrendous exploitation of children that were discharged by ORR. I asked you at that time whether the children referenced in the articles were still being employed illegally at dangerous facilities. You said you'd get back to me, so I resubmitted my question for the record. 7 months later, I mean, I know that the department is busy doing things, but 7 months later, I received your response to my questions for the record, and what was so obvious was that that question that I had originally posed was ignored. There was no answer from you on that. I think one of the most alarming aspects of this issue is that ORR employees claimed they faced pressure to expedite the release of children at the expense of their safety. Now, I've got questions about each one of these, but I want to get my comments in first. According to the New York Times, monthly calls to HHS reporting trafficking and abuse of children increased fivefold from less than 50 calls in January of 21 to nearly 250 calls in December of 22. I've requested more recent data in my questions for the record, but I haven't received any answer. Yesterday, I introduced the Transparency for Unaccompanied Children Act to strengthen congressional oversight of ORR by requiring the agency to issue timely, public, and comprehensive reports on the Unaccompanied Children's Program. And we need you to cooperate with us on this, because I don't think all is well at that part of your agency. So my first question is, and I'm asking it once again, are the children who were profiled by that article in the New York Times still illegally employed today?
Congresswoman, thank you for the question. And I know that my team has been briefing your team and you on this subject matter. And as I've said on many occasions before, it would be nice for me to tell you a more direct answer about what is happening to the children who are no longer in our care and custody. We don't have jurisdiction over them. If you wish to give us jurisdiction over them, that would be fine.
Secretary,
but
with all due respect
I have no authority
to you,
to do that investigative
wait a minute,
work.
it's my time. It's my time. Have you worked with the Labor Department? Did you ever call them to see what's happened to these children?
We have a joint operation.
A joint operation on what? No answer?
Addressing the
On
child
no answer?
exploitation.
I think you have the responsibility. You were a
Congresswoman,
member of the
we answered the
Congress.
questions based
You
on the
were
authorities
a
that
member of
we
the
have.
Congress, and our questions are important. I'd like to know what you've done to change ORR's culture to ensure that the agency always puts the safety of children first. What can you tell us on that?
Certainly, I can tell you that the snapshot that you are speaking to back in the early part of 2021 is not the circumstance you see at ORR today. If you recall, as I've said many, many times before, the previous administration had dismantled the ORR operations.
I don't want to, that's not what my question is. Just answer my question. Have you done anything? Share with us what you have done. I think you purport to have done things to change that culture. These children fell into a horrendous situation. And I know that the Department of Labor has, after they leave you and what you do, but there was so much room for improvement in this. And so, you know what? Why don't you answer my question in the questions for the record? And I'm asking you to commit to working with me on this legislation because this needs to change. I think it's a dark mark on all of us when these failures take place. They're the children. We have to answer to God for them.
Congresswoman,
so I'm
I
asking
disagree
you
with the way
to.
you've
I'm asking
characterized
you to commit to working with us on this, and I yield back.
Thank you. The gentlelady yields back. The chair recognizes the chair for 5 minutes for questions.
Secretary Becerra, let's talk about bold.
Gentleman's time has expired. The chair recognizes Mr. Bilirakis for 5 minutes for questions.
Thank you. Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here. As you know, I've been a long, strong advocate of research funding and federal efforts to advance diagnostics and treatment for individuals with neurological conditions, including Alzheimer's and Parkinson's diseases. We are making a significant amount of progress in Alzheimer's and going through the HHS fiscal year 25 budget in brief document. I was glad to see some of the proposed initiatives. However, I'm disappointed that Parkinson's disease is not mentioned once. For reference, the term equity is listed 77 times in the document, but not one single mention of Parkinson's disease initiatives. As the fastest growing neurological conditions, what is your agency currently doing to address this rising public health need?
Congressman, thank you for the question, and I assure you that like Alzheimer's, Parkinson's, and so many other of these devastating diseases are a focus at NIH and many of our programs within CMS. The difficulty, of course, is that we have to follow, it's very similar to the answer I gave to Congressman Reese. We have standards that we have to follow based on the laws that you have passed. And so for us to, for example, provide more research money or to include a particular therapy or treatment or drug as part of the Medicare program, we have to follow the process and make sure that we check the boxes, because otherwise, you probably saw an article that came out about a week ago of a number of drugs that the FDA approved, said they were safe and effective, but people took them, nothing happened. And so all of a sudden now all those drugs are not working. And so what we have to make sure is that when we say we're going to help, there's really going to be help coming.
You said that nothing happened. Elaborate on that.
So many of the people who reportedly took some of these drugs, and I could try to make sure I get you that article, many of the people who were taking these drugs found that there was no improvement in their health as a result of taking those drugs.
What diseases are we talking about? Neurological diseases, or?
I don't think they were neurological.
Okay, please give me that information.
I will send that to you. It just came out about a week ago.
Okay, thank you. It's been 1,144 days since this administration took away seniors' ability to access innovative medical devices. When the Medicare Coverage for Innovative Technologies rule, MCIT, was repealed, this administration promised patients it would quickly work on an alternative proposal. Every year we ask that question. This year, my colleagues, again, we want to know, what is taking so long, and will you commit to finalizing this new rule by the end of next month, possibly? You know, seniors are waiting on this, and they can't wait any longer. Can you address that, please?
Congressman, rather than try to commit to something like within the next month that I can't guarantee that, how about we do this? Let me follow up with you and tell you what the latest is. We can then share that publicly if you'd like. But I'd rather not try to commit to something that I can't guarantee, but I understand the importance of this.
Yeah, it's very important to our constituents. I'm concerned that the administration is forging ahead on a proposed rule that regulates laboratory-developed tests. And, you know, this is a bipartisan issue.
And academic institutions.
Yeah. We recently held a hearing with stakeholders talking about the rule, where there's unanimous agreement on this, that the rule is misguided. Is your department listening to the patients and provider communities here? Expand on, and answer that question if you can. And will you commit to ensuring that patients won't lose access to these types of tests under a FDA regulatory regime? Can you respond to that, please?
Sure. First, I think everyone recognizes that having good testing practices is critical for Americans to know what's going on, whether it's COVID or whatever else. Secondly, we like to make sure that those are standardized so that one test will work because everyone uses it and it works, and we don't have issues that some tests aren't working, other tests are. We want to make sure that that's a standard process. There should not be exceptions unless they're absolutely necessary. Academic institutions are saying that they should be outside of the scope of that. We're saying there's no reason why, in the process of making sure all tests work well, that we should allow academic institutions to be treated better or differently. And so I would challenge your statement that there is unanimity in agreement that this rule is a bad one. I believe the rule is a result of talking to all stakeholders and trying to make sure that we have a process that fits for everyone. No one is special in this process as a laboratory. You have the same obligations to make sure what you produce works for the American people. We want to make sure whoever you are, and we elevate those academic institutions. I went to a really great one, Stanford University. But that doesn't mean Stanford University is so special that it doesn't have to follow the same rules that other laboratories have to follow.
I know my time has expired. Thank you. Appreciate it.
Thank you. The gentleman yields back, and the chair recognizes Ms. Kelly for 5 minutes for questions.
Thank you, Chair Guffrey and Ranking Member Eshoo and Secretary Becerra. Good to see you. As you know, I'm a strong supporter of FDA's efforts to prohibit menthol cigarettes.
Questions. Thank you, Mr. Chairman. Thank you, Secretary, for being here. Good to see you again. Can we just talk a little bit about consolidation in healthcare and specifically provider consolidation? Is this a problem that needs to be addressed?
Is provider consolidation?
Yes.
Any consolidation which isn't for the purpose of efficiency should be a problem.
So do you think that we should even preserve independent practices at all?
Should we preserve? That's something we've had forever. There's no reason why consolidation should mean that there shouldn't be independent practices.
Okay, fair enough, and I'm glad you feel that way. And I personally think the presence of independent physicians is an invaluable counterweight to the rise of consolidation that we see in our healthcare marketplace. So what is this administration doing to help preserve independent practice as an option for physicians and patients?
Congressman, we continue to work within the industry to make sure that no consolidation is occurring for monopolistic purposes. We work with the Department of Justice on that. We try to keep prices competitive. I would probably agree with you if you were to ask me if removing those independent practitioners is going to lead to higher prices, and I would probably tell you it absolutely does.
And may I just add, it's going to lead to worse patient care, and that's really what we should be concerned about. I mean, it's one thing to spend a lot of money. It's another thing to spend a lot of money and not deliver the care that people really need. So let me just ask you this, because we got the physician's fee schedule coming up. It happens to us end of every July, and then I start getting the letters in October. So would you consider modifying the upcoming physician fee schedule so that it does not involve the large budget neutrality adjustment and offers physicians stability in contrast to many decades of disruptive payment rules?
Here I'll say, Congressman Burgess, I think, but I hear a question from Dr. Burgess, and what I would say to you is that's a dance we have to engage with together because, you know, Congress set the rules, the new budget neutrality rules we have to follow, but more than willing to work with you because, again, if it doesn't really deal with the reality of what the practitioner on the ground has to face, we all should take a closer look.
Well, here's the problem. We need to ensure that this year's physician fee schedule doesn't continue the cycle of large budget neutrality adjustments that drive conversion factors down for providers. And you think that we can do that?
We are more than willing to work with you because we know that there are a lot of providers, doctors.
I'll give you the benefit of the doubt. That's a yes, and we will work with you. So, look, we got a problem with, you know, Affordable Care Act, the CMMI was supposed to save money. It doesn't. Poorly constructed models favoring large health organizations, consistent disruptive payment rules driving consolidation. What we just heard this week about the Change Healthcare problems driving consolidation. It seems intuitively obvious to the casual observer that this administration prefers larger healthcare systems and neglects smaller providers. For example, why hasn't this administration embraced ideas such as site-neutral payment reform to lower costs for the patient and reduce consolidation, something that has been included in presidents' budgets for over a decade?
Congressman, probably a longer conversation, but I'd be more than willing to discuss with you the ways that we have continued to try to sustain the smaller providers, because the smaller providers are typically the ones that are in rural America. They're typically the ones that are in lower income America, and we desperately need to keep them in place. And so we have promulgated a number of policies that support smaller providers. We want to avoid them being gobbled up by the big guys.
Okay, here's a pro tip. Site neutrality can replace budget neutrality. We can afford this. We have the dollars within the system. we can afford to do this. It is just the will to deliver on that. There's a big increase in the budget for this year. We're 3 years now post-COVID, and the budget is even bigger than what it was when you all came in 2021. I appreciate your acknowledgement of the prior administration, Operation Warp Speed, providing you the platform of vaccines that did allow for the disruption of the coronavirus. But ultimately, we've got to put the well-being of America's patients first and foremost. Just one last thought, and I will submit a number of questions for the record. Do we have any idea what is the cost per enrollee in the Affordable Care Act now?
Again, that would depend on the plan that they purchase, what their income level is, what the level of subsidy would be.
But you say that the care is basically costless to Americans, but it's not. Americans are paying this bill, and now they're paying highest interest rates on the money they're having to borrow for what you're giving away. Thank you, Mr. Chairman. I'll yield back.
Thank the chair yields back, and the chair will recognize Mr. Sarbanes for 5.
Thank you, Mr. Chairman. Secretary Becerra, you must be exhausted, but we're delighted you're here. You can see the light at the end of the tunnel. Great to have you with us. The Department of Health and Human Services plays a critical role in protecting the health and well-being of our country, and this budget proposal reflects just that. The budget reflects this administration's commitment to ending the mental health and substance use disorder crisis, was been my #1 priority for 12 years in Congress. Last year, the FDA approved the first over-the-counter overdose reversal medication, naloxone nasal spray. This is truly an exciting first step to making this life-saving drug more accessible and reducing deaths from overdose. And I'll point out, New Hampshire is the site of one of the very first vending machines for naloxone to make it available to everyone in the community. However, I'm concerned that seniors with Medicare Part D plans and Medicare Advantage plans may actually lose access to the drug now that a prescription is no longer needed. As you know, 52,000 Medicare beneficiaries overdosed in 2022. The Office of the Inspector General believes this could actually be an undercount. The OAG also found over 1 million seniors enrolled in Medicare struggle with opioid use disorder, including relatives of mine. Secretary Becerra, what steps can be taken to ensure that seniors can access over-the-counter naloxone?
Congresswoman, you point out something that's critically important. Most folks think of young people when it comes to the need for naloxone to save a life from overdose. But we need to make that available to all people, including our seniors. We are right now in communication with Medicare Advantage plans and Medicare Part D sponsors to try to encourage them. Remember, we can't force them to do things. They are the ones that decide what they cover and what they don't. We don't have the legal authority to require them to do certain things. But we're talking to them because it just makes total sense. This is about saving a life. They might even save a lot of money by making sure naloxone is available, because if someone doesn't end up ODing, they may still cost a lot of money for the care that they're going to receive while they're in the hospital. So we're right now in the process of talking to the health insurance companies, those who offer Part D plans, to make sure they're clear. It makes total sense to make sure naloxone is available, even though it's no longer necessary through prescription, but can be available over the counter.
Thank you. And I hope that more plans will expand their supplemental benefits and take action to help seniors maintain their access to naloxone. And I stand ready to work with you on this important issue with my colleagues. I'd also like to discuss the work HHS is doing to better serve hard-to-reach populations. I applaud the Biden administration's effort to expand medication-assisted treatment and opioid treatment programs within the federal prisons. This is another area where I believe there's much work to be done, and I make it a priority in my months left in Congress. States and localities continue to struggle with the cost of providing mental health and substance use disorder services to incarcerated individuals under custody due to what's called the Medicaid inmate exclusion. Studies show, however, that for every dollar we spend to treat substance abuse in prison, we can save up to $7 down the road. That's a decent return on investment. We should maximize effective cost-saving treatments, and that's why I introduced my Rehabilitation and Recovery During Incarceration Act. This bill, which has bipartisan support, would reform the Medicaid inmate exclusion policy so that incarcerated individuals who are eligible for Medicaid can continue to receive mental health and substance use services. Secretary Becerra is our nation's top healthcare advisor and the former Attorney General of California. Can you explain how providing mental health care and substance use treatment in prison could actually keep our communities safer and healthier?
Congresswoman, we know that prison is supposed to be a place for rehabilitation. We know that most prisoners are at some point going to be released into the community again. It makes no sense to release someone into the community who is addicted or is still having behavioral health challenges. The more we do to get a prisoner ready for exit, the better prepared our community will be to bring them back into the fold. In fact, we are now making investments through Medicaid with states so that they can prepare those who are incarcerated in their process of exiting to be ready. So Medicaid will be available to them so they start right away with the health care they need. They may not have a place to live, they may not be integrated into society, but we'll make sure that at least health care is something that's available to them.
Thank you, and I encourage my colleagues to join our bipartisan bill, the Rehabilitation and Recovery During Incarceration Act. And it's a delight to have you with us. I'm so proud of your service. And with that, I yield back.
Thank you. The gentlelady yields back. Chair recognizes Mr. Obernolte from California for 5 minutes for questions.
Well, thank you very much, Mr. Chairman. Secretary Becerra, thank you for being here today. I appreciate your willingness to engage with us on the issue of the HHS budget. I'm one who believes that we don't have enough interaction.
As Mr. Sarbanes for 5 minutes for questions.
Thanks very much, Mr. Chairman. Secretary Becerra, thank you for being here, for your work and the Biden administration's work to protect and expand access to care and to lower costs for Americans, especially as you talked about prescription drug costs for our seniors. I want to discuss how this year's budget request provides some strong investments in a few particular areas, the first being our healthcare workforce. Like many on this dais, I've heard from providers and patients alike, you've certainly been hearing it about the very real challenges our healthcare system is facing as a result of tremendous workforce shortages that span every level of care. This year, I'm proud again to join with Representatives Blunt-Rochester and Representative Schreier in urging robust funding for HRSA's National Center for Health Workforce Analysis, which, as you know, provides critical high-quality data about supply and demand issues and oversees 9 research centers that provide technical assistance to regional and local groups. Can you discuss why investing in comprehensive data collection analysis initiatives like this are so vital to understanding the full scope of the workforce challenges we face and ensuring that we make the right policy choices to address them?
Congressman, because we know that too often the workforce goes where the money is, and unfortunately some of the deserts, healthcare deserts that we have that are desperately in need of more workforce won't get them. It might be rural America, it might be low-income America, and what we want to make sure is that we have the data that help us determine where we need to make sure that future healthcare workforce goes.
Thank you, and it's a smart investment. I've long believed that we can encourage individuals to pursue public service or other careers that may be paths less traveled for any number of reasons, lower salaries, what are perceived as less ideal geographic locations, et cetera, through programs that offer loan repayment assistance to those who commit to these positions for a given time. That is why I authored the Public Service Loan Forgiveness Program and helped create the STAR loan program for substance use disorder providers. It's also why I'm such a strong supporter the National Health Service Corps. Can you briefly speak to the investments this year's budget makes in helping relieve the student debt burden for critical primary and behavioral health care providers?
The budget, and thank you very much for your support, Congressman Sarbanes, over the years for this program, has made it possible for us to send thousands of healthcare professionals, doctors, nurses, others, into the field and helping mostly underserved communities. And my son-in-law, who is now a pediatrician, is one of those graduates of the program. He got his 4 years of medical school paid for, and the result is now he owes us 5 years of service in an underserved community, and that's exactly what he's doing. By the way,
he applied for that program way before I became secretary, so just so there's no confusion.
So
But
the
it
record
works.
is clear. Yeah.
It works. It really works.
Yeah.
There are some 19,000, I think, slots that we have to put the healthcare workforce out there. These are people who may not have otherwise had an opportunity to graduate and become the future doctors. So it is absolutely a great investment, not just for those people like my son-in-law, but for Americans who end up having a great pediatrician to offer services to their kids.
Yeah, let me punctuate the point you just made. It obviously helps those individuals fulfill their career aspiration, but it's more so what it does for the country, and that's why we support programs like that. It's critical that the pipeline that we're talking about right now be robust, particularly given the mental and behavioral health care crisis we face, especially among our youth. More data every day that supports that unfortunate circumstance. I've also long been an advocate for strong funding for school-based health centers. As you know, we've talked about this before, which meet children where they are at school to deliver care in a trusted setting. This year's budget includes robust investments, I see, in community health centers and their related programs, and increased funding for several youth mental and behavioral health care initiatives. How do you believe these investments can work together to ensure every child has access to treatment and prevention resources, as well as, should they need them, more acute crisis care interventions?
Congressman, as you know, there are a lot of phenomenal community health clinics out there in our communities who would love nothing more than to be able to reach into the schools to provide care directly, but they need some support. We put out about a $25 million grant proposal out there for a number of organizations to apply to help stimulate their interest in making that arrangement with schools. Today, we see far more young kids having access to health care through their schools. We want to continue to build on that. We're working through the Medicaid program to help schools qualify to actually get Medicaid reimbursement dollars directly into the schools, because we think the best place to offer a child who's especially low-income child health care is where they are 5 days a week.
It's a no-brainer. Thanks very much. I yield back.
Thank you. Gentleman yields back. Chair recognizes Mr. Latta for 5 minutes. Recognizes Mr. Obernolte from California for 5 minutes for questions.
Well, thank you very much, Mr. Chairman. Secretary Becerra, thank you for being here today. I appreciate your willingness to engage with us on the issue of the HHS budget. I'm one who believes that we don't have enough interaction between the executive and the legislative branches, and so the fact that you're here means a great deal to me. I'm a budget guy, and this purpose of this hearing is supposed to be to present the HHS budget for next year, and so I want to talk about the high-level numbers. So you're asking for a fiscal year 2025 budget of $130 billion in discretionary spending and $1.7 trillion in mandatory, for a total of about $1.84 trillion in budgetary authority. When I look and I compare that with last year totals about $1.7 trillion. So you're asking for about an 8.3% increase. One thing that stood out to me is that inflation over the last year has run about 3.5%. So you're proposing that we increase HHS spending by a rate that's over double the rate of inflation. Is that right?
We're not recommending it. In many cases, it's required because much of the increase that you mentioned is mandatory, which we don't have control over. It's by law, we have to provide it. So the Medicare beneficiary, the Medicaid beneficiary, that's automatic. And so if a population increases, as it has, a lot of the baby boomers are now into Medicare, we have to provide those services.
All right, so just projecting in the future, do you anticipate that in HHS spending will, on the path it's on, increase at over double the rate of inflation over the next few years?
Actually, I think if you take a close look, the discretionary part, which is the money that isn't mandatorily obligated, I think you're going to find that that's way, way smaller than what you, the percentage that you quoted.
Oh, certainly, but I mean, dollars are fungible, obviously, so when we care about the overall piece.
Not necessarily in this case between discretionary and mandatory. No, not necessarily.
Okay, we'll agree to disagree on that. Let me talk about this. Obviously, we have a problem with the federal budget. We're almost 30% in deficit. There are only three choices here. We can increase taxes, we can decrease spending, or we can borrow more money, and our national debt is already over $34 trillion. When you come to a budget with us with a budget that increases spending, I mean, that really is taking spending decreases off the table unless we make statutory changes to the law that decrease that mandatory piece. Or we could increase taxes, and I know your budget proposal has a proposal in there for increasing taxes, or we can deficit spend. So, I mean, of those three options, what do you think we ought to be doing?
Well, the president's budget responsibly makes investments. So, for example, I think you and I would agree that fentanyl is something we have to take on. I don't think you're going to say, let's shortchange our efforts to try to keep fentanyl out of the hands of Americans. So we want to make sure we're making the right investment there. I think you would agree that we want to make the right investments with behavioral health. Today, more and more children are dying from suicide than ever before. I think we want to improve our services. And so where we're making the investments, I hope you'll agree, it's important to do so. The president, though, in his budget, does make responsible choices in how to make sure we're covering the costs of much of what we're doing. And so I would say to you that the president's budget is extremely responsible because he tries to pay for what he does.
Sure. I mean, pay for maybe perhaps in the sense of incrementally, but overall the president's budget does not balance the budget. There's still a substantial amount of deficit spending, and healthcare spending is what's driving that. So let me ask you this. I mean, we will probably spend 18% of our gross domestic product this year on healthcare spending. That compares with much lower levelers in other countries. For example, the UK, which has a socialized healthcare system, spends about 10%, maybe even less than 10%, and has, by a lot of metrics, better healthcare outcomes than we do. And there are other countries like Singapore that spend a third what we do and have substantially better healthcare outcomes. So by a lot of metrics, the United States has the least efficient healthcare system in the world.
I would agree.
So what should we be doing about that?
I had a conversation with my friend, the health minister from Singapore and also from Indonesia on these subjects, and they do a lot more early intervention care, preventative care, so that way they can tackle health issues before they get really expensive, become chronic diseases. We don't do that well enough, and because we have a system of healthcare that is essentially governed by 50 states, not the federal government, you have a patchwork. Some states do better, some states don't. And if we could even that out and also focus early, my mom used to say, mejor prevenir que remediar, better to prevent than to remediate, we get to tackle those things better.
Yeah, I would agree with that, but also add that we need to restore the functionality of healthcare markets in the way that other countries have done. But I see that I'm out of time. I'd love to continue our discussion. Thank you very much again.
Thanks. The gentleman yields back, and the chair recognizes Ms. Trahan for 5 minutes for questions.
Thank you, Mr. Chairman. It's great to see you, Secretary Becerra.
Recognizes Ms. Kelly for 5 minutes for questions.
Thank you, Chair Guffrey and Ranking Member Eshoo and Secretary Becerra. Good to see you. As you know, I'm a strong supporter of FDA's efforts to prohibit menthol cigarettes and have led numerous letters signed by the majority of CBC colleagues to the administration in support of the rule, and I truly appreciate the leadership of HHS and FDA in sending the menthol rule to the White House for final review. Any idea that you can share of timeline? I know it's been a kind of slow walked. Any ideas, and will you commit to still being on the right side of this rule?
I have to begin first, Congresswoman, by saying we owe you for the work that you've done to try to help get this across the finish line. I think you do it because you know what it means. It means a lot of lives saved, especially in the black community, because menthol cigarettes impact the lives of more people in the black community than anywhere else. And so for that, we are indebted to you. And I hope you do, those jets, I hope, still have a lot of fuel in them. I can't give you a particular timeline. It is in the process. You know, when we see the white smoke, we can cheer if we get to see it, but please just don't stop. You continue to do the work you're doing.
I will not stop. Quickly, my grandparents owned a mom and pop grocery store in New York, and now when I think back how many people was in Harlem asked for Kohl's or Salem or Newports. So,
that was intentional on the part of the industry.
I know. I also want to commend the administration for its commitment to safeguarding and enhancing access to comprehensive range of reproductive health services nationwide. The allocation of $376 million to address disparities in maternal mortality and morbidity is a crucial investment in saving the lives of Black and Indigenous moms and birthing parents who are so unduly burdened with negative birth outcomes. But what concerns me, I hear from so many providers and groups, especially those in minority populations or those in rural areas, that they are unable to access the funding streams from the administration. A notable illustration of this issue is evident in last year's KFF report, which revealed that no Black rural areas have received any rural maternity and obstetrics management strategies funding until concerns were raised by me and others. So how will the administration work to ensure that funding, reaches the areas that really need it most at the end of the day, and not just the bigger organizations, but really the community organizations also?
And Congresswoman, I was recently in both Mississippi and Alabama, and we spoke, and I met with a group of healthcare leaders, mostly from the Black community, about this, but on a number of issues, but this obviously came up as well. What I can tell you is that we're trying to reach all those communities, because the purpose of, in fact, the President's budget calls for more than $370 million to address this maternal mortality and morbidity issue. We wanted to reach the right communities. So if there's something that we're not doing that you think we should, please let us know. We are reaching out. As I said, I traveled to states where this is a big issue. We're going to do everything we can, but we could use some help.
Okay. And I just, we are putting on a Black Maternal Health Forum right now, and I just left Congresswoman Sewell. So I think, meeting with us, would help. And she just talked about it in her area, but thank you. My last question, CMS has proposed a rule that will make sweeping changes to how Medicaid drug rebates will be calculated. Several provider and patient groups have reached out expressing concern regarding the potential unintended consequences this rule could have on patient care and access. Given that this proposal is still under consideration, would your office be willing to follow up with me regarding the concerns?
Absolutely, we'll follow up with you, and I can guarantee you we're not going to do something that's going to impact patient care.
Appreciate that. Thank you so much, and keep up the great work. Thank you.
Gentlelady yields back. Chair recognizes Dr. Bashan for 5 minutes for questions.
Secretary Becerra, on maternal mortality, I would suggest visiting Parkland Hospital in Dallas and reviewing their program. They testified in front of our committee. They have outstanding results, and their patient mix is uninsured, minority populations. Their results on this issue are outstanding. You might talk to them.
We'll follow up with you on that.
Yeah. There are many issues I would like to cover, including HRSA's effort to modernize the organ procurement and transplant network after my legislation 2544 was signed into law, and I've had that discussion with HRSA. Honestly, the lack of work being done on smoking cessation and cigarette alternatives at the FDA, we need to do more and be more aggressive there. And as was mentioned earlier, in my view, the misguided nature of the FDA's proposed rule on laboratory-developed tests, classifying them as medical devices. We need a law similar to the VALID Act, introduced by Diana DeGette and myself instead, in my view. We'd like for the agency to continue supporting KidneyX. I'm co-chair of the House Kidney Caucus. Innovation in kidney care is still critically important. But instead, I'm going to talk about surprise billing today. But all those issues, I think I'm going to submit some questions for the record. We want to revisit that topic. I believe that the bill was in a good place when it went to the floor and ultimately was signed into law. I was assured that it was written in a way that could be implemented for good, to ensure patients were protected from surprise medical bills, to encourage insurance companies to expand their networks, and to give providers fair compensation for out-of-network services. It evidently must lack the mechanisms necessary to accomplish some of these core objectives. We know that arbitration is occurring as intended, and according to recent reports, providers are more often winning than not. However, but I hear on a regular basis that from those who have, in quotations, won at arbitration and just aren't being paid what they're owed by the insurance company, in many cases not being paid at all. Thousands and thousands of claims. The decision just sits there, and plans are forcing doctors out of network inappropriately then to leverage them for reimbursement rates under the No Surprises Act, which would be lower. So can HHS provide guidance to insurers that they must pay out arbitration awards within a set time frame? And are there penalties in statute that can be levied for noncompliance?
Congressman, as you know, in our regulations, we stipulate that the losing party must pay, and I mentioned it earlier, the losing party must pay within 30 days. Now, here's part of the rub.
Correct.
We are not part of the dispute resolution process, the HHS, and so when a resolution is reached, we don't hear about it. We don't get information.
Labor, Department of Labor?
I don't know if even the Department of Labor gets the information, because it's a dispute that's between the two parties. What I would suggest is that the winning party, usually and more often than not, it's the providers, that they contact our help desk that we've set up to provide services. So the quicker we hear about it, the quicker we can make sure we enforce if they're not getting their payments within 30 days.
Yeah, I mean, you realize that an independent small practice fighting
Absolutely.
against one of the behemoth insurance companies is
Absolutely.
David versus Goliath, right?
Absolutely.
And the insurance plans they got more lawyers and they got more money.
Absolutely.
So we're going to need the agencies to. I would specifically like to know if there are penalties in the statute for noncompliance that can be levied, and if there are not, should Congress act to give you or whatever agency it is that authority?
We have the authority to try to push on the payment, and I don't want to misspeak as far as how far authority goes, but it is an obligation, a contractual obligation, because when you engage in that dispute resolution, you have essentially agreed to live by the resolution. So we can probably assist in trying to make that enforcement.
Well, if we can look into that, because it's not happening.
Yeah, I'd be more than willing to work with you.
We got to look into that.
And by the way, I completely agree that the little guys who win, those are the ones that suffer the most.
They
And
do.
So, whatever we can do,
Okay.
work with you.
Secondly, and I'll be quick here, ghost contracting remains a problem with respect to the way insurers determine their qualified payment amounts for QPAs. When insurers calculate the QPAs that include contracted rates for physicians who do not actually bill for those codes, these ghost contracts can dramatically reduce QPAs, resulting in payment levels that do not reflect true market median in-network payments. Can HHS provide more guidance to insurers that QPAs should be calculated on volume-weighted codes actually billed by the providers in question? This is a problem.
I'm with you, but now recognize that we conduct those audits if we have the personnel and resources to do them. And right now, because of the volume of cases, so much of our resources had to be focused on getting ready for the dispute resolution. So I'm going to plead with you now, Congressman, to make sure you help us before our funding runs out. Please make sure that you allocate some money so we can actually do the audits.
Okay, because this would result in more accurate payments and thereby dramatically reduce the number of claims
Agreed.
going to the IDR process.
Agreed.
With that, I yield back. Thank you.
Gentleman yields
Thank you.
back. Mr. Hudson's recognized for 5 minutes.
Mr. Secretary, thank you for joining us here today. As you probably know,
Recognize Ms. Becerra for 5 minutes.
Thank you, Mr. Chairman. Thank you, Secretary Becerra, for being here, for all you're doing. When I first walked into the hearing earlier, the chairman was in this opening statement and was talking about the border, and I thought I walked into the wrong congressional hearing. What I heard was expressing a disappointment that the budget request didn't address the influx of illicit drugs like fentanyl, which are coming across our border at a rapid rate. I just want the American people to know that President Biden had a supplemental request that had $850 million that he was asking for to help combat fentanyl from crossing the southern border. Another $100 million for HSI, which is investigations from crossing the southern border regarding fentanyl, and the hiring of more Border Patrol agents for this very reason. So the President of the United States and this administration asked for money, millions of dollars, hundreds of millions of dollars. And it is Republicans who said no to that. So expressing a disappointment about the lack of money in the budget for that is a little rich, considering the President asked for the money and Congress, with the Republicans in charge, have said no. And with that said, Mr. Secretary, I'm going to move on to my questions I have for you. I want to thank you for all you're doing on health care, all you're doing in the space of women's reproductive rights, and all you're doing on Alzheimer's. And my first question is on Alzheimer's, Mr. Secretary. 85% of initial diagnoses of Alzheimer's are made by clinicians who are usually primary care providers. And half of these providers reported that they do not feel adequately prepared to care for those individuals. That's why I've introduced a bill called the ADAPT Act with my Republican colleague, Representative Carter, which would empower primary care providers to better diagnose Alzheimer's and deliver high-quality personal-centered care. As the number of people with dementia is set to increase, how will HHS work to support workforce readiness as well as access to treatments and services?
Congresswoman, thank you for the question and all the work you've done on this issue of dementia. We are continuing to work to try to make sure that as we graduate the next generation of physicians, nurses, that we have them going into the areas that we need them most. And so we are trying to make sure that GME, graduate medical education slots, are going into those spaces. We're trying to make sure that, as you just mentioned, a primary care physician gets training beyond what they currently get in most medical schools. I focused earlier on the issue of behavioral health because too many family care doctors, too many internists are not really trained on behavioral health services, and that means someone going in with a child that has behavioral health challenges has to wait to get to a specialist before they start to get the care. Very similar to the question you're asking with regard to Alzheimer's. We would be very supportive of any initiatives, especially if they come with resources, so we can make sure we can implement that to make sure the healthcare workforce actually addresses the needs of the populations that we're seeing grow.
Great. Thank you, Mr. Secretary. I also want to thank you for demonstrated commitment in the budget, to cut the cancer death rate by 50% over the next 25 years, which includes implementation of President Biden's Cancer Moonshot Initiative. Every 3 minutes, someone in the U.S. is diagnosed with blood cancer. One such cancer is multiple myeloma, where early detection is key to effective treatments. My sister has multiple myeloma. She's only 2 years older than I am. Of course, our colleague, Republican Steve Scalise, has been battling multiple myeloma, and so I know firsthand, what he's going through with the stem cell transplant and ongoing chemomeds people take. Can you share the importance of funds for the Advanced Research Projects Agency to improve early detection of such cancers?
Congresswoman, ARPA-H, the agency you just referenced, unlike the National Institute of Health, when it engages in a research program, it is not the long-term 10, 15-year process that NIH usually goes through to try to get some innovative therapy on the ground. ARPA-H is meant to harness those innovative ideas that are out there in America but haven't yet been catalyzed with resources. And ARPA-H says, if you can get something going in the next 2 or 3 years, then you're in ARPA-H's space. And so something like the issue of cancer, if there's an innovative idea on how to address any number of cancers, ARPA-H is a great platform, so long as that proposal can get out there within 2 or 3 years.
Well, thank you. I'm interested in working with the agency on the Moonshot Initiative, especially on blood cancers, because there is no formal program at the Centers for Disease Control and Prevention, so hopefully we can get that on a bipartisan basis done. And with that, thank you, Mr. Secretary. I yield back.
Gentleman yields back. Recognize Mr. Pence, 5 minutes.
Thank you, Mr. Chairman. Thank you, Ms. Secretary, for 5 minutes.
Secretary Becerra, in your final rule titled Non-Discrimination in Health Plans and Activities, you mandate that private health plans provide sex change operations on children and abortions for minors or risk losing their federal funding. And this rule certainly would violate the religious conscience of thousands of doctors and medical providers. What would your department do if a doctor refused to provide the treatments mandated by this rule?
Congresswoman, first, that was not accurate what you said, and a provider, if they, for religious reasons, object, they are not forced to provide any particular service.
Well, your rule says that gender identity and sexuality is protected under the title Sex Discrimination. It says that a doctor cannot refuse service to a patient for that care, and I actually don't believe you. Your department has a history of violating the closely held religious beliefs of people, and doctors do need to know. Would you tell me today, can you commit here today that your department will not withhold federal funding from hospitals or doctors who refuse to provide the gender-affirming care that you are, mandating, if it violates their religious beliefs.
So now, Congressman, recognize you're going somewhere completely different. First, you started talking about how a doctor should have the rights to not offer particular care. Then you stretch it out to provide for the system-wide services that
Yes,
are
you've
very
put out
different.
this guidance.
Very different.
You've put out this guidance, and doctors do need to know.
Yes.
What are you going to do if they refuse to provide this care?
A doctor, if that doctor has religious objections, that doctor, under these rules, is not required to offer the
Okay,
care.
so you're committing here today that you will not withhold federal funding,
Doctors don't get federal funding, ma'am.
but the hospitals do.
Okay, so now talk to me about the
Are you saying that the...
Don't confuse the two.
Okay.
A doctor's not a hospital.
But the doctors are working in these hospitals. Are you going to say, today, are you committing that you will not withhold federal funding from those healthcare facilities?
If a healthcare facility is violating the law and not providing the service they're required to,
We
they are
knew
not
that
entitled
you
to the
would
resources.
withdraw federal funding. Mr. Secretary, the United Kingdom recently banned private health providers from performing gender-affirming care on minors. Their decision relied on a study that stated puberty blockers may damage a minor's ability to think and reason, and that the rationale for suppressing puberty at all remains unclear. Mr. Secretary, are you worried that other countries are banning puberty blockers for children, while here in the United States, the number of children on puberty blockers continues to increase each year, as you can see here?
Congresswoman, we rely on the best medical evidence in knowing what services to provide or to support and provide reimbursement for.
Your department is marketing these drugs to children. The guidance on your website tells children how great puberty blockers are. And so you're getting what I want to stop people like you that are forcing these non-reversible treatments on children. I'm asking on behalf of parents across the country.
Yeah, and if you would accurately portray what we were doing, it'd be easier to respond to your questions. But you continue to mischaracterize what we said.
I'm not mischaracterizing you or what you're
read,
promoting.
Read them what
you
we're
have
doing.
Put out this guidance.
Congresswoman, why don't you read what our regulation
You are promoting the use
says?
of dangerous, toxic chemicals that are not reversible, that are experimental. You are promoting unnecessary surgical mutilation, and it is a fact that 80% of our youth that struggle with gender dysphoria end up growing out of it. And I can say that no rational or compassionate person would be promoting this. Joe Biden and his administration are attempting to force doctors and medical providers to go against their closely held religious beliefs and are forcing toxic experimental drugs on young children. It is a fact. These drugs and procedures have serious side effects and will take away their ability to ever have children. The Biden administration is also distorting the ruling in Bostock to push their far-left political agenda. Justice Gorsuch was clear in his majority opinion that this ruling only applies to Title VII. It does not give Joe Biden license to push radical policies like this rule. History will show how wrong you and Joe Biden are on this issue. Thank you, and I yield back to Dr. Fox.
Thank you. You're recognized for 5 minutes.
Mr. Secretary, under federal law, folks who are here illegally in this country aren't eligible for Medicaid benefits, but some states have circumvented this by using state funds to expand eligibility for their Medicaid programs to the entire population of undocumented immigrants. Do you support those initiatives?
Congressman, they haven't circumvented any law. They're just using their own state resources to do what they want for the populations
Sure.
in their
Do
state.
you support those initiatives?
Absolutely.
You do. You support expanding eligibility like your own state of California has at a cost of $3 billion to every person who's in the state illegally.
The state has decided it wants to make sure as many of its people, if not all of them, have access to health care.
So you just said you support that. Is that administration policy or your policy?
You asked me, and I answered as an individual.
Do. Okay. Do you know if the administration has a position on it? Do they agree with you and support that policy?
The administration wouldn't interfere with the state's decision to use its own money.
Sure, but you said you support it. So does the administration support expanding eligibility for Medicaid programs to all undocumented immigrants?
Congressman, as you know, we use federal dollars and we make sure the federal dollars are used properly. A state can use its state dollars as it wishes.
So you support it personally, but not necessarily the administration?
No, I don't want to speak for the administration because we wouldn't have a position on how a state, your state, my state, uses its own dollars.
Well, I'm sure you do. You would. I mean, there's all kinds of positions the president has about what states are doing, but he hasn't spoken.
Okay, then you can ask the president.
Okay. You started your testimony by talking about COVID, and you said we can now manage it like the flu. Yet there are 30 universities in this country that still have COVID-19 vaccine mandates for students. Do you think it's time they ended those?
They're managing it.
I'm sorry?
We're trying to manage COVID, and everyone can manage it as they see fit.
Well, that's certainly not how the administration conducted its policy during the pandemic. There were all kinds of mandates and various programs. So is there any authority, health authority under your jurisdiction that at this point even recommends universities to have COVID vaccine mandates?
The recommendations principally put out by the CDC show best practices that everyone can employ.
Right. So do they recommend vaccine mandates at universities right now?
The recommendations are pretty clear, and states can then do what they wish.
Is that a yes or no for universities?
It's the states have the ability to do what they believe is best for their
So just right
population.
now, you as the Secretary of Health and Human Services, you have no opinion on whether it's a good thing for these universities to continue their COVID vaccine mandates in May of 2024?
Well, we've expressed what we think is best practice in those policies that have been articulated by the CDC.
Okay, so is it best practice right now for a university to have a vaccine mandate for COVID or not?
Well, the best practices have been set out by CDC. Then any entity, whether it's a university or state, then decides how it wants to move forward.
What's the best practice for a university? Should they have vaccine mandates now, yes or no?
There are thousands of universities. I'm not going to speak for thousands of universities.
Are you familiar with the Biolab that was discovered in Reedley, California, that was set up with links to China?
I'm familiar with it.
This was discovered last year or maybe even sooner, and there were all kinds of pathogens there. It was actually set up by an international fugitive named Jesse Zhu, who's currently under federal indictment. Local officials found pathogens like E. coli, hepatitis B, hepatitis C, HIV, malaria, and others. And yet when local officials reached out to the CDC for help, they refused to provide it. This is from a report from the Select Committee on the Chinese Communist Party. It says, based on their initial observation in March 2023, local officials began to reach out to additional federal authorities for assistance. Local officials spent months repeatedly trying to obtain assistance from the CDC, but the CDC refused to speak with them. And on a number of occasions, it was reported by local officials that the CDC hung up on them mid-conversation. So why didn't the CDC come in and try to help when local officials discovered this situation?
I don't think that's an accurate representation of what CDC has done.
They did. You disagree with the committee's report?
I don't think it's an accurate description of what CDC has done.
I see. Did the CDC test the samples they found at the lab?
I'd have to get back to you on what the CDC precisely did.
Because according to the report here, the local officials asked them to test these samples, these dangerous pathogens, and they didn't do so. Does that sound inaccurate to you?
I think you're leaving out a good part of the story.
What part is that?
I'd have to get back to you because I don't have a direct understanding right now. Again, I came to testify on budget, but I can get back to you and let you know what CDC did or didn't do.
Do you have confidence right now that there aren't similar labs with links to the Chinese Communist Party in the United States?
Recognizing that these labs are licensed by the states, the 50 states, and not by the federal government, it'd be difficult for me to answer that question. The states don't work for me.
Well, I mean, but you do have responsibility for public health in this country. And so right now, as the Secretary of Health and Human Services, do you have confidence that there aren't similar illegal biolabs like the one that was discovered in Reedley throughout this country?
I don't know what every state has in its governance rules for the establishment of some of these labs. So if the question is, do I have confidence that all the states are doing the right thing, I'd have to say, probably not.
Thank you. I yield back.
Ms. Hayes, you're recognized for 5 minutes. Recognized for 5 minutes.
Thank you, Secretary Becerra, for being here with us today. Since DOPS, Republican politicians have been attacking women's reproductive health care and in turn jeopardizing the lives of millions of women. Can you tell us what steps HHS has taken to ensure that women continue to have access to comprehensive reproductive health care, including abortion?
Congresswoman, we've taken a number of steps. Obviously, everything will fall short of what the protections that Roe versus Wade had provided to women. But, for example, we have gone all the way to the Supreme Court to protect a woman's access to medication abortion, mifepristone. We have gone all the way to the Supreme Court protecting a woman's right to emergency care services. We are continuing to enforce laws that require providers and insurers to offer contraception services to women. We just issued a rule that would protect the privacy, health information privacy of women and their providers, so that that can't be used against them. I could go on, but I suspect you have more questions.
No, thank you so much for that answer. I'm really concerned about the epidemic of the opioid crisis that we are looking at, that is shattering the lives of thousands of people across Minnesota. My family has lost close and personal friends to this epidemic. In Minnesota, opioid-involved overdose deaths increased 43% from 2020 to 2022. The number of deaths has more than doubled since 2019. Indigenous Minnesotans are dying at over 9 times the rate of white Minnesotans, and Black Minnesotans at over 3 times that rate. And we're seeing a disturbing increase in addiction rates among the East African immigrant population. I'm deeply concerned about these disparities and about ensuring that hard-to-reach communities are receiving the care and services that they need. I see that in the budget, you have requested $1.6 billion for the state opioid response grant and $2 million for the youth prevention and recovery initiatives specifically. Can you tell us what steps the agency is taking to make sure that the federal funding is going towards culturally competent care? And how are you going to serve the underserved populations?
And Congresswoman, we are making every effort to try to encourage states to adopt culturally competent programs so that they can reach populations that are often neglected or underserved. We continue to try to stand up opportunities for them to get funding to increase the number of clinicians and professionals who are coming from communities where there is a shortage of those individuals. We could use more resources to really push the envelope on this, but we are making every effort, for example, to also collect data that gives us a better sight on where there are absences of the professionals that we need. And we're trying to also recruit people, help states recruit people who have lived experience, so that when they go out to be the professional, they've gone through some of those experiences that they're now trying to help people with.
And it looks like those impacted are getting younger and younger. I know that there are resources that are focused on education and deterrence. What do you think can be done to better assist folks who are already addicted, as well as the parents, considering that many of those suffering are under the age of consent and need their parents' approval for treatment?
I've mentioned on several occasions already how we are trying to get states to adopt Medicaid innovations that would allow us to use Medicaid dollars in a school to provide behavioral health services in a school, so a child and a family member doesn't have to wait until you find a doctor that you can send your child to help with substance abuse or mental health services. We are hoping there are about 15 states that have worked with us to change their programs, their Medicaid programs, to accept those dollars. We have several programs, one called Project Aware, that's specifically focused on children to try to help them address issues like drug use, suicide prevention, and we're trying to expand those services, working with states to see if they'll adopt them.
Yeah. Our kids are really in desperate need, so I hope those services reach them. Thank you so much.
Thank you. Mr. Kiley, you're recognized for 5 minutes.
I yield back.
Okay, I guess I'll call on myself for 5 minutes. I'd like to talk a little bit about the Office of Refugee Resettlement. How many minors without parents do you know how many have been allowed in this country in the last 3 years?
Congressman, I don't have the precise number, but it's been over 100,000 over the last few years each year.
How many each year?
Over 100,000.
Every year, so every year in this country, we let 100,000 kids in without either parent, right?
We process these children and they come to our custody because they're unaccompanied children.
Okay. Do you know how many you are keeping track of right now, or how long you keep track of? If a 14-year-old shows up at the border, how long do we keep track of them?
So to clarify the way this works, if a child crosses the border, does not have an adult supervisor, DHS, Department of Homeland Security, has 72 hours within which they must transfer that child into HHS's care because they're not equipped to handle children. We then will process the children, get all the information on the child. We then hold custody of that child as we work to find a sponsor who we vet, because by law, we're supposed to place that child in the most appropriate setting for children, and it's not in large congregate care. So we go through that process.
Percentage-wise, how many are going to another relative?
How many are going to a relative?
Yeah.
The vast majority.
Okay. Do we do DNA testing to make sure it's really a relative?
DNA testing is one of the tools we use to try to identify the individuals who are seeking to be
How
sponsored.
frequently, percentage-wise, do we do a DNA test?
It depends, because oftentimes we get some very credible information on the identity of both the child and the sponsor. And so if we need to do the confirmation, we'll go to something like DNA.
Do we know to this day where those kids are, whether they move on somewhere else? And even if it is a relative, say an uncle or whatever, do we do follow-up to see whether they're in an appropriate place?
Yeah, and as I tried to mention before, we have the records of the sponsors, and so we can reach out to the sponsors to find out about these children afterwards.
I think the New York Times once published something, and I don't quite believe their numbers, but
they're not correct.
A large number, I will believe that tens of thousands of children out of this country, and we don't know where they are or who's taking care of them. Is that true?
So people talk about them being lost. That's all inaccurate. Remember that they are placed with a sponsor. We no longer have jurisdiction to follow up with them. We try, because we think it's important, best interest of the children, we make an effort to try to contact both the child and the sponsor 3 different times.
Okay, go ahead.
Yeah, 3 different times. And the number that you're citing from the New York Times is based on the fact that some of those children and sponsors don't respond to us. We don't have the authority to make them respond. They're not lost.
That's of interest, though. I guess I'm for keeping families together, okay? And I'm going to give you 2 more questions.
Yes.
Do you feel that if somebody comes here without a parent, 14-year-old or 15-year-old, why don't we at least try to turn them back to their country of origin? Is there any reason why we don't do that? If a 14-year-old kid shows up, my parents aren't here, well, we're going to look for a foster parent. Why don't we send them back home where maybe their parents can take care of them?
Congressman, that may be the end result. The difficulty is...
Maybe, but why isn't it the norm?
Well, I can't say it's not the norm. What I can tell you is it takes so long to process the case of that child in immigration court that it could be 4 or 5 years before we finally decide what the status of the child will be, whether the child stays or whether the child goes back. And so it's the fact that the process takes so long that leaves this child in limbo.
I'm going to go ahead, one more question.
Yeah.
Even if in our country, if there's a divorce or something, our court system tries to keep both parents in contact with the child.
Yes.
It bothers me that when a parent shows up with one child in this country, we can allow them in this country rather than saying, hey, wait a minute, you're here from whatever country, you're from Brazil. Why don't we wait and you see if you can come here with both parents? We're not going to take a parent and a child and leave the other parent in some other country. When we wouldn't allow that, maybe even for a parent to move to a different state. Why don't we, at least in that case, try to keep the families intact?
You have struck on the problem we have with the broken immigration system. We can't do that because everyone is entitled to a due process hearing, and because it takes forever to hold the hearing, we can't get to the point of adjudicating to what you just said. That's the difficulty when you have a broken system that doesn't let you process all these individuals, not just the kids, but the adults as well. It takes forever to finally get justice, whatever that justice might be. It may be going back to the home country.
Dr. Adams?
Thank you, Mr. Chairman. Thank you, Secretary Becerra, for testifying before the committee today, and certainly I enjoyed having you in my district.
Yield back, Madam Chairwoman.
Thank you. Mr. Owens, you're recognized for 5 minutes.
Thank you. Mr. Secretary, I hadn't planned on going this direction, but can't help it at this point. We just had one of my colleagues talk about some of the evil that's happening at our border. There's no longer a rapid DNA test as of June of 2023 because of the Biden administration, which means we can no longer tie children coming across the border with the people bringing them across the border. There's reports of 85,000 children being lost. So far, the best you can give us is that they're not lost, it's just the people are not answering the phone. We're now hearing about children being used and reused, going back and forth to the border because of the cartel. We're talking about slavery, rape, abuse of children, stealing of children. You say that if this was your child, you'd do everything they could to stop it. What about other people's children? How can you remain part of an administration that allows this evil to happen? We talk about it, we're going to take lunch in a little bit, we move on, and nobody thinks about it other than the folks that are being impacted. These parents, that the children are being stolen, they can't just give it up the way it seems like the my administration is doing. Let me just say this, because it appears that there's a big hit on private market. Let me tell you what happened to this in the private market. A private company did the same thing, they'd be shut down after losing the first 10 kids. And then those who would be responsible for it, we'll find them in orange suits, paying a price for decades because of losing 85,000 children. So I think it's disgusting, to be honest with you. We're not in the 1800s, slave trading. We're not in the 1930s, where we're allowed the Nazis to do the same thing with the Jews. We are seeing this real time. We're sitting here talking about the lives of children, adults, and yet there seems to be no concern about resolving it. Let me do this. I need to say that I've heard your answer, so I know right now that's not on the top of your agenda. There's a plethora of rules coming through our administration, this administration. A new rule called the Non-Discrimination in Health Programs and Activities is an example of one of the rules that HHA members are now have put together. I'm curious, who on your team is responsible for putting together and deciding on these rules? Do you have a team, a group of people that do this, that say this is what we're going to do now for this particular industry?
We have a very large team because we have a number of agencies. We have CMS, we have NIH,
okay,
we have
but
DA.
Within those agencies, there has to be somebody. Do you have a small team? That has to be somebody making these rules.
That's correct.
All right. So who are they? Is it possible to get names of these bureaucrats that are changing literally the industries that we see across the board?
I'm not sure I understand, Congressman. That all goes through a public comment period. Everybody sees what we're doing.
Well, I'm sorry?
There's no rule that becomes final that hasn't gone through a public comment where you and everyone else has a
Well,
chance
you go through that
to take a look
process,
at it.
but there's somebody that comes up with the rules. We're talking about right now.
Before that rule becomes final, you get to see it. Everyone gets to see it.
I'm not talking about what goes through the process. Who makes up these rules? Who is it sitting at the table? Or you have physicians that are sitting at the table when it comes down to that's going to be impacting physicians?
Yes.
Okay, so this rule you have here, the Non-Discrimination in Health Program. From what I understand, by the way, physicians do have the religious liberties, right? They still have that opportunity to be able to act based on their religious conscience.
Everyone does.
Okay, so the Non-Discrimination in Health Program, would that require doctors to provide gender-affirming care regardless of their religious beliefs?
No one is forced to do anything that goes beyond their.
So even though it's a rule, they are not forced to do this in their situation, in their industries.
The rule does not force any physician to do something that's against their religious beliefs.
Okay. Well, I was told differently, but we'll make sure we follow up on that one.
Yeah.
If in case.
Go ahead and correct them.
All right, so I guess in this case here, then the rules really are not rules. It's not just a suggestion.
No, these are rules.
Okay. All right. So if it's a rule, are you saying then that they can decide not to just do whatever the rule might say then?
If it goes against their religious beliefs, Under the law, they have protections for their religious beliefs. Therefore, they would not be forced to do something that goes against their religious beliefs.
Okay. All right. Well, I'm glad to hear that. I was told a little differently. Let's just wrap up then. I just have a few seconds. We're going to make sure I think American people hold this administration accountable for what's happening at the border. 85,000 lives, innocent children, is not acceptable in this country, no longer. And the fact that you're in a position, in the administration, you should have some sway to make sure those that are part of this process are making changes. So,
Congressman, if I could just, in 5 seconds, just respond. Yes. If 85,000 children were lost, you, me, everyone in this room would have taken action. That number is inaccurate. That's not a statistic that's real.
So what is the real number? How many have been lost?
That's the thing. They're not lost. They're
just not answering the phone. In other words, the sponsor's not answering the phone.
Well, Congress did not give anyone in the federal
let me just say this. When you leave it, you give it to a sponsor, they do not answer the phone, you don't know where those kids are, they are lost. Let's just if you don't know where they are, you don't have their address, you can't go and pick them up, you can't look, do a welfare, they are lost.
Accurate.
Okay, with that, I want to yield back my time. Thank you.
Yeah. We'd invite the Secretary to send us proof that you know where those kids are. Ms. McBath, you're right. Thank you, Ms. McBath. Mr. Good, you're recognized for 5 minutes.
Thank you, Madam Chair, and welcome back, Director Becerra. I appreciate you being here, Secretary. Do you think abortion is a good thing?
I think my wife is an OBGYN. I will tell you that.
Do you think abortion is a good thing?
Congressman, if it's a service that's needed in terms of providing good health care.
Do you think abortion is a good thing?
I think abortion is a service that's essential for many women.
Do you think abortion is a good thing? That would be a yes or no answer.
I think I've answered your question, but
you haven't answered it. Do you think abortion is a good thing?
I think for many women it is a resource.
Do you think abortion is a good thing?
I think for many women.
Okay, so do you think abortion is something that should be reduced or something that should be expanded?
I think women should have access to the health care.
Do you think abortion is something that should be reduced or something that should be expanded?
I think women should have access to the health care.
Do you think that abortion should be reduced or expanded? Do you think it's something that's a good thing that should be expanded? We ought to have more of it and celebrate that as success? Or do you think it ought to be reduced? It's a bad thing. We ought to do everything we can to reduce abortion. What is your view on that? That's a pretty simple thing, one or two of the directions.
Do I think having access to health care is a good thing?
Which one do you believe should be reduced or expanded?
The question is, do I think having access to health care is a good thing? Having access to health care is a good thing.
Okay, I didn't ask you about health care. I asked you about abortion.
Abortion is health care.
So killing a child, terminating a child in the womb is health care.
Access to the health care a woman needs.
That would make sense that that's how you would view it with your policies on it. On May 6th, HHS issued a final rule titled Non-Discrimination in Health Programs and Activities that uses Affordable Care Act to advance the radical left, that would be you, agenda to redefine sex by including sexual orientation and gender identity as classes protected from discrimination. But further, the rule also says discrimination on the basis of pregnancy termination can be a form of sex discrimination. Let me read that again. The rule says discrimination on the basis of pregnancy termination can be a form of sex discrimination. Can you explain what this means? I mean, how is pregnancy termination now a class of people that needs to be protected?
Women need access to care. If they need reproductive care and they're denied it, they are now having their rights abridged.
So if we don't provide coverage for the termination of a pregnancy, the killing of a child in the womb, which, by the way, I might add, the number one killer in America is what? Your Health and Human Services. What's the number one killer in America?
Why don't you tell me, since you're going to tell me what anyway?
Go ahead. What is the number one killer in America?
I'll let you tell me. You don't seem to want to have me answer your questions.
So heart disease or cancer, there are numbers 2 and 3. Number one killer in America is abortion. Number one killer in America is abortion. So your rule says that if a woman's health insurance plan isn't giving her the unfettered right to end her child's life, then she can claim she's been discriminated against. That's correct?
The way you described it, no.
Okay, why don't you clarify then?
A woman should have access to the care that she needs.
Would not, let me ask that a different way. So it would not be discrimination to not cover the ability for a woman to kill her child in the womb. For that not to be covered is not discrimination. You're not saying that.
I wouldn't characterize it the way you have, so I can try to answer the question, but I wouldn't answer the question that you've posed, because it's posed inaccurately.
Do you believe that someone who opposes abortion should be accused of discriminating against a woman because they choose not to end the life of a child? Is that discrimination? If you oppose abortion, you oppose the termination of life in the womb, the killing of a child in the womb, that's discrimination?
If a person is being denied the health care that they need, then that requires action to be taken.
So it's bad enough that this regulation applies to Obamacare, but of course you didn't stop there. The rule also states that the HHS Office of Civil Rights will extend non-discrimination enforcement to third-party administrators contracting with group health plans that are self-funded. So this is reaching into a whole new category of private insurance. So now, under your regime, every employer-sponsored health plan would be required to provide gender-affirming procedures. That's an interesting term that you and your colleagues like to use, and abortions. And it could even force medical professionals to violate their expertise if they believe these procedures are wrong or harmful, which they are, or their beliefs on the best care in a plan for individuals, particularly children. Worse yet, your budget proposes a $17 million increase to the Office of Civil Rights so you can weaponize the department against doctors who don't want to provide abortions to women. So the question is, why do you and the rest of the Biden administration, why are you so determined to violate Americans' religious beliefs through abortion and so-called gender reassignment mandates? They are mandates, but why are you so determined to violate Americans' religious beliefs through that?
We're not. We actually protect and are willing to enforce the religious beliefs and conscious protections that are afforded to all Americans.
Well, we don't see that in this rule. There's no
I
need
should
for the
refer you
rule.
to the rule so you
and
could read it.
Non-discrimination law does not give you or HHS the authority to mandate this nationwide abortion and gender reassignment surgeries. And I yield back, Madam Chairman.
Ms. Manning, you're recognized for 5. Thank you, Mr. Secretary. Under Committee Rule 9, we will now question the witness under the 5-minute rule. I ask members to keep your questions succinct so the witness has time to answer. I recognize myself for 5 minutes of questioning. Mr. Secretary, this committee's efforts helped lead to the passage of the historic No Surprises Act. However, the law's independent dispute resolution process has been mired in litigation, delays, and faulty implementation. Data shows that 77% of disputes are ruled in favor of providers, and the Brookings Institute now anticipates that the IDR process will raise costs and premiums, contrary to the law's goals. What is HHS doing to improve the operations of the IDR process under No Surprises Act? And are you concerned that the law's current implementation will raise health care costs for employers and employees?
Madam Chair, thank you for the question, and you're right. Because there was a mad rush to try to make this independent dispute resolution process work, I think we saw that the gates got overcrowded, and as a result, we saw that there were delays. The arbitrators were wondering if they were going to get paid. There were a limited number of arbitrators. We think most of that has now sort of settled. We're now beginning to see that the cases that are coming through are eligible to be processed through this dispute resolution process. Initially, in that first year, we saw scores of these cases that were ineligible, and of course they took time. And since an arbitrator only gets paid for a case that's actually adjudicated and completed, arbitrators were getting very unhappy because they were having to adjudicate claims that didn't go anywhere.
But we're very concerned about the increased costs, so what are you going to do about that?
So by having been able to essentially scrub the system so that it now is much more efficient, so that the claims that come in will have an opportunity to go before an arbitrator, we're beginning to see them run a little faster. Because the courts have given us more guidance on how they wish to see us interpret the law, it should go faster as well.
Thank you. I'm concerned by regulatory overreach by HHS over self-insured health plans. The recent Notice of Benefit and Payment Parameters final rule and the Section 1557 Non-Discrimination in Health Programs and Activities final rule saddles self-insured health plans with new Obamacare regulations. Under current law, self-funded plans are not subject to Section 1557 or regulated by the Department of Labor. Will you confirm that it is HHS policy that self-insured health plans are not subject to HHS regulation, and will you commit to abandoning any unlawful HHS efforts to regulate self-insured health plans?
Madam Chair, let me make sure I give you accurate information because we have seen an evolution there. I don't want to give you an answer that's not complete, so if it's okay, let me follow up with you to give you the precise answer.
Okay, but we'd like that answer right away. No delays, please.
I commit to giving you that.
All right. I'd like to ask about parental rights in the Head Start program. The Head Start statute goes out of its way to describe parent and family engagement in Head Start services. In the department's recent Head Start workforce proposed rule, there's even language that claims to ensure, quote, programs are consulting and engaging with current parents and families to be involved in the methods the program uses, unquote. However, the proposed rule strikes from current regulations the requirement that parental consent be obtained for mental health consultation. What is the Office of Head Start trying to hide? Does HHS intend to complete mental health consultations on children without parental consent?
Madam Chair, there's nothing that's being hidden. What we're trying to make sure we do is provide the services that are important for any child in the Head Start program. We want to make sure that whether it is ensuring the physical safety of a child or also addressing any mental health concerns. We can try to follow up with you if you have particular concerns with some of the language, but I can guarantee that what's going on in this rule on Head Start, a proposed rule, is the best interest of the child.
Well, we will see, but we think that needs to be clarified and that you are not giving mental health consultations on children without parental consent. With that, I yield and I recognize Mr. Courtney for 5 minutes.
Thank you, Madam.
Are you familiar with the Biolab that was discovered in Reedley, California, that was set up with links to China?
I'm familiar with it.
This was discovered last year or maybe even sooner, and there were all kinds of pathogens there. It was actually set up by an international fugitive named Jesse Zhu, who's currently under federal indictment. Local officials found pathogens like E. coli, hepatitis B, hepatitis C, HIV, malaria, and others. And yet when local officials reached out to the CDC for help, they refused to provide it. This is from a report from the Select Committee on the Chinese Communist Party. It says, based on their initial observation in March 2023, local officials began to reach out to additional federal authorities for assistance. Local officials spent months repeatedly trying to obtain assistance from the CDC, but the CDC refused to speak with them. And on a number of occasions, it was reported by local officials that the CDC hung up on them mid-conversation. So why didn't the CDC come in and try to help when local officials discovered this situation?
I don't think that's an accurate representation of what CDC has done.
They did. You disagree with the committee's report?
I don't think it's an accurate description of what CDC has done.
I see. Did the CDC test the samples they found at the lab?
I'd have to get back to you on what the CDC precisely did.
Because according to the report here, the local officials asked them to test these samples, these dangerous pathogens, and they didn't do so. Does that sound inaccurate to you?
I think you're leaving out a good part of the story.
What part is that?
I'd have to get back to you because I don't have a direct understanding right now. Again, I came to testify on budget, but I can get back to you and let you know what CDC did or didn't do.
Do you have confidence right now that there aren't similar labs with links to the Chinese Communist Party in the United States?
Recognizing that these labs are licensed by the states, the 50 states, and not by the federal government, it'd be difficult for me to answer that question. The states don't work for me.
Well, I mean, but you do have responsibility for public health in this country. And so right now, as the Secretary of Health and Human Services, do you have confidence that there aren't similar illegal biolabs like the one that was discovered in Reedley throughout this country?
I don't know what every state has in its governance rules for the establishment of some of these labs. So if the question is, do I have confidence that all the states are doing the right thing, I'd have to say, probably not.
Mr. Secretary, the number of children who have come across our southern border on your watch and Joe Biden's watch is estimated at 481,535. Last year alone, it was 137,000. And if you compare that to the last year of President Trump's term, on his watch in the last year of his term, it was less than 25,000. So a pretty significant and dramatic increase of unaccompanied children coming across the southern border. The New York Times says that your department has lost contact with 85,000 minors, and that statistic is over a year old, so undoubtedly it has risen in the past year. Congressional Research Service says that 75 to 80% of unaccompanied children are now traveling with smugglers, and those smugglers have reportedly sold migrants into situations of forced labor or prostitution, forms of human trafficking, in order to recover their cost. The Coalition Against Trafficking in Women says that 60% of unaccompanied children caught by cartels and are exploited through child pornography and drug trafficking. And the New York Times has reported that almost 1 in 3 migrant women, including a large population of young girls, are reported to be sexually assaulted, over 1 in 3 of them coming across our southern border. Mr. Secretary, is it the policy of this administration to return children, unaccompanied children coming across the southern border back to their families where they came from, or is it to send them into the United States away from their families instead?
Congressman, let me address that question as it pertains to the Department of Health and Human Services, because we don't engage in immigration activities. We accept the children that the Department of Homeland Security has encountered.
Okay. Is it the policy of the Biden administration to return children back to their families or to send them into the United States to sponsors or to someone else, never to be seen from again? What's the policy?
The administration policy, and I'll try to speak for it generally because, again, it goes beyond my jurisdiction, but generally the policy is to abide by what the law says we must do. When someone requests an asylum hearing, by law, they're entitled to an asylum hearing. So let
me ask this a different way. If a 15-year-old girl came across the border from, say, Guatemala, would we send her back to her family in Guatemala, or would we keep her in the United States?
If she requested an asylum hearing, we would, by law, be required to offer her a hearing.
How many children have we returned back to their families in the country they came from? On your watch?
That would not be something I have information on because I at Health and Human Services,
thousands,
we don't
hundreds. Can you estimate?
I'm not going to speculate, but that's something that you can ask the Department of Homeland Security.
You and I both know the answer to that is zero. 0 children that you've returned back to the country. Let me ask you this. Hypothetically, if you and I have something in common, we both have girls. If my daughter or your daughter was smuggled to Guatemala, would we expect Guatemala to return our daughters back to us, our families in the United States of America, or would we expect them to keep them in Guatemala?
Again, you're asking me to speculate, but I will tell you, I would do anything I have to do to get my daughters back.
Yeah. So why isn't the Biden administration doing that?
Because we have to respect what the law says, and the law says you have to provide someone with an adjudication of their claim for asylum.
Well, the law says that because Joe Biden has made that the law.
No,
one of his first acts as president was to
that's inaccurate.
exempt unaccompanied minors under Title 42. He did that. You did that. You're responsible for that law, and you've never. By the way, have you ever come to this committee and asked us to change that law? Do you support changing that law to allow us to send those children back to their families in the country they came from?
The president has asked you all to change the law. There was a bipartisan bill to change the law.
I think I've only got a little bit of time left. I think the reason that you're doing this, Mr. Secretary, and your boss, Joe Biden, is because Democrats are getting rich off of it. The Global Refuge CEO, an NGO that you funnel a lot of money to, her salary is $520,000, and it doubled over 3 years. The former CEO of an NGO called Southwest Key Programs made $3.5 million. The new CEO makes $1 million. The CEO of Endeavors, who was an Obama administration aide, made $600,000 in 2022. A former Biden transition official who helped you vet political appointees helped Endeavors secure a $520 billion no-bid contract. These groups are making hundreds of millions of dollars, and now you are asking us to give you $9.3 billion to funnel to more of these NGOs so that your Democrat friends and donors can get even more rich. I think that's shameful, it's sickening, and I'm going to do everything I can to fight against it. Madam Chair, I yield back.
Mr. Burleson, you're recognized for 5 minutes.
Secretary Becerra, according to the Congressional Budget Office, they estimate that the ACA plans cost the taxpayers 3 times as much as an employer-sponsored plan. With that being said, is it beneficial or better that we would encourage more more policies to migrate towards an employer-sponsored plan as opposed to the ACA?
Congressman, remember, there's a difference between an employer-sponsored plan, an ACA plan, the Medicare program, Medicaid. All of them are different. The reason that there may be a greater cost in an ACA plan is because these are individuals that don't work for a large employer, can't take advantage of the large pool of employees that would be part of a system. The employer gets discounts because they're bringing a whole bunch of people into the system.
Wouldn't it be great if they get the discount, the taxpayers win, they win?
Yeah.
Is that not a good deal?
It would have been great, but remember, before the Affordable Care Act came into play, all these folks couldn't find insurance because the insurance carriers wouldn't offer them insurance.
Arguably, we had high-risk pools, and I don't want to get into that. That's pretty detailed stuff. But wouldn't it be great if we found a way to reduce the employer-sponsored plans by 29%? Then obviously more people could be able to afford to get access to health insurance.
Reducing the cost of health care would be a great
Especially
thing for any
in the
American.
private market, and then it would save the taxpayers even more, right? Because we're no longer paying for them to be on the ACA.
The more people are insured, the less it costs all of us.
So we have the association health plans, which was an innovative idea. They have a lot of the associations in America have had a longstanding interest in allowing themselves to combine lives to create those larger pools that you're talking about. And in 2018, the Department of Labor issued a final rule to expand access to these associated health plans, which actually did reduce the cost of insurance premiums by 29%. But just recently, the Department of Labor issued a final rule to rescind that 2018 rule. How do you think that that's going to have an impact on the costs and the access of affordable care for patients?
And recognize that the actions that you're speaking about were done by the Department of Labor, not by the Department of Health and Human Services. But what I can tell you about the various types of offerings, health insurance offerings that are out there, what you want to make sure is they all provide a core level of services, the basic level of essential services that anyone would want. Preventative care, for example, maternal health care, natal care. We want to make sure that you're providing the basic services. If you start to go outside of the Medicare program, Medicaid program, employer insurance, or the Affordable Care Act, you start to get into the weeds and the gray areas where these providers of these plans can avoid providing some of those basic services. That's the problem with some of these association-based plans.
No, I absolutely disagree. There's no difference between an associated-based plan. When they go out to bid for pricing,
I guarantee you there are big differences.
There's a difference because they're able to negotiate in bulk. I have a different line of questioning I want to get to before time expires. Last year, you testified before this committee, and I asked about the 85,000 unaccompanied alien children that your department was not able to regain contact with. You made repeated comments that the moment that you were able to place them with the vetted sponsor, you lose custody. But you do attempt to call them, correct?
Yes.
How many have you been able to contact?
Well, I would say that the majority we contact at some point, whether it's the child or the sponsor.
Do you have a number?
I could try to get you a number because, again, they don't have to. They're under no obligation to reach out to us.
You did prep for this, right? Like that last year, that was a course of dialogue questions that you got a lot of questions about, and so I assume that you were.
I prepped for budget questions.
Okay.
Budget questions.
Right. So you would say that this is a concerning. You would agree that it's concerning the number of children that we're not able to identify.
What I'm concerned is that members in Congress continue to ask me if I'm concerned. I would ask you, are you concerned enough to give us authority so we could actually track these kids? Because we don't have authority to track them.
Let me ask this question. When
it's
you're
a voluntary
placing
effort.
these children, do you ascertain whether or not the homes that they're being placed into, that they are able to actually work, that they're eligible to legally work in the United States? Is that one of the questions you ask?
Children should not be working. They should be going to school.
No, I'm asking because why would you place them in a home where no one can provide any kind of support?
You cannot become a sponsor if you indicate that you don't have the wherewithal to support the child.
And that means that they're able to legally work in the United States? Do you verify that?
We make sure that they have the income that would be needed to care for the child. That's
legally.
Part of the vetting process.
Legally.
You know, we are not INS, or we're not the Department of Homeland Security. Our job is to find someone who can care for this child.
Surely you could connect with them. My time has expired.
Thank you. Ms. Omar, you're recognized for 5 minutes. More thoroughly to the question.
Which question is that?
From Mr. Owens. I will make sure that question is clarified. Thank you.
Thank you.
Mr. Moran, you're recognized for 5 minutes.
Thank you, Chairwoman. Secretary Becerra, I want to talk to you about something that I think is very bipartisan. So let's take a deep breath. I know a lot of stuff that we talk about here today is partisan in nature, and frankly, a lot of it we disagree with. But I think there is something we can agree on, and that is we can agree on the protection of children from child abuse, and we can agree that we should not just prevent it, but we should protect those that are in those situations and get them out as soon as possible. Would you agree with that?
I would.
Yeah. Mr. Secretary, the Child Abuse Prevention and Treatment Act, also known as CAPTA, authorizes grants to states to assist communities to prevent child abuse and neglect. Your department is tasked with overseeing the implementation of CAPTA, as you're aware. I believe that, as I mentioned, everybody here should be on the same page with trying to prevent sexual abuse and the exploitation of children. It's awful and it should be stopped. I'm sure you agree with that, as you said, correct?
As I say, no child should be abused.
That's right. I'm sure you're also aware that a high percent of abusers are actually connected either by family or close friendships to those that they abuse. Are you aware of that as well?
I think you're accurate.
Yeah. The numbers that we see across the board is about 90% of those that are being abused by those that are closest to them, and that's just so despicable. In Texas, the average child spends about 7 hours a day in their school system. That means that most students are spending a good portion of their day, sometimes more with teachers and with staff and school personnel than they are with their family members at home. And that provides an opportunity for them to cry out when necessary. And that also provides an opportunity for those teachers and staff to recognize those students that are being abused throughout the day and then to help step in that moment. Would you also agree with that?
You said a lot. For the most part, I do believe that we have to make sure that we're providing ways for children to communicate that they're being abused or to be able to spot the abuse.
Yeah. In fact, school personnel are critical in helping to identify child abuse cases. I think they account for about 52% of all identified child abuse cases that are actually reported. With that in mind, I strongly believe that lots of child sexual abuse can be prevented or stopped through our educational institutions with enhanced prevention policies and enhanced opportunities for guidance in that area. Do you believe it's important for teachers, school employees, and other caregivers who work with children to be educated about the signs of children being sexually abused?
I know in some areas of the country they do receive some training, but certainly I think the more that our teachers and those who have who are surrounded by children most of the time should have some training.
Yeah, I agree. Do you think additional resources for teachers, school employees, and other caregivers would be helpful in these efforts for them to be able to identify and report so that we can combat sexual abuse?
I think most teachers would say that would be a good thing to provide the resources for them to be trained and have the resources to implement.
I completely agree with you. In fact, Representative Wild, who's a Democrat from Pennsylvania, and I are working on this exact issue. I've reintroduced what's called the Jenna Quinn Law of 2024, named after Jenna Quinn, a sexual abuse survivor from Texas. This bill would allow HHS to use existing federal funds to be used for eligible entities for increasing evidence-based or information training on sexual abuse prevention. It does exactly what you and I just agreed needs to actually happen is we need to open up additional resources, no additional cost to taxpayers, but more resources here where schools and institutions can tap into these existing resources and get education and training for their teachers so they can report these sexual abuses. Data has shown that after this law passed in Texas, and it's passed in a lot of states, educators reported abuse at almost 4 times the rate than before. Sounds like good progress in my state. Nearly every committee member on this committee in their own home state has enacted a version of this law, that their states have enacted that version. I think it's time that we have a national strategy to stop child sexual abuse, and I think the Jenna Quinn Law of 2024 would be a good way to do it. Hope you'll take a look at it. With that, I'm going to reserve and yield the remainder of my time to the gentleman from Utah, Mr. Owen.
Okay, thank you so much. I just wanted to tie down that last question I had for you.
Thank you, Mr. Chairman. Mr. Secretary,
It's good to see you. As you may know, I spent nearly 3 decades in healthcare as a therapist, rehabilitation services manager, and licensed nursing home administrator prior to being elected to Congress. I served patients from rural communities throughout central Pennsylvania during that time, and I learned the unique barriers these communities face in accessing quality, affordable health care. And while I appreciate your stated goals of expanding coverage and access to care that you detailed in your testimony, your agency's recently finalized rule establishing minimum staffing requirements for nursing homes seems to fly in the face of these goals. Ms. Secretary, do you believe that nursing homes across the country today have enough staff to meet their current needs?
Congressman, first, thank you for the work that you did in this space because it's essential for so many families. There's obviously something going on within the nursing home industry where, while they represent about less than about 1/3 of 1% of all Americans living in nursing homes, when COVID hit, we saw 20% of people dying living in nursing homes. That disparity shows that there's something going on.
Mr. Secretary, I will say that was because one of the huge contributing factors of that was bad policy by governors like my former governor, who required the readmission of nursing home residents diagnosed with COVID back into these populations. It was many of these people died as a result of bad public policy that was put forward. So, you know, I mean, but getting back to my original question, do you believe that that nursing homes across the country today have enough staff to meet their current needs? Yes or no?
I believe that too many of these long-term care facilities are not providing the staffing. In fact, the comments we received to our rule made it clear when people are talking about having 5 CNAs, certified nurse assistants, available for 55 residents. Clearly, that's not enough. When people are talking about a resident had a stroke and was on the floor for more than 15 minutes because it was breakfast time, not enough staff knew, and it wasn't until they were collecting the food trays that they discovered there was this person on the floor who had suffered from a stroke. Clearly, there are not sufficient numbers of qualified people.
Obviously, I keep close contact, obviously, having worked with older adults and specifically in many different capacities, including, I think, perhaps the only former licensed nursing home administrator between the House and the Senate. I may be wrong about that, but I think that may be accurate. It's certainly not what I've heard from nearly every provider in my district. So I would encourage you to engage with these providers more closely to learn about current conditions on the ground. Yeah, it's important for federal agencies to engage with local providers and stakeholders, and I would encourage you to do more of that certainly in the future. According to your department's own estimates, under the proposed staffing minimums, nursing homes around the country would need to hire nearly 13,000 registered nurses and 76,000 nursing assistants. That's actually where I started my career, working as a nursing assistant as I worked my way through my undergraduate degree. Can you certify here today that not one senior across the country will lose access to care as a result of this proposal?
Carson, what I can certify is that if one single American, your loved one, my loved one, is going to go into a nursing home, we're going to try to make sure that they are provided with safe, quality care because there will be the staff necessary to provide that care.
But in terms of access, having available facilities that are still open is an incredibly important part of that. Do you believe that nursing homes in rural areas that already face staffing shortages will be forced to close their doors or drastically reduce the number of seniors that they serve if this minimum staffing mandate takes effect?
The rule takes into consideration rural health facilities and nursing home facilities, as well as smaller nursing home facilities. We provide them with a longer transition time to adopt these new rules. We also provide them with a hardship exemption. They can show that it would be tough for them to meet the standards. They have more time. So we've listened to a lot of the facilities, and especially those in rural communities and those that are smaller.
So in terms of listening to them, how do you expect nursing homes to pay for the cost of implementing this rule, which your agency estimates will cost between $1.5 billion to $6.8 billion to fully implement?
Congressman, the way I ask the question is, what kind of operation do you have now if you're saying you don't have the people you need to take quality care, to provide quality care to the people who are your residents? Because what we're simply saying is you should have a minimum level. We're not telling them they have to hire more than that. We're just saying have a minimum level so you don't have the situation as occurred in Ohio where an individual who was in a nursing home was suffering from a wound because they didn't get wound care and diaper changes and feeding. Ultimately, that wound became a bed sore. That sore then became, got to the bone and ultimately to the
having
death.
worked many years in nursing homes, both as a delivering that care and as an administrator, I certainly understand that, but I also understand that when you're dictating and mandating from Washington without bringing the people to the table that provide the care, what you're doing is actually creating a decrease in access to care at a time when our population is aging. Thankfully, most people age with dignity and don't go into a nursing home.
Gentleman's time has expired and now recognized.
Capitalism is a superpower, and I want to thank you for that work. My time has expired, and I yield back, Madam Chair.
Thank you, Ms. Leisure-Fernandez. Mr. Bean, you're recognized for 5 minutes.
Thank you very much, Madam Chair. A very good afternoon, Mr. Secretary. Welcome back. I've got my very first question is something that unites us all. How about that? It also unites the American people because we're fired up. We're all fired up against people stealing our money. Medicaid and Medicare fraud. How much do we know how much is being stolen before our eyes, Mr. Secretary?
We don't have a precise number, but we know that there are folks who are always gaming the system.
It's a very big number. And how about this? I've got a report from the National Healthcare Anti-Fraud Association. There is such an association that does a little tracking. They say it's 100 billion. Does 100 billion sound about right, or is that just getting started?
You know, I've heard many numbers, but I wouldn't be surprised.
It's a big number. Mr. Secretary, the American people telling me we want our money back, and hopefully that we're going after it. The CNBC just did a little news story where they interviewed crooks that are stealing our money, and the crooks say, it's just so easy. It's unbelievable. I know that the administration is pursuing and persecuting people, some will say that haven't committed crimes at all, but what are we doing to go after bad guys that are stealing our money? Are we putting them in jail? Are we going after them?
We are. We have a team at HHS who does investigations. By the way, we are proposing $4 billion to help us do the investigations of fraud detection. For every dollar we invest, we return about $3 to $5 to the
Do we
taxpayer.
track that? We should put that on our website. This is how much money we've got back. Now, when you find somebody that's committed fraud, do we kick them out of the program and can we ban them for life? Do you do that, Mr. Secretary?
We try to remove those who have violated the law.
I hope we do, because we want our money back. There's an issue, you know this, the American people who have health insurance and are covered sometimes get surprised by medical billing. They think they either go in for a procedure or have an emergency procedure, and they get multiple bills, yet they had health insurance. Congress 2 years ago passed the No Surprises Act to say enough. The only surprise has been the implementation of your administration that's kind of fumbled the ball, or at least that's what doctors are telling me. They're telling me it's a big surprise that it's not done yet. Is this on your radar screen, Mr. Secretary, to fix this problem?
Absolutely, but everybody saw the new game in town and everybody tried to get in, and only certain ones were eligible, and so that's what caused some of the chaos.
I hope you'll consider that. I'm meeting with doctors, there's anesthesiologists, there's dermatologists, there's everybody in here and saying we can't get relief.
The good thing is the consumers are now out of that food fight.
Let's hope so. Let's hope so, but people aren't getting paid, and it's no fun to work for free, and that's what's happening. Mr. Secretary, Florida, and I represent the free state of Florida, Florida Department of Children and Families just put out a report this week citing disturbing findings, and that is that NGOs, non-governmental organizations operating under the guidance of the Office of Refugee Resettlement under your leadership are placing children in unsafe, unvetted settings, and even worse, are explicitly prohibited from reporting concerns to law enforcement. Are you aware of this report?
Actually, the state of Florida took the initiative to
remove the licensing requirement for these care centers, which doesn't make any sense.
Well, it doesn't make any sense that this report's come out. That's devastating. I know we've talked about the 85,000 kids that are missing that we can't find, that you've called. I know you're calling to try to locate them, but we're still putting them, according to this report, we're putting them in places that we don't know.
That's not accurate, but I understand what you're trying to say.
10-4. So you're aware of the report. And I know just earlier you talked about if a kid comes to our border and crosses line, and you gave the example a 15-year-old kid. 15-year-old kid wants a hearing. Then that 15-year-old kid is not sent back home. They're allowed to stay and given a hearing. What if that kid is 12 years old and says, I want a hearing? Would we do that for a 12-year-old?
If an individual crosses the border and says, I'm seeking asylum, by law...
Even 12. Okay, 9, 7. What age do we say, you know what, you belong with your parents? What age? You said a 12-year-old can do it. They can't get a tattoo in America because they're not old enough. But you're saying a 12-year-old can say, I'm leaving my family, and we keep them. So a 7-year-old, would you say a 7-year-old is enough to say, I want a hearing, and you would say, you need to stay. We're not going to put you back with our parents. Is that what you're saying, Mr. Secretary?
It's not what I say, Congressman. It's what you and Congress have said. And by statute, you say that if an individual requests
Mr. Secretary, I just think it's unacceptable as a parent that if
then you'll have
these
to change the
young
law.
kids are coming and we're not only are losing them, but we're not putting them back with the family.
You'll have to
Mr.
change the
Secretary,
law.
thanks for coming out today. And with that, Madam Chair, I yield back time.
Thank you, Mr. Bean. Ms. Houchin, you're recognized for 5 minutes.
Thank you, Madam Chair. Thank you, Mr. Secretary, for coming before us today. I'm going to pick right up where Mr. Bean left off because I, too, am a...
The gentleman from Utah, Mr. Owen.
Okay, thank you so much. I just wanted to tie down that last question I had for you. Are you saying then we're not going to punish the doctors that have religious freedom to say no to these operations? Is there any consequence to the institutions that are hiring these doctors? Yes or no?
Congressman, if you understand the way this works, an institution is seeking federal reimbursement dollars.
So that federal reimbursement will end if they do not.
Well, they accept the reimbursement dollars under certain conditions. They have to follow the rules of federal law.
And those rules will be their employees have to make sure they do these operations.
No, they have to make sure they're offering services. If they hold themselves out to be
let me just say this. Let me just finish up. I've taken a lot of time, but this one question I think is very stealth the way you guys are approaching this. You're not hurting the doctor, but you're hurting their employee, and that's what it comes to. You're taking away their funds.
No,
either way, the result is the same.
Congressman, it's been very direct, and again, people have conscious rights, religious rights.
But you're punishing the institution. I yield back. I think anyway. I yield back.
Mr. Scott, you're recognized for 5 minutes.
Thank you.
General Lady, her time has expired. I now recognize myself. Secretary Becerra, welcome back. As you may recall or may not recall, last time that you were before this committee, I asked you about HHS's vetting procedures in light of reports that unaccompanied children were being placed with sponsors who were exploiting these children. At that time, you stated that you believed sponsors were properly vetted by the HHS. In February, the HHS Office of Inspector General issued a report examining whether the Office of Refugee Resettlement took steps that were required to ensure the safe release of unaccompanied children through sponsor screening and follow-up calls. One of the findings from the report stated that the case files of 16% of unaccompanied children who were released to sponsors did not contain any documentation that a required safety check on the sponsor was conducted. Mr. Secretary, ORR received referrals for nearly 119,000, at least according to our records, of unaccompanied children in the fiscal year 23. That could mean over 19,000 children were released to sponsors without proper safety checks. Yes or no, do you still stand by your statement to me last year that HHS properly vetted sponsors?
I stand by my response, but Congressman, we need to clarify. You have mixed different numbers because the report that you reference, OIG, is from 2021, and now you mentioned 2023 numbers.
And what you have to remember is in 2021, in the spring of 2021, we were barely coming in. We were taking over a program that had essentially been dismantled by the previous administration. So it was difficult to have spots for these children, and it was difficult to have an operation to be able to send them to sponsors as we're required by law. Things are very different from that point in 2021 today.
Then let's talk about that.
Okay.
My notebook is over there. I'd debate you a little further. But let's not quibble on that. What changes have been made as a result of this audit? And secondly, what changes have been made in regards to release of unaccompanied children to individuals who have previously sponsored children?
We have continued over those 3 years to improve the services that are provided to children. I would refer you to our foundational rule, which just became final this year, which takes a lot of those best practices. So today, for example, we have enough space for the children that are coming to us from the Department of Homeland Security. We're no longer having to use convention centers to house these kids because we didn't have the infrastructure in place. We established the infrastructure, which is the most important thing, because now they're getting the health care they need, they're getting the services they need as we prepare to send them to a vetted sponsor. Secondly, we're trying to follow up with your help in getting the resources. We're able to do not just the referral to a sponsor, but hopefully if you give us the resources, we'll be able to do follow-up. We don't have authority to do follow-up, or we're not required to, but we believe it's a good idea to do it. If you give us the resources, we'll continue to do more follow-up with these kids.
If a child who was under the care of HSS, Unaccompanied Children program, is found to be a victim of human labor trafficking, is the sponsorship immediately terminated, and does the federal government reclaim custody of the child?
So you've touched on the issue, the difficulty. Once we find the sponsor and transfer the child to the sponsor, we no longer have jurisdiction, authority over that child. And so when you ask, will the sponsorship be terminated? We don't have the authorities to just terminate, because we don't have sight on what happens to the child once the child is in the sponsor's hand. You are welcome, and I've offered this before, Congress is welcome to give us more authority so we can follow the child.
Immediate action is taken. Immediate action is taken, though, once you find out there's a problem there.
Yes, if we're alerted, we will contact the appropriate authorities. But we don't have jurisdiction to try to stop that activity. Remember, if you're talking about a child being exploited in labor, they're already outside of our custody, because kids that are in our custody stay in our custody. They don't go out and work.
Are there circumstances under which the child will be returned to an immediate relative of the original sponsor?
I'm sorry.
Are there circumstances under which the child will be returned to an immediate relative of the original sponsor?
That is our priority, to make sure that we can place the child closest to whom they know. So a parent, if there's a parent available, an immediate relative, we seek to have them.
Is there a vetting process for them as well?
Yes, there is. No one gets to sponsor a child without going through a vetting process, even if they're the parents.
Well, we hope that continues, if that's the change that's been made.
Yes.
My time has expired. I yield back. Now I recognize the gentleman from California, Mr. Decano.
Thank you, Mr. Chairman. Mr. Secretary, welcome. Thank you for being here today. I'm thrilled to see that the Department of Health and Human Services recently finalized and released its regulations under Section 1557 of the Affordable Care Act, and many thanks to you and your team for your diligent work. Mr. Secretary, can you...
For coming out today, and with that, Madam Chair, I yield back time.
Thank you, Mr. Bean. Ms. Houchin, you're recognized for 5 minutes.
Thank you, Madam Chair. Thank you, Mr. Secretary, for coming before us today. I'm going to pick right up where Mr. Bean left off, because I, too, am a mom who is very, very concerned about the number of kids who've gone missing, unaccompanied minors who've gone missing under your watch. So you've said repeatedly...
Congresswoman, let me repeat again. No child has gone missing under our watch.
It's my time.
No child has gone missing under our watch, just to correct.
No children have gone missing on your watch?
Under our watch, no child has gone missing.
So you know where all of those 85,000 kids are?
Those children that are in our custody, we know where they are.
The ones that are in your custody. Okay, you keep repeating that. So
it's hard for me to track people I don't have custody over.
This is my time, Mr. Secretary. I'm looking at a report from Axios back in 2021, and this says, this is critical of the Trump administration. Roughly 1 in 3 calls made to release migrant kids and their sponsors went unanswered, raising questions about the government's ability to protect minors after they're released to family members or others in the U.S. Mark Greenberg, who oversaw the Unaccompanied Minors program during the Obama administration, was briefed on Axios's findings and says that's very dismaying. If large numbers of children and sponsors aren't being reached, that's a very big gap in efforts to help them. So under the Trump administration, Axios reported that there were 1,500 kids that he lost that could not be accounted for. 1,500 kids under the Trump administration. Under your administration, that number is close to 85,000. On March 1st, 2023, the Homeland Security Act of 2022 transferred responsibilities for the care and placement of unaccompanied children from the Commission of the Immigration and Naturalization Service to the Director of the Office of Refugee Resettlement. Who does the Office of Refugee Resettlement, who does that director report to?
Congresswoman, if you want us to have jurisdiction over these children, you can give us that authority by law. Right now, we don't have the authority to follow these children, and that's why it is inaccurate to say that we've lost any of them.
Let me just go on, because
I just wanted to correct the record because you have misstated what we do at ORR. I just wanted to correct the record, Congresswoman.
Please stop filibustering.
I understand, Congresswoman. I just want to correct the record of what you said.
Madam Chair. So, Office of Refugee Resettlement is under the Department of Homeland of HHS. That is your department. Since then, since March 1st of 2003, ORR has cared for thousands of children incorporating, quote, child welfare values. ORR takes into consideration the unique nature of each child's situation and incorporates child welfare principles when making placement, clinical, case management, and release decisions that are in the best interest of the child. Are 85,000 missing children, is that in their best interest?
Again, Congresswoman, you are mischaracterizing what's going on.
I don't believe I am, sir. I worked in child welfare, and what's happening to these kids...
Then if you think 85,000 children are missing, why haven't you tried to pass a law to make sure we can find them?
I
if you're so concerned...
I believe that what's happening is you're releasing them from your custody. That's what I believe is happening.
We're doing what the law requires,
Because if they're under ORR authority, then it is your responsibility to care for those children, and it is your responsibility to watch out for them. It absolutely is.
Okay, then you don't recognize and understand the law. The law does not give us the authority to do what you just said, Congresswoman.
According to the FBI, more than 98% of all children that go missing in the United States are found. However, less than 1% of all migrant children reported missing to HHS between October 2019 and April of 2023 have been found. This, I'd like to submit for the record, this is from the Center for Public Integrity, a spike in reports of missing and runaway migrant kids. Beginning in 2020 up to 2022, we see, if you can see, a huge spike in the number of reports of missing and runaway migrant children, again, under HHS authority. Only 1%
They are not
of
under
those
HHS authority, ma'am. I keep trying to clarify that for you.
Thank you, Madam Chair. So I am extremely frustrated as a mom, as a former child caseworker. Democrats were very critical of Donald Trump and his administration when there were 1,500 kids that fell into this category. Under this administration, there's an unbelievable number of 85,000 missing migrant children. I would encourage the department to not release these kids when they find placement and to keep track of them for their own personal safety. With that, I'd like to yield the remainder of my time to Representative Owens.
Thank you. Thank you so much. I just have to clarify a couple of things. The rules that we talked about earlier says that the gender identity and sexuality is protected under Title VI discrimination. I want to clarify. You mentioned that the doctors are not forced to, they're not punished. What about the institutions that hire these doctors? If the institutions that hire these doctors tied into your federal funds do not adhere to this discrimination that this rule is now tied to, are they taking away funds?
Congressman, I hope you understand the way the
it's a yes or no.
laws work.
I'm running out of time. Is it a yes or no? Are you punishing the institution?
We're not punishing, no.
So there's no punishment for breaking the rule of...
These institutions understand what they're supposed to do if they're going to take federal dollars.
Okay, so you're going to punish... You're taking away the dollars, right?
No, they decide that if they want to take a federal dollar, they must follow federal rules.
All right, so you're taking away their dollars. They're deciding, but you're putting that out if they do not...
Mr. Owens, we'll ask the Secretary to please respond more thoroughly to the question.
Which question is that?
From Mr. Owens. I will make sure that question is clarified. Thank you.
Thank you.
Mr. Moran, you're recognized for 5 minutes.
Thank you, Chairwoman. Secretary Becerra, I want to talk to you about something that I think is